hands-on in the medical school of Marrakesh. And more than 70 attendees were present with high level of exchange. Dear colleagues, I welcome you in Africa, in Morocco, and to Marrakesh, and I wish you a very productive meeting full of stimulating conversations and inspirations. Thank you very much.
Thank you. Thank you, Drisi. Next, we will take the welcome address from the President of the World Society for Pediatric and Congenital Heart Surgery, Dr. Zohair.
Bismillah ar-Rahman ar-Rahim. Good morning. Dear friends and dear colleagues, ladies and gentlemen, it's a great pleasure and honor to welcome you all to this 7th meeting of the World Society for Pediatric and Congenital Heart Surgery and the first meeting of the African Society for Pediatric and Congenital Heart Surgery. Having a meeting here in Marrakesh actually has been a dream not only for Dr. Boumzebra, but also for many members of the World Society, and particularly Dr. Jonas, who has been pushing for a meeting here for quite some time. And here we are, after so many delays and after the corona pandemic, here in Marrakesh, this lovely city, having this meeting that we hope to be educational and also of social exchange for all of you attendees. Our thanks actually go to our host, Dr. Boumzebra, and his team who worked really effortlessly to make this happen. And our also thanks go to the World Society staff, organizing committee and scientific committee, who also helped to put together the program for this historic meeting. Our thanks also go to the local company who organized the meeting in this lovely venue. Also go to the sponsors whom without support with this could not have been happening. And of course to your audience being here in support of this meeting. I thank everybody, and I hope that we all enjoy this meeting in the scientific program and also enjoy this historic city of Marrakesh. Thank you very much and welcome.
It's now my pleasure to introduce the first president of the African Society for Pediatric and Congenital Heart Surgery and a close friend, Frank Edwin.
Thank you very much, and a very good morning to you all. On behalf of the African Society for Pediatric and Congenital Heart Surgery, I welcome you to this historic meeting, which is the first of its kind on African soil. I thought I should tell you a little bit about the man to whom this joint meeting is dedicated. You will find his picture on page 5 of your conference booklet. So that is Rob Kingsley. He's from South Africa. I've known him since 2008, but I first saw him during the historic inaugural meeting of the Society, which was held in Washington in 2007. And since then, he has been a role model a mentor, and a teacher to me and several of the African surgeons gathered here today. At a conference in 1976, Professor John Barlow, for whom Barlow syndrome is named, described Rob as the rising star in the cardiac firmament. That's not surprising if you consider the prizes that he won in his undergraduate and postgraduate training years. So in 1963, he was the best student in medicine. Then he won the Glaxo Prize for Surgeons in Training in 1967. Then he won the Jamie Miller Prize in 1968. Went on to win the Cecil John Adams Traveling Fellowship in 1972. So you wouldn't be surprised if he was described like that. Now, in 2010, in acknowledgement of his contribution to the University of Witwatersrand and the esteem of his peers, this portrait of Rob was commissioned and hung in the Hall of Fame in the Department of Surgery at Wits University in South Africa. In 2011, he received a medal at the World Society meeting held in Istanbul when he delivered the Aldo Castaneda lecture, which he titled The Neglect of Infant and Pediatric Cardiac Disease in Africa. Rob has trained more than 30 cardiothoracic surgeons, but was ever mindful of the man who had molded him, including Dr. Dwight Magoon, under whom Rob trained at the Mayo Clinic. I heard quite a bit about him when I was there with Rob. Now, in 2003, Rob founded the Walter Sisulu Pediatric Cardiac Center for Africa, which was commissioned by Nelson Mandela, with President Clinton in attendance. The idea was to use philanthropy to fund operations on patients from Africa who lacked access to cardiac surgery, and also to train surgeons from Africa who would return to their countries and develop their own units. Here are 3 of such surgeons that Rob trained. You can recognize maybe 2 people in there. The third person is not able to be here. He's caught up with some duties in Accra, Ghana. So these 3 people are from West Africa, Ghana, 3 of the people Rob trained. In addition, he also trained nurses from my unit. There were 7 of them, ICU and oral nurses, to help us start our pediatric program in Accra, Ghana. A big part of Rob's contribution to our specialty in Africa is the annual scientific meetings he organized and the published works that originated from them as a result. The meetings were legendary for the international faculty he brought and the financial and logistic assistance he provided to facilitate the attendance of African surgeons. And here, Dr. Jonas was one of the first people I met when I was working with Rob in 2010 in Johannesburg. Rick Oye was there. The first time I think he was in 2008, and then he came again in 2017 when this picture was taken. One of the people who was with us there, Dr. Schreiber of blessed memory, Rob actually sent me to work with him in Munich in 2010, just to gain some experience with what other people were doing. These are some participants from Ghana and Nigeria at one of Rob's annual meetings. So although Rob Kingsley is unable to be here for this historic meeting, but for the lives his surgeries have saved and the lives he has changed, the surgeons he has taught, and for his extraordinary contribution to pediatric and congenital heart surgery in Africa, we of the African and World Societies believe this meeting, the first of such meeting on African soil, is rightly dedicated to him. And with that, I welcome you all. Thank you.
Thank you, Frank. May I introduce the Executive Director of the World Society of Pediatric Congenital Heart Surgery and a friend of the local committee, because we have been working for months to put everything, set everything for the World Society meeting in Marrakesh. Dr. Christo, welcome to Marrakesh.
Bismillah, assalamu alaikum. Marhaban bikum fi Marrakech. Bienvenue à Marrakech, on est dans la partie française de l'Afrique. So welcome to Marrakesh. This is a really, truly historic meeting. A few years ago, at the meeting that Jeff Jacobs organized in Orlando, Florida, at the end of the meeting, we went for dinner with Frank Edwin, Anti-Infant Etiuma, and Darshan Reddy, my African friends, and we said, how come there's no organization for pediatric congenital heart surgery in Africa? And just prior to that, we had chatted a little bit with the World Society president at the time, Marcello Giattini, and just like that, we said, there has to be an organization that is established. And here we are 4 years later. This is a truly historic meeting. I think the World Society, one of its roles is to generate interest in all parts of the world in the treatment of babies and children and adults with congenital heart disease. Every continent has a continental organization. North America has the Congenital Heart Surgeon Society. Europe has the European Congenital Heart Surgeon Association, the Sociedad Latina for Latin America. There's a newly established Asian Association of Pediatric Congenital Heart Surgery, and now we have the African Society. So this is a truly historic meeting now. Those that know me, I come from Montreal, Canada. That's where I've lived for the last 55 years of my life. So I'm Canadian and North American. But I was also born in Europe, in Eastern Europe, in Bulgaria. But what many people don't know that I have actually lived on 3 continents. I have lived 2 years of my life on the continent of Africa, not far from here, in Algiers, Algeria, from 1966 to 1968, and that's where I learned French, and we settled in French Canada. So for me, it's really, I'm a little bit emotional to be on African soil 45 years later in North Africa. I've been to Morocco once in 1967, driving from Algeria to Spain with my parents, and never forget the night we slept in Fes, the imperial city. So this is a homecoming for me in some ways. This is a truly historic meeting, and I wish you all the best. I hope we'll have good science and good friendship, and we will build a strong foundation for the future. So have a great meeting. Thank you very much.
Okay. Thank you very much, Christo. We're going to roll into our first postgraduate session today, focused on tetralogy of Fallot. Our first speaker is Dr. Craig Sable from Washington, D.C. Unfortunately, Dr. Sable couldn't make it, and we've got it set up so that he can present his presentation virtually.
You can speak with them.
Dr. Sable?
I'm here, yes.
You're on, sir.
Good morning. All right. Well, I wish I could all be with you in person this morning, but I'm glad to at least be able to join remotely. You're going to have to let me share my screen. It says it's disabled right now.
You have to allow him to share a screen. Great, we see the slides.
Perfect. All right. Well, this morning I'm going to talk about echocardiography and advanced imaging for tetralogy of Fallot. Before I start, having been fortunate enough to visit Marrakesh at least a dozen times, I would strongly encourage you all to try all of the many wonderful foods. My favorite is pastilla, and there are 3 very different ones. And I would strongly encourage you to try all of them. Well, I'm going to start by talking about the basic echo principles for preoperative echocardiography assessment. The view on the right is something we call a tetralogy view. It's a subcostal view that is a view that's the right axial oblique equivalent in the cath lab, which shows the RVOT profiled very nicely in this patient with very tight infundibular stenosis. So when we're looking at the RV outflow tract, we examine the subvalvular anatomy. We want to look at define it, whether it's discrete or long segment narrowing, looking at the os infundibulum, and distinguishing between TOF variants and a double chambered right ventricle where there's more discrete os infundibular narrowing proximally with no override. We want to look at the pulmonary valve morphology and Z-scores. There are many different Z-scores out there, and sometimes they're more confusing than helpful, giving the variability, but they're important to use. And then, of course, we want to look at the main pulmonary artery, pulmonary branches, and do a Doppler of the RVOT. The parasternal short axis here shows the aortic valve that's about twice as big as the pulmonary valve. Note here the thymus, while not always accurate, the presence of the thymus decreases the likelihood of DeGeorge or 22q11 deletion. And then tipping up, you can see the pulmonary arteries here, and you want to, obviously defining the pulmonary branches is important. The Doppler can also be informative. This is an RV alpha talk Doppler that has a very full Doppler with a high gradient. The gradient itself, is less critical than the character of the gradient. This is a full gradient indicative of more fixed obstruction, and this has a very dynamic pattern. Paradoxically, some of the most severe patients have no gradient because of limited flow. This is another patient with similar views from short axis and the subcostal view. And in this case, there is subvalvular narrowing, but not nearly as bad as the other patient. This patient's Z-score is still probably less than -2 and would be at best on the cusp for a non-transannular patch repair. Looking at the ventricular septal defect is also critical, and this can be done both by transthoracic and preoperative transesophageal as shown on the right. We want to look at the number of VSDs, especially important to try to rule out additional defects that could be unmasked when a repair happens. The location, although conoventricular is the most common, conoseptal or doubly committed subarterial or supracrystal also exists in the setting of tetralogy. We want to look at the relationship between the aortic mitral and especially tricuspid valves when there's significant override in the direction of flow. We also want to look at the right ventricle itself. There are additional findings that are important. The presence of an atrial septal defect, especially when doing neonatal repairs, may be important in some practices, and a decision whether or not to make an ASD or leave an ASD is an important discussion to have. The venous anatomy, and then in tetralogy, the most concerning coronary artery pattern to look for is if there's a coronary artery crossing anterior to the RVOT as shown here. When this is present, this could indicate a very prominent conal branch, dual LADs, or an LAD from the right coronary artery, which in the setting of severe pulmonary or significant pulmonary valve hypoplasia may impact the surgical plan of care. It is normal to have somewhat clockwise rotation of the origins as well. We want to look at arch-sidedness, especially in the setting of a right arch. 22q11 is more common. The presence of a patent ductus, and especially collaterals, although these are associated with more severe obstruction, they can be present and can also impact surgical management. And then we want to look very carefully for if there's a patent ductus present, and as I'll show you in a minute, the concern about proximal left pulmonary artery branch stenosis. Well, I've had the good fortune to spend a lot of time in my life in Morocco and in low-income countries such as Uganda. And this finding on the left is far too common, where we have a lot of older patients with severe RV outflow tract obstruction. And in my experience, in the older tetralogies, probably in some part because of just natural selection, these patients often have very severe subvalvular narrowing with reasonable formed RV outflows. And then this is a case that is becoming more frequent in our practice as we are doing palliation, especially for babies that are premature with stents. And this patient has a ductal stent, and whether it's a ductal stent or a ductus itself on prostaglandins, it's important and sometimes very challenging to assess the proximal LPA, where there may be significant stenosis where the duct enters, but the duct itself may mask that finding. And then we want to look for associated defects. This is an example of a tetralogy of Fallot AV septal defect. The RV outflow tract anatomy here has severe stenosis, and this patient has a Rastelli type C common AV valve with a complete AV septal defect. This is a case of tetralogy with absent pulmonary valve, where there's very large pulmonary branches, a very small pulmonary annulus with essentially minimal valve tissue, and to and fro flow across the RV outflow tract. And the subcostal views are very interesting in that you see these two large structures here. And at first glance, you may be fooled that this is the left atrium, but these are the pulmonary arteries behind the heart. And this subcostal short axis view shows the anatomy very nicely with the subvalvular narrowing, the remnant of pulmonary valve tissue, and the dilated pulmonary branches. Well, the intraoperative and early postoperative assessment of tetralogy is very much done by echo. And this is a postoperative TEE, which shows a very nice RV outflow tract repair with unguarded pulmonary insufficiency and a very tiny residual VSD. So we want to look for residual VSDs. Even a small VSD in tetralogy with an excellent RV outflow tract repair can result in a significant increase in left to right shunting. So it's always important to assess whether that residual shunt is hemodynamically important. And because we're looking at lower RV pressures in the post-op setting, you could unmask additional VSDs. We want to look for residual right ventricular outflow tract obstruction and insufficiency, atrial shunting, the presence of aortic or tricuspid valve insufficiency, and try to assess the right ventricular pressure, residual ductuses and collaterals, and restrictive physiology. And I'll show you examples of some of these. So here's a patient that has what on anatomy may look like significant residual RVOT obstruction. This is a postoperative TE. Keep in mind, this is a three-dimensional structure, and in reality, this is likely dysdynamic. The peak gradient across the RVOT was mild at worst, and we would consider this an excellent finding. And I think Dr. Jonas, who is in the audience, we've talked quite a bit about the importance of not trying to go back and make this look better aesthetically when hemodynamically it's totally acceptable. This is a TE view showing a right to left atrial shunt, and it's important to know when this exists for postoperative management, and we can confirm this by injecting saline through an RA line or a central line and seeing right to left shunting. It may reset what your oxygen saturations will be. Let me go back and just show you one more finding. If you look at this RV outflow tract, there's a mild gradient across the RVOT and systole, and then there's forward flow and diastole, so-called restrictive physiology, and this is a common finding. And this is why having a right to left shunt may be helpful in managing a postoperative patient. So in the long term, we're going to assess residual defects, the right ventricle for size, function, pressure, and restrictive physiology, and we have many advanced imaging settings. In reality, even though I'm an echo doctor, much of this lies in cross-sectional imaging, and I'm very fortunate to have a wonderful team of cross-sectional imagers who continue to innovate. And using MRI has been the gold standard for assessment of the right ventricle, branch pulmonary arteries, and pulmonary valve regurgitation. And the complete assessment includes standard imaging and additional case-specific comprehensive imaging, including late gadolinium enhancement. And I'm going to show you a few examples. This is a cine assessment of the RVOT in a patient on the left that has unguarded pulmonary insufficiency, and MR can exquisitely define the RV volume and the RV regurgitation fraction along with the RV ejection fraction and LV size, which all are important parameters in deciding the timing and indications for pulmonary valve replacement, and also assess whether a patient may be a candidate for transcatheter replacement. There's also a lot of enhanced 3D anatomy with and without contrast. This is a contrast enhanced MRA on the left, and this is a 3D steady state free precession image on the right. And in addition to the cines, these can give you quite a bit of anatomic and flow information. And then CT and MRI can also be helpful with the anatomy. And more we're using CT and MRI to complement echo. You can look at the outflow tract morphology to assess for a percutaneous pulmonary valve and the presence of pulmonary artery stenosis, hypoplasia, interruption, along with arch anatomy and coronary artery findings, and you can make really nice 3D reconstructions. Cardiac CT can also be important to help define the anatomy more than the physiology. These two sites show patients with good sized pulmonary arteries and then pulmonary artery branch stenosis. And we're now using CT 100% of the time before considering ductal stents. And then it can also be very helpful in a case of pulmonary atresia MAPCAs. And then in these two examples, looking at TED absent valve. If you take this, we can do a 3D reconstruction and exquisitely define the MAPCAs in relationship to the arch and airways and trying to define the true PAs. And then there's a lot of advanced techniques that we're now using to assess RV function. This is something called feature tracking that we're doing in our lab to quantify RV and LV wall motion and measure septal displacement. And this is felt to be a biomarker of interventricular interaction in which RV volume afterload affects LV strain. And when there's abnormal septal displacement, the RV pulls the septum, which can be a concern for poor hemodynamics. And this is just an example of that, looking at a patient with normal septal displacement and one with tetralogy of Fallot. We can also quantitate flows, and this is how we measure regurgitation fraction by looking at phase contrast imaging and flow volume across different structures. And this can help us look for regurgitation fractions, differential flows to both lungs, and the presence of residual shunts. And then Tom Loke in our lab is doing a lot of really cool translational science. This is a few slides from his papers looking at computational modeling and fluid dynamic research in congenital heart disease. And he looks at vortices and energy loss correlating with RV dysfunction and exercise tolerance, and trying to model some of these flows in the vortices in the heart can again take us beyond what our existing model is in terms of simply looking at ejection fraction and regurgitation fraction. And then there are two really good guidelines, one from the American Society of Echo and one from American Heart Association, and they use this same table about timing of when we're doing imaging. And for sure, we're doing echoes every 12 months in the first 10 years of life and every 24 months later. And the recommendation is to do in adolescents and adults MRIs every 3 years if stable, and more frequently if not, and then looking at other imaging modalities as well. And these can easily be found online. So I want to thank you very much. I have very warm feelings for Dr. Boumzibra and the team in Marrakesh, and I wish you a wonderful conference. And again, I wish I could be there in person with you all. Thank you.
Thank you, Craig. That was a great presentation. I think what we'll do is open the floor up to questions since we'll have some time during this session. I have a question to get us started. You alluded to a little bit the immediate postoperative period and the residual right ventricular outflow tract obstruction, Craig. You know, often we come off bypass, you have a hyperdynamic ventricle, you've done an extensive infundibular resection, your cardiologist is telling you there's a gradient of 25 to 30 across it. You believe you've done a good resection, but again, we do these resections with the heart paralyzed. What are your recommendations to your surgeons if there's a gradient that's you know, mild, but they're telling you they think they've got it all?
Give protamine. I think I think it's very important to not overdo it because there's going to be a mild gradient. I think at 20 to 20. I meant to show that image as an example of what I would consider to be an excellent repair and something that will probably get better over time with remodeling. I think if there's really a concern, you can always try to do a needle measure of the right ventricular pressure, but TE should complement the overall assessment of the patient. If the patient's doing well and there's a mild gradient, then I would be very cautious to go back and keep resecting more proximally because I agree that it's not a significant gradient and it's likely to be expected.
And then maybe you could expand a little bit on the role of epicardial echo in the operating room, and maybe specifically not for tetralogy, maybe for the branch PAs, but how do you use in your institution epicardial echo?
We do use it quite a bit as a complement to transesophageal echo. We have a micro TE probe that goes down to about 2.5 kilos, but the image quality is not as good as the pediatric probe. And epicardial echo is especially helpful for PA branches and coronary imaging. And we also find that there is both Philips and GE, not to endorse any one company, they're the two vendors, at least in the US, with the biggest market share. They both have hockey stick shaped, very high frequency vascular probes. And we find for coronary arteries and for PA branches, they can give you exquisite imaging to complement using the regular 12 megahertz probe. And I'm happy to share links with the audience to those probes. But interestingly, there's, I think, only one paper ever published on epicardial imaging, but we use it a lot in the operating room now.
Thank you. Additional questions, Christo?
So when I train, this is a question from Craig and also some of the surgeons, just to keep in mind, maybe that's a discussion we can have at other sessions on tetralogy. When I trained with Aldo Castaneda, Richard Jonas, and John Meyer, I remember Aldo saying, make sure you leave no obstruction. So we used to make quite significant transannular patches. And then over time, we found out that chronic pulmonary insufficiency long-term becomes a problem. So they began a trend towards valve-sparing surgery. So now perhaps the pendulum has gone too far because in the last 10 years, I see a few cases in my practice where I saved the valve, but then a few months later, a couple of years later, I had to go back in and do a transannular patch. So my question is, as an echocardiographer and perhaps to some of the surgeons, at the end of a valve-sparing tetralogy repair, at what point of a gradient and what other characteristics tell the cardiologist doing the echo to tell the surgeon, listen, you did your best, but this valve is really is going to be a problem in terms of obstruction. Go back and do a transannular patch.
I think from the echo standpoint, we should be able to distinguish subvalvar from annular stenosis. And so I think it is an important question that the surgical team and the echo team need to work together to answer. So it's not only the quantity of the gradient, but it is the location and characteristic of the residual obstruction that may impact whether or not to go back or to do a transannular patch. And then again, as I said before, I think that if there's a question, it's all, even though it's very fluid, it's always reasonable to consider doing a needle measure of the RV pressure and compare it to the LV or aortic pressure.
This is fantastic. Frank, maybe you can comment of what your resources are in the immediate post-op period and your echo resources that you have at your institution.
Yeah, and I think sorry, go ahead.
Yeah, thank you. So the challenge we have really is patients coming back for follow-up. Communication, transportation in many of our countries in Africa, not great. And most patients don't have the money to make that journey. So a lot of the time, what you find is that the patient never comes to you until he has a problem. So sometimes we are not sure. You haven't seen the patient. Is it that he's dead? Or is it that he's so well that he doesn't need a doctor? When they finally come and they have a problem, they usually have a big problem, because the problem is not just a decision on are you going back to surgery. Often the problem is if you make the decision you are going back, how are they going to be able to afford the reoperation? And that is a real challenge. In terms of being able to echo them, there are not many centers in my country, at least, where you can get a good post-op echo. Certainly, unless you come to the National Cardiothoracic Center in Accra, which is the only facility in the country, I don't suppose there are many places in the country where you can get a very good evaluation in terms of, is this a good repair or that kind of thing. So almost invariably, the patients have to come to one particular place to be able to make that assessment. I was just wondering, Dr. Sable, if you can comment a bit on your approach to imaging patients where you do an echo and you can't see the LPA. You've gone ahead to do a CT. I've had this a couple of times where you've done a CT, you still can't see the LPA at all, and the surgeon is wondering, is this just a tight origin stenosis or is it just an absent LPA completely? How do you approach imaging such a patient?
And I think sometimes the only thing, you have to go to the gold standard test, which maybe is CT, maybe is cardiac cath. When we start by echo, we want to try to look for the presence of collaterals, look for runoff in the descending aorta. But if you can't answer the question, then I think a cardiac cath may be the only way to get to that answer. And I think it is of critical importance to answer the question. Conversely, if there is flow, but you can't determine if there's stenosis where the ductus inserts, then that is something that can probably be figured out in the operating room. And just getting back to your last comment, having been to Uganda about 40 times in my life, we have similar experience where we have good echo in the capital and a few other large metropolitan centers, but it is a challenge to do follow-up. And I think there are some new approaches with telemedicine and some of the smaller handheld echo devices to try to expand the reach. But I agree that it's a challenge in low-income countries and to do chronic follow-up.
Greg, Andrisi, I want to have your opinion whether at the end of the tetralogy follow repair, if we rely on the gradients by TEE or RV over LV pressure. What is the best possibility? And this question is open for discussion on floor.
And from our standpoint, you have to use all the data in front of you and look at it over time, because one instant may not give you what you need the most. And the direct pressure measurement should be very accurate, but if it's dynamic and you don't know exactly where your needle is sometimes, but I think it's a matter of looking at all the data and then given the changes in the operating room in the early postoperative period, you also want to be very mindful to look at how the patient's doing, what rhythm the patient's in, what the systolic blood pressure is, what inotropic support the patient's on, because all of those data together contribute to answering the question, do we need to go back on bypass?
Any additional questions? Okay, we'll move to the next speaker. Oh, I'm sorry, there's a question. Please go to the microphone. One additional question. Can you identify yourself too and where you're from?
Good morning. My name is Valdan Manuel. I'm from Angola, Rwanda. Attending the fact that in the developing world there is many difficulties with the facilities, I want to hear from you your opinion about the use of speckle tracking and follow-up of patients in post-operative of the tetralogy follow. Thank you.
I think you have to rely on whatever resources you have available. Speckle tracking, both by echo and by MRI, can give you a ideal assessment for regional wall function, which may help in more clear terms define the long-term assessment of the impact of pulmonary valve regurgitation on the right ventricle. But I think some of this is still a research question, and it's not clearly known exactly how that impacts the timing. So again, it's probably more critical to know about more severe disease by basic assessment, but I do think speckle tracking and some of the newer echo machines is readily available, but I don't know if we completely know how to use that data to make optimal clinical decisions.
All right, thank you very much.
All right, thank you. So we'll take the next presentation from Alexis Palacio Macedo. He's going to talk to us on the effects of high altitude on tetralogy of Fallot physiology and late presentation. Alexis.
Thank you very much. I would like to thank the Society for the invitation to participate in this fantastic meeting. It's an honor for me to be here to talk to you about the effects of high altitude and late presentation on tetralogy of Fallot physiology. In mountain medicine, high altitude has been defined as that between 1,500 and 3,500 meters above sea level. Very high altitude, between 35 and 55 meters above sea level, and extreme altitude above 5,500 meters above sea level. However, for some reason, it has been common practice to talk about high altitude above 2,500 meters above sea level, probably because it is thought that the syndromes, the mountain syndromes, rarely appear under these levels. However, when reviewing the literature related to physiology in high altitude, two things need to be considered. One, that the conclusions obtained from data in the literature are usually used indistinctly for high altitude, regardless of it being high altitude, very high altitude, or extreme altitude. And second, while most information from high altitude has been obtained above 3,000 meters, most centers performing cardiac surgery at high altitude actually are located under 3,000 meters. And in fact, there is some evidence in the literature that there is indeed a significant physiological change only above 3,000 meters. Acute mountain sickness is related to hypoxia, and subacute and chronic mountain sickness are related to increased PVR induced by hypoxia. And it has been around these syndromes that most of the research related to high altitude has been done. But there has been some vagueness in the literature regarding the altitude at which they appear. For example, in this extensive review, we can read that the mean prevalence rate for chronic mountain syndrome is 5 to 10% among the global population who reside at altitudes higher than 2,500 meters, and that consequently up to 14 million individuals worldwide might have chronic mountain syndrome. This is pretty scary, particularly for those of us who live and work at these altitudes. However, what we can, if we go to the reference, if we go to the reference that is mentioned in this article, what we can read only is that establishing better definitions of high altitude related illness is important for the millions of people who live above 2,500 meters, and it is estimated that up to 5 to 10% of high altitude inhabitants may develop chronic mountain syndromes or high altitude pulmonary hypertension, but with no reference to it. And that chronic mountain syndrome is a clinical syndrome that occurs to natives or long life residents above 2,500 meters, but again with no reference. So really the limit of 2,500 meters seems to have been spread by word of mouth, but with no scientific data. What in fact has been demonstrated to happen at high altitude is related to much higher altitudes. For example, it has been shown that in children and adolescents, there is indeed a significant increase in pulmonary artery pressure after rapid ascension close to 3,500 meters. And in his pioneer work in the early 60s, Peñalosa in Peru informed about pulmonary hypertension in subjects living at 4,540 meters above sea levels. And in a more recent review, the same author mentions, after an analysis of several publications, that in healthy subjects, pulmonary pressure is significantly elevated above 3,000 meters, but that in cities located under 3,000 meters, like Mexico City, Xining, and Bogota, and of course Denver, which is located in a much lower location, pulmonary pressure have been shown to be within the normal limits, and therefore probably PVR is also normal at these altitudes. These data are sustained by animal studies that have shown that hypoxic pulmonary vasoconstriction is triggered only when alveolar partial oxygen pressure decreases under 50 to 60 millimeters of mercury, and that these low pressure are indeed reached only around approximately 3,000 meters above sea level. But apparently all this dispersed data has not been analyzed globally, and my personal impression working in a high, in a center located at high altitude is that the effects of high altitude have been emphasized, probably to explain at some point some suboptimal results that can rather be explained by other multiple factors. In 2019, we published our results on 39 patients operated with a non-fenestrated fontan in Mexico City, with 28 patients, that is 72% of the patients, operated at 2,691 meters above sea level, and the rest at 2,312 meters above sea level. All patients had normal PVR despite these altitudes, with low preoperative PA pressures too. Also low postoperative PA pressures, and a high rate of extubation in the OR and low mortality, that is with overall results similar to non-fenestrated fontan performed at sea level. And more recently also, we published our experience with early extubation in a pediatric center, in our center at high altitude, with all type of procedures with a global extubation rate for the whole population of 81%. Now, the second relevant variable at high altitude is hemoglobin saturation. And as it is shown in this table, from measurements done at different altitudes, its impact is in saturation is relatively minor. Only above 4,000 meters above sea level does it come below 90%. And this translates also to a minor impact in hematocrit, as is shown in these tables from a study done at different altitudes in Colombia. At 2,600 meters in young women, it is 43%, and in men, 49%. So this low impact of certain levels of high altitude in saturation in PDR and hematocrit can be explained by the hemoglobin saturation curve that shows how saturation and oxygenation is kept almost at normal level up till the alveolar oxygen partial pressure is close to 60 millimeters of mercury. What we do observe, though, is temporary desaturation after cardiac surgery for a few days, probably related to lung edema that is transitory and reverts after a few days with minor clinical significance. So how this translates particularly to patients undergoing repair of tetralogy of Fallot at high altitude? Well, when doing research in PubMed, not a single article has been published analyzing this relation. But many centers at high altitude, like ours, are located in low and middle income countries where late diagnosis and referral are still common. We'll still need, therefore, to perform frequently surgery in older patients, including adults, with several challenges, of course. One of them, long-standing hypoxemia secondary to progressive pulmonary artery stenosis, but not to high altitude really, leads to an increase in erythropoiesis, initially in a compensated way. But when saturations fall under 75%, there's several physiologic phenomena that lead to preoperative events, or to the possibility of preoperative thrombotic events, and in the postoperative period to increased risk of bleeding. And then restrictive physiology, which is defined as the presence of telediastolic RV forward flow that has been related to several factors, but mainly to low persistent preoperative saturation and RV hypertrophy, and which is associated with longer ICU stay, increased need of inotropes, and increased pleural effusions and ascites. Tetralogy of Fallot patients were shown to have, in the mid-80s, when repairs were still performed later in life, significant worse ventricular function during the first 24 hours compared to other repairs in congenital heart surgery. Although poor compliance, residual RVOT stenosis, pulmonary insufficiency, tricuspid insufficiency might explain most of this, there is some evidence that chronic hypoxia has a main role in this. So in experimental models using dogs, chronic cyanosis has been shown to predispose to myocardial depletion of energy substrates, stores, and also in biopsies of patients with tetralogy of Fallot, there has been shown to be a significant decrease compared with non-cyanotic patients of antioxidant enzymes. So we can say that part of the greater vulnerability of hearts of older patients that undergo tetralogy of Fallot repair might be related to hyperoxemia at the start of bypass in a heart with already depleted antioxidants and diminished energy stores. Of course, we have other concerns for patients that are operated late, like endocarditis and brain abscesses, pulmonary branch distortion due to long-standing VT shunts, and a higher incidence of aortic insufficiency, but this doesn't have any relation to high altitude. So finally, an analysis of our data shows that our center in Mexico City, although we have been able to slowly increase the number of early referrals, in the last 10 years, still 21% of tetralogy, only 21% of patients with tetralogy of Fallot have been done during the first year of age, with results that show a mortality of 5.7%, of course, higher than expected in high-income countries, but around the numbers usually seen in low and middle-income countries, with approximately 50% of patients needing a transannular patch, and again, early extubation in 63% of patients. In an analysis comparing hematocrit to altitude and also age at the time of operation, we did not found, as we expected, any significant relation with between altitude and hematocrit, but we did see a statistically significant relation with age at the time of surgery. So in conclusion, we can say that the term high altitude has been used indistinctly for a wide range of altitude above 2,500 meters, but that, of course, its impact is not uniform and probably doesn't have a significant impact at altitudes where most centers perform heart surgery that is under 3,000 meters above sea level, where we have not seen any impact on PVR and only a relative significance on immediate post-operative oxygenations. Many centers at high altitude, however, are located in low and middle income countries where late referrals and late corrections of tetralogy of Fallot are done. Thank you very much.
Alexis, thank you for a wonderful presentation. We'll take questions from the audience if there are any. If you have a question, you may walk up to the mic and then introduce yourself and ask your question. Jim?
Alexis, that was fantastic. A long time ago, we learned of the profound effects of chronic hypoxia on the myocardium, on the right ventricle, not only on the hypertrophy it causes, but the metabolic aspects of the function of it, and also the immune system. And we know that it causes a fair amount of, inflammatory response or SIRS response after bypass. Is there anything in your practice, seeing a lot of these children that come in with hemoglobins that are high with the chronic hypoxic exposure, you do on bypass or after bypass to prevent what we call the SIRS response?
Yeah, we do two things. One, if the hematocrit is above 60%, we lower the hematocrit, but not more than 20%. So we are very careful not to lower it too much. And the second thing is we try to go on bypass with lower levels of oxygenation to prevent damage, reperfusion damage by oxygen.
Okay, thank you. Marcelo?
Yes, congratulations, Alexis. Very nice presentation. Do you have any specific policy for the children, even for small children, with high hematocrit? No blood?
Yeah, that's what I mentioned.
You have more patients like this?
Yeah, only before surgery, or during surgery, we try not to bring the hematocrit too low. So we might need sometimes some blood in the pump, sometimes not. We just calculate as not to come down too much on hematocrit, and we try to go on bypass with lower oxygenation, and that's all the measures we take.
Nestor?
Thank you very much. Nestor Sandoval from Bogota, Colombia. Alexis, congratulations again. No, a few years ago, we used to take those patients with a very high hematocrit and hemoglobin for a palliative procedure instead of going for the total repair when they are grown-ups or they're older. Have you any experience with that approach for those kids, preventing like a disaster in the OR?
No, we haven't. We haven't. We usually take the patients regardless of the high hematocrit, but I know it's a conduct that can be taken, that can be good, perhaps. Although I'm not aware of any study that has shown benefits compared to just going on and repair the tetralogy. I don't know if you've done that in Bogota.
No, they used to do that, but related to the high altitude is there are, as you mentioned, there are a big discussion about why 2,500 meters, and the most studies from West and Gibelin, they mentioned that the hypoxia start when you reach the 2,500 meters. And when you are operating a tetralogy of Fallot, it's not a big deal, but when you are doing a univentricular heart repair, maybe there is a big impact, and we feel in our patient that we normally, all of them are operated above 2,650 meters above sea level. And some of those patients don't tolerate those. Maybe it's an adaptation that we call adaptation. Those who are living permanently at the high altitude, maybe is fine, but those who are coming from the sea level to be operated at a high altitude, they really need to be sent as soon as possible to the lower altitude to be safe. So that's why we have a special strategies for those patients, because all of our patients are operated at above 2,600 meters.
Yeah, we stopped, for example, to fenestrate patients because we routinely saw normal PVR on preoperative caths. And after surgery, we noticed that the pressures were completely normal. And the problem after cardiac surgery, particularly at our altitude, the problem is that we are on the beginning of the downslope of the saturation curve. So for a few days, patients can be desaturated, and this desaturation can be exacerbated by fenestration. So we just opted for non-fenestration approach to patients. Of course, we need to do long-term follow-up of these patients and see if there's any difference between fenestration and non-fenestration. But for the moment, we don't think there's any. And of course, for tetralogy of Fallot, we haven't seen any impact. Of course, when I talk about high altitude, I talk about high altitude in centers where cardiac surgery is done. I would not pretend to do a Fontaine surgery at a mountain in the Everest, for example. But we're talking just about centers that perform cardiac surgery. And I think that it has been overestimated, the impact of high altitude, which is really minor. And in our experience, it's only minor desaturations after surgery, but no impact on PVR at all.
Right, thank you. Just a comment on what Nestor was saying. I remember when I was in Johannesburg. Johannesburg is just 1,700 meters. But one of the things that I noticed, and I remember asking Rob, and he commented on it, was why is it that when these children are flown from other parts of Africa, particularly with the single ventricles, they come in there and within a few hours they are in some hypoxic, hypercyanotic crisis. And I remember Rob saying that it's because of the altitude. So I went checking what's the altitude of Johannesburg, just 1,700. What's the FiO2? Somebody had actually done a study on the FiO2, various parts of it, and it's 17%. At sea level, it's 21. And I was asking myself, is it sufficient to account for this? But as you with the tetralogies, I didn't notice anything like that. But for the single ventricles, it seemed to be something significant. They come in there, flown from sea level, they get up there, and then they get into a crisis. So that is something that I think we probably need to be paying attention to. I think we'll go on to the next presentation. Thank you very much, Alexis.
Michael Okecho from Uganda was not able to be with us, so we move to the next presentation with Dr. Adil El-Gamal, who will treat practice patterns for the management of tetralogy of fallow in developing countries. Adil El-Gamal is working in Mansoura, Egypt, and he developed a sustainable activity after a long stay abroad, mainly in Saudi Arabia.
So good morning, Mr. Chairman, dear colleagues. I am very happy to be here and participate in this inaugural meeting of our African Society of Pediatric and Congenital Heart Surgery and the 7th meeting of the World Society. That meeting, which is being held here in Morocco, the country where the oldest university in the world, Al-Qarawiyyin University, was established in 859 in Fas City. This university was the first university in the world that graduated physicians. It's still fully functioning till now. Also, I should like to thank Dr. Christo, Dr. James, and Dr. Al-Halis for their support to our young society. They spend endless effort and time to help us. The most recent evidence of this support was yesterday in the Governing Council meeting when they decided to consider the World as the official journal of our African society, side by side to other giant pediatric surgery societies in the world. Since the first surgical repair of tetralogy of Fallot by Lily High in 1954, a wide spectrum of surgical strategies have been used to repair the two major components of tetralogy of Fallot, closing the VSD and relief of the right ventricular outflow tract obstruction. In an attempt to find out where we as the countries are regarding the strategies in the management of tetralogy of Fallot, we designed a multinational questionnaire survey on practice patterns for management of tetralogy of Fallot in developing countries. 24 surgeons from 23 centers in 15 countries and 3 continents had participated in this survey. And the following 2 slides shows the names of the authors and their country who participated in this study. The diagnosis of tetralogy of Fallot was made during the first 6 months of life in more than 2/3 of the centers. In most cases, the tetralogy of Fallot was suspected based on bluish discoloration noticed by the parents or cyanosis noticed by the physician in more than 80% of the centers. Accidental discovery was made only in less than 20% of cases. Echo-Doppler examination was the primary mode of confirming the diagnosis in all cases. Cardiac multi-slice CT was routinely used for preoperative evaluation of tetralogy of Fallot in only 1/3 of the participating centers. In the remaining 2/3, it was used only when pulmonary artery hypoplasia or major aortopulmonary collaterals or coronary artery anomalies are suspected. Most centers in developing countries offer primary surgical repair for patients with tetralogy of Fallot around the age of 6 months. 25% offer surgery between 3 and 6 months of age, and only 5% do repair at the age of 3 months. There is no neonatal repair of tetralogy of Fallot in developing countries. Staged repair was a strategy in only 12.5% of the participating centers. The reason for staged surgical repair was hypoplasia of the pulmonary artery branches in 66%, lack of infrastructure to support primary total repair in 17%, lack of an experienced anesthesia team in about 13%, low body weight in a very small percent of patients. The good news is the availability of a dedicated anesthesia cardiac team in more than 2/3 of the participating centers. In more than 60% of the centers, a cardiac surgeon is the one who performed the surgical repair of tetralogy of Fallot, and in only 37% of centers, the surgery was performed by an adult cardiac surgeon. All types of cardioplegic solutions were used with a slight preference of HTK and Delnido. Regarding the use of hypothermia during surgical repair of tetralogy of Fallot, most centers cool down to 32 degrees. About 30% cool down to 28. Very few cool down to below than 28, and also very few use warm bypass. For the management of right ventricular outflow tract obstruction, an annular infundibular preservation strategy was used in just more 50% of cases. A minimal transannular patch was used in 37%, and a large classic transannular patch was used in less than 10% of cases. The preference of the surgical strategy to manage right ventricular outflow tract obstruction is based on the surgeon's choice in about 2/3 of the centers. The VSCD was approached through a transatrial, trans-tricuspid approach in more than 90%. The adequacy of repair was assessed by the use of intraoperative TEE in more than 1/3 of cases, and by direct measurements of the pressure in the right ventricle and pulmonary artery in 1/3 of cases, and in the remaining 1/3 there was no intraoperative assessment of the adequacy of repair. In more than 60% of centers, the post-operative ICU care was taken in a cardiac surgical ICU, either pediatric or a combined adult and pediatric ICU place. Only about 20% of cases, the care was taken in a general surgical or pediatric cardiology ICU. Minute-to-minute management in the ICU was the responsibility of a pediatric cardiac surgical, cardiology resident, or an assistant consultant in about 41% of centers. Pediatric cardiology surgical intensivist in about 33%, general anesthesiologist in 18%, general intensivist in about 8% of the participating centers. Nursing care was taken out by a pediatric cardiac ICU nurse in 45%, both adult and pediatric ICU nurse in 41%, general ICU nurses in only 12.5% of the participating centers. The post-operative ICU echo evaluation was used routinely in about 54% of the participating centers, and only when indicated in 45%. A pre-discharge echo study is a routine in more than 95% of the centers. Post-discharge follow-up in the outpatient clinic of the same center is the practice of more than 95%. Follow-up echo evaluation every 6 months is the policy in about 2/3 of the centers, while only every year in the remaining centers. On the contrary, post-operative evaluation using cardiac MRI is only used in less than 5% of the participating centers. In developing countries, half of the participating centers deal only with complex form of tetralogy of Fallot. A quarter perform surgical repair of some cases of complex like tetralogy of Fallot absent pulmonary valve, tetralogy of Fallot pulmonary atresia without MAPCAS. Only a quarter of the centers in developing centers offer surgical management of tetralogy of Fallot pulmonary atresia associated with Wspchs. More than 80% of the participating centers offer surgical help to patients with late complications of tetralogy of Fallot, like residual VSCD, residual right ventricular outflow tract obstruction, and chronic pulmonary regurgitation. To compare our practice with the practice patterns in developing countries, there is a study by the STS in 2010, and to the best of my knowledge, there is no available STS studies after this date. The conclusion of the STS study was primary repair is in the first year of life is the most prevalent strategy, despite contemporary awareness of the late consequences of pulmonary insufficiency. Ventriculotomy with transannular patch remains the most prevalent technique, both for the primary repair and for repair following patch. In a more recent study by Radi et al. From 18 multinational cardiac surgery centers, including centers from developing countries, showed the same strategies as our study regarding the management of right ventricular outflow tract obstruction. This study indicated that there is a shift to annular infundibular preservation strategy during relief of right ventricular outflow tract obstruction in tetralogy of Fallot repair in the past 10 years. Our study showed that this is true even in the developing countries. So, in conclusion and wrap up, we in Africa and developing countries apply and utilize up-to-date practice strategies for management of tetralogy of Fallot. However, we need to improve on training more specialized pediatric cardiac surgeons, cardiac anesthesiologists, cardiac surgical intensivists, and cardiac nurses to be available in all centers. Also, we need to improve on our infrastructure to include more transcatheter echo machines in the OR and the use of more cardiac MRI machines. Finally, I would like to express thanks and gratitude to both local and international committees for organizing such fantastic meeting. Thank you.
Thank you, Adil, for this excellent presentation, which is an idea about what's going on in our continent. And there is a lot to be done as well. So is there any question for Adil?
Get it started. Adil, that was a fantastic presentation. And as we know, surveys give you a shot of what practice patterns are going on at the current time. You know, there are 5 centers in the continent now that are submitting to the database, you know, to look at long-term outcomes of all congenital heart disease, tetralogy of Fallot. I wonder, from your center and what you've seen, what are the obstacles for being involved in these databases and not just following the snapshot of the practice, but following long-term outcomes that were really critical in understanding how we're doing?
Yeah. Actually, the big obstacle to participating of our centers is the time to introduce this data. So, I mean, ago we discussed this with James and with Jim, and we said we need to hire computerized personnel who can enter this data regularly. Because as I am a surgeon, I have no time to stand on the computer and put all these data together. Because, I mean, we do like 10 cases a week. So I need at least 2-3 hours to sit down and to use this data. And I have no money to hire some person just to enter this data. This is a major obstacle, at least from my center. So I participated in the world database for about 3-5 months, and then I cannot make it. I stopped.
Christo?
a great presentation, and obviously we're scratching a little bit the real problem. A few years ago, I remember our Latin American friends had come up with a study, Nestor Sandoval and Marcelo and other colleagues from Latin America, on the deficit of the number of patients or percent of patients in each country in Latin America that are not being treated with congenital heart disease. Do we have any sense in Africa, if we, let's say the malformation of tetralogy of Fallot, what is the deficit? What percent of patients with tetralogy of Fallot in the African continent are not getting surgery, are not getting treatment? Is that information exist?
Maybe I can answer that. From our studies in Ghana, we looked at this, I think in a 2-year period, 2013 to 2015. And from our data, we realized that considering the number of children that were born in the country, expected in the country a year, and the number of children who received a diagnosis in the first 2 years of life, the numbers match up. It was a percentage of less than 1. Less than 1% of that number actually got a diagnosis, never mind treatment. So it's a huge deficit, very, very large one.
I can answer this question in Egypt. Now, I do believe that there is no Egyptian kid with a diagnosis of tetralogy of Fallot have no access. All of patients have access to surgery, and most of them do surgery within the first year of life. That's in Egypt. I'm not sure about the rest of Africa.
I think, Adele, you should explain that a bit, because the rest of Africa, I know because we talked about this, but maybe you should give a little bit of detail. How did this happen? Because this is not usual in Africa.
Yeah, well, in the past 5 years, there was a major change in the strategy of managing patients born with congenital heart disease. There is a presidential initiative that aims to eradicate of all of the waiting list in Egypt for many lesions, including congenital heart disease. So now, most and up to 100% of patients born with cardiac defects have a free access to insured medical service, including surgical repair. Because of this presidential initiative in the past 4 years, it was implemented in 2018.
We have a question on the floor.
Thank you very much. Dr. Fudi Jonan Kamara from Sierra Leone, West Africa. Yeah, here what our learned colleagues saying about their country. For us, in our country, we can diagnose the condition, but of course we don't have the cardiologists there to do this. So we don't have the infrastructure, and then sometimes we look for organization to do the sponsorship overseas to do the surgery, and it's difficult to sometimes get such organization. So as we are also from the presentation, then the first 1 year will be the most time you advise that surgery, and then for us, late diagnosis may happen, and we may not even get sponsorship to actually fly the person out of our country to do the surgery. So what would be the chance for those children that we can actually diagnose, but there's no chance for them to do the surgery because of various conditions? Just explain.
So, the question?
What? Can you maybe say it again clearly?
So we can diagnose the child with the TOF, but we don't have the means to do the surgery. There's no finance to take the child out of to do the surgery.
Oh.
And so what would be that child? What would be the survival? Assuming we want to still try to ensure that the child gets the surgery. So what's the surviving rate of somebody who has a condition, but haven't got the chance to do the surgery?
I mean, Dr. Zuhair and Dr. Abdul Saidi and Dr. Hani Najm and myself do many missions to developing countries in Africa. We go to Sudan, to Tanzania, and Dr. Zuhair goes everywhere, all over Africa, do surgery for like 20, 30 cases per mission. I don't know if you can offer sending the patient to countries where centers for surgical management is available or no, because there's some financial aspect for this.
Good, Adil. I think the question was, what is the survival without surgery?
Oh, without surgery?
Yes, this is question.
Okay. It's very well known that, but I think that by the age of 10 years only, I'm not sure how much is the survival with
So
untreated
I can
natural-
comment on what we have in Ghana because we've looked at this. So in Ghana, it's about, for tetralogy, it's about 28% of them who will be alive after 5 years. But I mean, by the time they are 10 years old, I think it comes down to 10% or something like
I'm
that.
sorry, I get not the question.
Okay, thank you.
I'm Hisham Shawki from Cairo, Egypt. I'm just elaborating on what my colleague Dr. Adel said. Our last presidential agreement for doing all cases, this decreased the waiting list definitely. But what I'm saying is, as Adel said, it's all diagnosed patients receive surgery. What I'm discussing or what I'm saying is there's a group of patients which are undiagnosed congenital heart. If you go for figures, we have a birth rate of 2.5 million a year, and this will give us around between 18 and 25,000 patients needing surgery. And our last statistics last year, 2021, all the numbers approached in Egypt, both between cardiac surgery and intervention, was 10,000. So this keep us with around between 8 and 15,000 undiagnosed and untreated. We are planning a study next year, I mean actually very soon, to do early diagnosis of congenital heart, and this will increase the number of patients and the number of patients operated upon. Thank you.
But I think every diagnosed patient have access to surgery.
Yes.
He said, so what are maybe you could just expand a little bit on the barriers for getting all these children diagnosed? Is it the medical system, the exposure during the fetal period? What are the barriers that you've seen in your country?
The main problem we have is patients born in urban areas in the cities are diagnosed early and they can reach surgery. And as Adel said, and I only added that all of these patients are going for, all diagnoses are going to be operated upon. Other areas in rural areas, it's very difficult to diagnose. We're trying to implement three things, actually, starting from this year. Oxygen saturation on newborn, clinical examination, and making echo centers all over the city, all over the country, to get more patients diagnosed.
Another question?
Thank you very much. I am from Ethiopia. I'm a heart surgeon in my country, and thank you for your presentation, and you intrigued me to talk about my country, about this condition. As you know, Ethiopia is the second largest populated country in Africa, with a population of more than 120 million.
You speak closer to the microphone.
Yeah. No. So, as you know, Ethiopia is the second largest populated country in Africa, with 120 million plus population. And you know that Ethiopia is the seat for African Union and African nations. And you know that the history of this country. And if you take this population and the percentage of congenital heart disease is 1%, and take the share of tetralogy of Fallot, you can imagine the number of tetralogy of Fallot in this country. And open heart surgery by the local team has just launched 5 years ago, and I am the one who has started open heart surgery in my country. So in my 5 years stay in Ethiopia, in the cardiac center of Ethiopia, I did only 6 tetralogy of follow. 6. And you can imagine the number of tetralogy of follow that can exist in my country, and you can imagine how people are dying from this condition. So the point that I want to raise in this special session is that it is because if we can urge the AU, or if we can use this special first meeting of the African Society for Pediatric and Congenital Heart Surgery to have a kind of financial means to support these kids and to involve big organizations like the African Union to have an insurance to secure a free surgery for these kids, I think that would have been a very nice thing, because I want to raise these issues because Ethiopia is the largest country with a very nice history for Africa. We are the pride for Africa, and with a huge number of population. And I think we have a very good center. The cardiac center of Ethiopia is the only center with a very nice setup, but this country and this population need more centers. And I want this society to urge for a kind of insurance or a kind of finance system to reach for those lives. Thank you very much.
Thank you. Maybe I'll make a little comment on that. This is a huge problem, and it goes beyond surgery. It goes into politics and government and a whole lot of other things. But I think it is also one of the reasons why the African Society was formed, that practitioners who are facing these problems, because we see these problems, the politicians don't see it. And unless we come together and form an advocacy platform for this, this problem will remain. It's not only surgeons who can deal with this. We need to involve a broader stakeholder group to be able to deal with this. These are some of the things I'll talk about in my address tomorrow, so maybe I shouldn't overdo myself.
A last comment. I'm happy to see that our colleagues from Sierra Leone and from Ethiopia are here, because I was following their presence closely because of many administrative visa issue, and I'm really happy to see them today in this big meeting expressing and exchanging their point of view about the practice of pediatric cardiac surgery in their countries. Thank you. Last question maybe, and go.
Okay, so thank you very much. I'm a Ghanaian, Dr. Isaac. The West Africa, Ghana has a nice center where the president of African Congenital Pediatrics president is. I was trained by a national center, and I've gone to the second largest city, which is Kumasi. Historically, Kumasi started 2006 October, started the first cardiac missions with the Boston Children's Hospital, with the Francis Finn Thompson, and we just our 15 years, and so I've done almost 125 cases of congenitals, totality forming about 80% of it, because that's a maximum complex that they want to do at a time. They usually don't want to do the simple shunts. And so my maybe small advice to my brother from Ethiopia is that probably if there's opportunity to link up with some missions or some big hospitals who are ready to assist. So we've been doing that for the past 15 years. Just about past 5 years, I have returned fully to the center in Kumasi. I'm trying to do some simple things, and then non-pump cases like PADA, coagutation, pericarditis, and then simple things, shunts, and then the vascular and the thoracic, hoping that with the continuous support from our national center and the missions, we hope that in 5 years' time, we have a dependent center in Ghana. So in between time, maybe what they can do is to link up with some missions who are ready to assist you. And I'm sure it's one of the issues we discuss as a presentation later on. Thank you very much.
I think the only way to solve this problem is we need some champs from advanced centers to come over and spend a week or so in our developing centers. I have done this when I came back from America after my training, and I worked with Dr. Hani Najm for 5 years, and then I came back to Egypt in 2005 when I started my program from zero, actually zero. No one in the hospital knows what open cardiac surgery means. So I got Dr. Zuhair, and he visited me the first time with a team of 17 persons. Nursing, perfusionist, ICU, anesthesia, and spent 10 days with us doing 30 cases. And then next mission, he came with 12 persons. Next mission, he came with 7. Third mission is with 3. And then after this, he came by his own alone. And then left us, and now we are doing extremely good in managing almost every single pediatric cardiac surgery lesion. So I think this model should be repeated in any centers in Africa.
And just to plug this session on Sunday morning, we'll dedicate to this exact topic, is how centers on the continent can get started and flourish as yours has. So I think with that, we'll end this session. It's very successful. We have, no, was it?
Is Dr. Kumar here? Yeah. The last presentation will be treated by Dr. Kumar from India, and it will be on long-term follow-up and management of pulmonary insufficiency.
Whilst the presenter is getting his things ready, I just want to mention the African delegates who are here. Some of you, we understood from yesterday, may be leaving before Sunday's session. So because of that, we want to meet all of you this evening after dinner, right in this place, 9:30 thereabouts, so we can get together, get to know each other, so that even if before that session, you would take something back. Thank you. Please go ahead, Mr.
All right, morning, all of you. At the onset, thanks, Drizzy, Dr. Shevchenko, the organizing committee for giving me this honor to present this talk. A lovely country, I'm very glad to be here. Yeah, so my talk today is on the obstacles to the long-term follow-up of repaired tetralogy of Fellow and avoiding the long-term effects of pulmonary valve insufficiency and other post-op sequelae. The long topic, I have no disclosures. Well, just to start with, tetralogy is the prototype of what congenital heart disease has been. You know, it was the first cyanotic lesion to be described, the first palliative and operation, the first cohort of long-term survivors. It's a model for natural history studied in the treatment of congenital heart disease. It has been the central role model sort of a thing in molecular biology, myocardial protection, the inflammatory response, as we just discussed. It's a disease which is lethal if untreated. Surgical results are good, but at times getting outcome is still a challenge, and especially in the long term. So since this is a postgraduate symposium, let me start from the beginning. You know, what is an ideal TOF repair? It should be suitable for all ages and weights. Good relief of right ventricular outflow tract obstruction and prevent further hypertrophy. A complete atrial and ventricular septation, avoid a ventriculotomy, avoid a circulatory arrest. Preserve the pulmonary and tricuspid valve function. There should be minimal early mortality and morbidity. Freedom from reoperation and late morbidity, and give the patient a good functional status and quality of life. So the issues which I'll superficially touch today, it's very difficult to get into in-depth in these things, is the obstacles to follow-up of post-operative congenital heart disease in lower middle-income countries, long-term post-operative complications of tetralogy of Fellow repair, specifically primarily pulmonary insufficiency, and avoid and mitigate the effects of pulmonary insufficiency. Just to touch on the global burden of congenital heart disease, and then we'll reflect on how it is affecting the lower and middle income countries. One out of every 100 children around the world is expected to have a congenital heart disease. Now, in our part of the world, India, Southeast Asia, the Pacifics, Africa, a significant percentage of these deliveries, babies are born unsupervised at home, and critical heart disease escapes detection. And also, what makes the whole treatment and giving these treatment protocols to these children more complex for the caregivers is there is a very large pool of older infants and children, and sometimes adults, a lot of time adults, who have survived without any intervention, and they require the ideal treatment. Additionally, there is a large subset of patients who have non-congenital pediatric conditions, and we are going to touch on these topics of rheumatic heart disease and others, who require diagnosis and treatment, and it takes away a lot of the funding and the infrastructure for the treatment of these diseases. So yeah, we have challenges and we have roadblocks for the ideal cardiac care of children in this part of the world. And I want to put sort of India as a prototype, because we have made a lot of progress in the last 10, 15 years. And when I show you the map in the next slide, you will come to know how we have progressed, but we are still very, very short of giving the ideal care to these children. So the first problem is the rapid population growth in this part of the world. India has just sort of plateaued out for the first time, but there's still a huge population growth. And by our assessment, I think there are almost 250,000 kids are born with congenital heart disease every year in India. Poverty is rampant. So for the parents, it's a big problem trying to get treatment for the children. The publicly funded hospitals have long waiting lists, and a lot of these patients die while waiting for surgery. Illiteracy is another big problem, where the parents don't understand, despite the doctor telling them what is the problem. There's a lot of social pressure about a heart disease. The child is not well, and there is a sort of a I wouldn't call it ignorance, but a known ignorance to the problem of the child, and they never get their child up for treatment. There's lack of adequate healthcare funding, because funding is limited, and you want development, but healthcare in a lot of countries, including my own, takes a big backseat in comparison to giving jobs to the young. There are competing priorities for us, healthcare givers, for the government, for the parents, as to where to apply those funds and give the best out of that money. There's inefficient and inadequately equipped infrastructure in smaller places, and more so, mostly there's a shortage of trained manpower. So yeah, the need of the hour in our part of the world is motivation, manpower, machinery, and money. And if you, this slide is courtesy my good friend Dr. Sachin Talwar, and we presented this slide a couple of years back in one of the talks. And if you see the distribution of the volume of cases being done every year in the country, and the private versus public and the pure versus mixed cardiac centers, most of the cardiac centers are concentrated in very the larger sort of cities, what we call the tier 1 and tier 2 cities, and there's a big geographical gap as to when the patient can reach the ideal kind of medical care which can be provided for a congenital lesion. So yes, having all this in background, we want to give the ideal treatment to all the patients. We have some historical truths about tetralogy of Fallot. Post-operative RVOTO is bad. PRVLV of more than 7.75 requires revision. More so, post-operative PI is well tolerated, and we should wait for important RV dilatation or dysfunction to treat or revise the repair. Historical truth? No. The historical fact is severity of RVOTO, PI, and time all influence the course of RV dilatation. Significant dilatation causes RV failure. Severe dilatation or RV failure impairs LV function. And of all the modalities of treatment we are providing for the tetralogy patient now, I think if you look at the long-term outcomes, they're all palliative. We have to go back and re-intervene at some stage. There's a very nice paper in JSCC, the state-of-art review, about how pulmonary stenosis versus PI influences the cardiac myoarchitecture. And what they found was that in comparison to pulmonary stenosis, there's lesser fibrosis. If I can I don't think this is working right now. So the rightmost histopathological slide shows there's lesser myofibrosis in comparison to the middle slide, which is pure PI, PS versus a PI model. And also we know that there's a systolic ventricular dysfunction after tetralogy of fellow repair, mostly because of ischemia reperfusion injury. Prolonged period of deep cyanosis and impaired oxygen supply causes a metabolic remodeling, shifting the myocard, what we call the metabolic mitochondrial switch to anaerobic glycolysis, which is less effective. There's long-term abnormal iron metabolism causing some endocardial hemosiderosis. So the RV dysfunction post-surgery is produced by surgical scarring, RV volume overload of pulmonary regurgitation, residual right ventricular outflow tract obstruction, and the LV dysfunction occurs as a result of this. The alteration in the size and function of the RV, the reverse Bernheim effect, leads to LV dysfunction, abnormal coronary artery patterns which may be damaged, destroyed during your surgery, and a lot of times these palliative shunts cause left ventricular dysfunction if left unattended for long durations, and which is a common cause. You do a shunt and he comes back to you for surgery first time after 5 years. So if you look at these pressure volume curves, you see that at the beginning of pulmonary insufficiency, there's already a rightward and upward shift to the pressure volume curve loop, and as the pulmonary insufficiency increases on a long term, there's a significantly increased diastolic stiffness, and effectively it causes a reduced effective stroke volume. What effect does it have on the left ventricle? So left ventricle dysfunction is seen in 25 to 33% of late survivors of tetralogy repair. It's an independent predictor of adverse cardiac events, and there's a 30% increase in the risk of adverse cardiac event for every 5% increase in decrease in left ventricular ejection fraction. And a similar kind of effect occurs on the left ventricle if you look at it physiologically, where there's a rightward and upward shift, causing a passive stiffness increase, causing a decreased end diastolic volume and a higher end diastolic pressure. So initially in the course of this dysfunction of the pulmonary insufficiency, the left ventricular stroke volume is maintained by decrease in the afterload or increase in contractility. But as the PI evolves, the whole system falls apart and the passive stiffness increases manifold, causing a decrease in the stroke volume. So just to summarize the pathophysiological effects, the RV contractility is decreased in pulmonary insufficiency. The RV and LV reserve, that is the effective stroke volume and the ejection fraction, are compromised both in PI and PS, but in the long term more in PS. The effect of a free PR appears equal to or worse to a combined PSPI with regards to both RV and LV function. So PI per se is not to be waited on for a very long time because it has a similar kind of effect to the left and right ventricular function as an isolated PS. Now, if you look at the contemporary predictors of death and sustained ventricular tachycardias in patients with repair tetralogy of fellow, this is the indicator trial where age 73 patients with a median age of 24.4 years, 3.7% the primary outcome, that's there were 28 deaths, 4 with sustained VT, and the median age of outcome was 38 years. And what the study found was on the basis of clinical outcomes, ECG, exercise, cardiac MRI, that RV dysfunction was predictive of the outcome. RV hypertrophy, ventricular dysfunction, and atrial tachyarrhythmias that were, as a result of the RV dysfunction, were predictive of death and sustained VT in adults with repaired tetralogy of fellow. Coming to the evaluation of right ventricular function, the topic has been taken up in detail earlier. The echo is just, as I would consider, is just an initial imaging modality. It does not give you enough information about how the right ventricle is functioning or is going to function in the coming years. It's suboptimal for delineating the RV after tetralogy repair. It's just to my mind, a scanning modality. The traditional measurements of RV function, what we see in adults, the TAPSE and the Doppler-derived tricuspid lateral annular systolic velocities, have not been correlated well with RV function as measured by the cardiac MR in tetralogy of Fellow. Maybe the fractional area change is the only one which comes closer to cardiac MR. So I think on assessment of echocardiography, a cardiac MRI has now become the gold standard for the long-term assessment of the effects of PI. And I will not dwell on this slide because we have already had a discussion on one of the previous talks, but just to elaborate on the optimal thresholds for intervention for a better event-free survival, right ventricular ejection fraction less than 30%, LVEF less than 45%, RV end diastolic indexed volumes of more than 150 ml per meter square, RV end systolic indexed volume of more than 80 ml per meter square is a good threshold for event-free survival in the later date. One of the newer assessments is the QRS fragmentations. It's not so new, but yeah, it's not in vogue as yet. I thought I'll bring it up here. QRS fragmentation is superior to isolated QRS duration in predicting mortality in adults with tetralogy of Fellow. Multi-notched QRS complex or an R wave is a high indicator of prediction of mortality. So preventing PI has been essentially the holy grail of tetralogy of Fellow repair. Various techniques have been tried for the past 20 odd years. Various papers have come out. There's a horde of literature out there. Preservation of pulmonary annulus with a competent pulmonary valve with growth keeping pace with age and no progression of pulmonary insufficiency or stenosis is the ideal repair. Well, I couldn't find any consensus on what is the ideal repair. So if we start looking at how people have gone about it to avoid a transannular patch, Dr. Mavrodas and Carl Becker's group in 2005 came up with this paper where they upped the Z-score to Z-4 to a valve-sparing surgery. I do not know the outcomes in the long term. I have not been able to find Dr. Becker is here. We might have a chat with him. Balloon dilatation, intraoperative balloon dilatation by the Boston group in early 2005 to 2010 came up in a vogue. They did a study, but finally they have found that compared to the transannular patch, the exact RV dilatation in midterm follow-up of a balloon dilatation intraoperative is no different from a transannular patch. And this intraoperative balloon dilatation has no significant advantage over a TAP in the midterm. Well, my favorite has been for the last 10 odd years the Sung reconstruction or what we call the anterior leaflet augmentation, either using a Gore-Tex or pericardium. And when I show you our results, they have been quite satisfying as far as this technique is concerned, where we augment the anterior leaflet. Having said that, this technique is not possible to be employed in all subsets of the valves, and sometimes with very dysplastic valves and a very small diameter of the valve, it is not possible to do a Sung repair well, and a pure tap required. Vida and colleagues from Padua have been very aggressive about their approach in trying to maintain the pulmonary annulus. And they have a couple of other papers which define the anatomy and which subset of pulmonary valves is amenable to this kind of repairs and sparing the pulmonary valve. So what they do is they do an aggressive, it's a very aggressive approach. They do an aggressive commissurotomy, do an intra balloon dilatation, and whatever damage has been done to the valve after intra balloon dilatation and after the delamination is repaired by one of the various techniques described. Again, the jury is still out on this because the midterm results are still not there, so we need to wait and watch. Once the patient is beyond this stage of the first surgery from the surgeon's hand and there is significant PI, pulmonary valve replacement is the only thing which is going to give this patient a good and long quality of life. And the indication and timing of pulmonary valve repair replacement had been described first by Tal Geva and have been essentially, I'll not describe all of them, but have been essentially followed by most units plus minus 5 or 10% in the right ventricular end diastolic volumes. But it is common knowledge, and this meta-analysis from Kalamakanti and colleagues of 48 studies says that RV experiences improvement in the volume and function. The LV experiences improvement in its volume and function. The QRS duration decreases. The symptoms improve after a pulmonary valve replacement in the long-term tetralogy of fellow patients. There are multiple heterogeneicities in various studies, and the effect of mortality is still not known. Just to give you a brief overview of our experience, we have operated over the last 11 odd years, 757 cases of pure tetralogy of fellow. We have taken out the top pulmonary atresia, absent pulmonary valve subset from this. Our mortality has been 0.8%, and all the mortalities have been in the pure transannular group. What we have found in this study that freedom from reintervention at 5 and 8 years is the most in the Sung valve group, at least in our unit, and is the maximum in the transannular patch group, which is obvious. I think the transannular patch with the Sung valve reconstruction in our hands has been a good modality for treatment for these patients. Well, just to summarize with the take-home message, prevention of PI and maintaining integrity of the pulmonary valve is of paramount importance, but not at the cost of a repeat early intervention, as Dr. Christo just said. Various surgical techniques are available. Take your pick. Early repairs in neonates and infants, small infants, prevents the ill effects of right ventricular hypertrophy, but add to the long-term effect of chronic pulmonary insufficiency. So you have to balance the two. Chronic PI is well tolerated for long, but is damaging to both the LV and RV in this period. And pulmonary valve implantation at the correct time may reverse the myocardial damage to a certain extent. Thank you very much for your patient hearing.
Thank you, Dr. Kumar, for this excellent presentation. For sake of time, there is one or two questions. So, meanwhile, to preserve the RV function according to your experience, you try as much as you can to preserve the pulmonary annulus, or you go and open if needed and put a patch with a cusp.
So from our initial experience in the first 2 years between 2008 and 2010, we were very aggressive about trying to preserve the pulmonary annulus. And we found that, as Dr. Christo said, that within 2-3 years, we had a fairly large percentage of these patients who would come back for resurgery. More so, in our setup, sometimes the patient don't come back to you for research. You know, they're just lost to follow-up. I mean, even with this paper, we have just an 85% follow-up. So I don't know what has happened to the 15% residual patients. They don't come to you and with the VSD closed and the RV hypertrophied, sometimes they come back after 4 years, 5 years with terrible right ventricles, with hardly any volume in the right ventricle. So we started going more aggressive towards the transannular patch, trying to minimize the length of the patch, and also trying to reconstruct the pulmonary valve, which gives you the most competence. And once I came back, I worked with Tom Carl for a few years, and when I came back from him, and he was very fond of doing this Sung valve, and we sort of managed to figure out how to do it perfectly. The results have been pretty reasonable. Our reintervention in Sung valve over the last 8 years has just been about 10%, and most of them have been obstructive and not for PI. So yes, so we are more towards doing a tap and reconstruct the pulmonary valve and try to give some competence to it. And that's the case.
Thank you. Any question? I think
Thank you.
It's time to have a break. Thank you, everybody. Yes. Yeah, we come back at 10:30. 10:45. Okay. We'll resume at 10:45.
Presentation
Okay.
is this afternoon presentation. Can you do it?
Yeah, yes, of course.
The time of the presentation tomorrow, no need.
The time will show it.
I know, but here no need.
No, no.
Anil Devapuram, Anil Devapuram. That one. No? You have to scan it? No.
Yes. No, no need because I copy it in the computer.
The first one.
تكومونس انتي تكومونس انا كيما تحب وراه فلاديمير واحد بواحد ندير مرة انتي ومن بعد يدير فلاديمير مرة ومن بعد هاني بريزونتي انتي ولا انا كيف رانا في ثلاثة دونك تحبوا كنترول هنا باسكو جيفري جاكوبس هو اللي يدير الانترودكسيون تاع ديان سبايسر باش بريزونتي لا سي سبيكر ديان سبايسر هو يبريزونتي جيفري جاكوبس شوف نقول حنا نقولوا باللي جيفري جاكوبس يبغى بريزونت will introduce the speaker for the 7th step version of our lecture about anatomy of tetralogy of Fallot. D'accord. ومن بعد الاخرانيه هذه بريزونتي سا بيرسون سا اون اكسبيريونس بيرسونال هذه كلوي ايوا هذيك اللي هي اوبيري بور اون تيترالوجي تفالو Hi, Professor Seleni.
Giovanni Stellini.
Yeah.
Hi. I think I'm replacing Vladimiro Vita.
Okay,
because he's not here. That has been agreed with.
It's our
with
pleasure
Christoph.
to get you with us.
My name is
Giovanni Stellini.
Stelling or whatever.
Nice to meet you.
Very nice to meet you. You're Nadia?
Nadia Idrissi
Idrissi.
Nadia Eldrissi.
Si, yes.
From Marrakesh. You're
From Marrakesh.
here.
Yeah.
Fantastic.
I'm really, yes.
And
Abdel Malik,
Abdel
from
Malik,
Algeria.
From Algeria.
Algiers.
Algeria. How do you say? Algeria.
Aljazair. In Arabic, Aljazair.
Aljazair.
In
Italian, we say Algeria.
Algeria.
Yeah.
In English, like in English, Algeria.
Yeah.
In French, Algerie.
Algeria. Yeah, that's right.
Are late.
So Algeria was under the French influence, like Morocco, right?
Yeah. Before Morocco, we were occupied by France in 1830. And Morocco was occupied in 1911. So
much earlier than that.
Yeah, yes.
And then when
and
the
we
French
got our independence in 1962. And Morocco in 1955.
55. Okay, good.
So we were occupied for 132 years by France.
Well, at least now you're independent, and you still have the culture from the French at
Yeah,
the
yeah,
time.
yeah.
And, let's look at the positive thing.
Yeah, but we look forward because, for example, we use French in medical studies.
Yeah.
And what I said yesterday in the Governing Council, we have problems with the French language because it
not
doesn't
the
allow
international.
to us to publish, to communicate in English. We have difficulties in using
To
English.
call them.
Okay.
So
How
You began.
Are you starting?
No.
No, please.
In our culture, we never began.
Yes.
No. You please introduce.
No.
You please. Please. I'm asking you. I'm the oldest,
Yeah.
so I'm. You please introduce the other co-chairs. Say that Vladimir Vida couldn't make it, so I'm replacing Vladimir Vida. I'm still from Padova, Italy.
Okay.
And then you start with the first one. The second one, perhaps management technical challenges, can be done by Nadia, and I can present Jeff Jacobs. How about that?
Okay.
And then you go again to the last one, the Susan Basler, if she's here. Because I haven't seen her.
No, she is not here, Susan. Susan will present by video.
A video.
Yeah.
Video presentation. Okay. And do we have a screen there? Okay, good.
So we have to start. And the question just after each presentation.
Yeah, I would say so. After
Yeah.
each presentation, but we need to keep the timing. So we started with almost half an hour delay, right?
Yes.
So each presentation's got 20 minutes. So if the presentation is too long, any questions? We launch afterwards. No, we're gonna. Yeah. Okay. Okay. Yes.
Growing up with tetralogy.
Yeah, you might introduce George Sorais, who I haven't seen him actually, and perhaps if you want, or I can introduce George Sorais. So what would you like? I introduce George Sorais, and you introduce Jeff Jacobs. The third one.
Growing up with tetralogy. Do you want
The
me to
last
do
one.
it? The last one? I'll do the second one and the last one.
The second one.
And the last one.
Hi, everyone. Please, we will start soon because we are late in the program. So this session will be co-chaired by myself, Abdelmalek Bouzid from Algiers, Algeria, Nadia Idrissi Slitin from Marrakesh, Morocco, and Professor Slayton Giovanni Stellini from Padova, Italy, in replacement for Mr. Vladimiro Vida. This session, each presentation will be 15 minutes to allow us to have 5 minutes for questions. We are so late on the program, and we will start with the first presentation. We introduce Mr. Mark Blivas from Gainesville, USA, to present us the management and technical challenges for neonatal and early tetralogy of fallout repair.
Good morning to the moderator. Is this on? Can you hear me? Oh, good. Good morning. Good morning. Thank you to the moderators, members, and guests. It's truly an honor to speak at the 7th scientific meeting of this World Society, and also the inaugural meeting of the newly established African Society of Pediatric and Congenital Heart Surgery. Today, I'll speak a bit about the management and technical challenges for neonatal repair of tetralogy of Fallot. Please, note that there's substantial variation around the world in how we manage these children. In my talk, I'll share some information about the variation in North America. In North America, some centers never perform complete repair in neonates with tetralogy. Some centers selectively perform complete repair, and some centers strive to perform complete repair in all neonates with tetralogy. And all of these philosophical approaches are completely acceptable and reasonable and have the potential to lead to excellent outcomes. At the University of Florida, our institutional philosophy is to perform complete repair of tetralogy in most prostaglandin-dependent neonates and small infants. And we reserve palliative interventions for those neonates who require a neonatal intervention and have either contraindications to bypass or anatomical contraindications to neonatal repair. So by reviewing information and data about neonatal repair of tetralogy, one can learn valuable lessons about the management, and these lessons can be helpful even for surgeons practicing at institutions that never or rarely perform complete repair. This slide shows the official definition of tetralogy of Fallot that's published in both the 2021 International Pediatric Congenital Cardiac Code and the 11th revision of the International Classification Disease. And the key component of this definition is the anterior superior deviation of the conal or outlet septum or its fibrous remnant. The four components, as we know, of tetralogy are shown in this slide and include a ventricular septal defect, narrowing or atresia of the pulmonary outflow tract, aortic override. Most often, patients with tetralogy have some degree of right ventricular hypertrophy. In reality, all of these four are found because there is this monology. Many scientists refer to tetralogy of Fallot as a monology characterized by this anterior superior deviation. So in order to prepare for this presentation, we examined some data from the Society of Thoracic Surgeons Congenital Heart Surgery database to learn about the prevalence of neonatal complete repair of tetralogy of Fallot in North America and the associated outcomes. So I'll share some data from several studies, and one was already alluded to in one of the previous talks, starting with the manuscript published by Hamad Al-Habib and colleagues in the Annals of Thoracic Surgery in 2010. In this analysis, the study population was all 3,059 index operations performed in 2002 to 2007 in patients aged 0 to 18 years, with a primary diagnosis of tetralogy of Fallot and a primary procedure of tetralogy of Fallot repair or palliation. Patients with pulmonary atresia, absent pulmonary valve, and TED with AV canal were excluded. 294 patients had initial palliation, including 178 neonates, and 2,534 patients had primary complete repair of tetralogy of Fallot as their initial operation, and this included 154 neonates. The data in this table documents the results of this analysis related to the prevalence of the various operative approaches in the various age categories. In this analysis, overall, of 3,059 operations performed in patients with tetralogy, 344 or 11% were performed in neonates. Of these 344 neonatal operations, 154 or 45% of the neonatal operations were complete primary repair, while 178 or 52% were primary neonatal palliation. Meanwhile, in the overall cohort of 3,059 operations, 2,534, 83% were primary complete repair, while only 9.7% or 294 operations were primary palliation. The data in this table documents the results of this analysis related to the discharge mortality of the various operative approaches in the various age categories. In the overall cohort of 3,059 operations, discharge mortality was only 1.9%, 1.3% in those undergoing primary complete repair, and 7.5% in those undergoing primary palliation. While in the neonatal cohort of 344 operations, the discharge mortality was 7%, 7.8% in those undergoing primary complete repair, and 6.2% in those undergoing primary palliation. So just to as a reminder, all of the data that I've shown so far comes from the STS Congenital Heart Surgery database from operations between 2002 to 2007. In order to gain an appreciation of the more recent patterns and outcomes in North America, we examined previously unpublished data related to tetralogy that was contained in this chapter about tetralogy of Fallot in the Society of Thoracic Surgeons ebook. This ebook chapter contains previously unpublished data from the STS Congenital Heart Surgery database about operations performed in 2015 to 2018 for tetralogy. These data are basically 11 to 13 years more current than the data I've just finished reviewing. And the data in the table is stratified by three categories: 0 to 30 days, 31 to 90 days, and greater than 90 days. And the data is also divided into primary shunt, primary repair, and repair following palliation. In this more modern era, 55% of neonates underwent primary complete repair, and 44% of neonates underwent primary palliation. As shown by these black arrows, the neonatal operative mortality was 3.6% with primary palliation and 2.4% with primary complete repair. In the same era, in patients over 90 days of age, 91% of neonates underwent primary complete repair, and only 1.3% of neonates underwent primary palliation. And again, shown by using the black arrows, in patients over the age of 90 days, the operative mortality was 11% with primary palliation, because as one would expect, these few older patients undergoing primary palliation represent a notably high-risk group. And the mortality for primary complete repair of tetralogy was now less than 1% in patients older than 90 days, undergoing surgery in 2015 to 2018. So to summarize these data, the snapshot of data from the STS database from 2 eras shows several trends. First, the mortality associated with both complete repair and palliation has decreased in the last decade significantly. And second, neonatal complete repair has increased from 45 to 55% of neonates over the past decade. So with this background of some North American data, I'll now transition to a discussion of our institutional philosophy for neonatal repair and really neonatal and small infant repair of tetralogy at the University of Florida. And I'll divide the talk into 4 sections: patient selection, preoperative management, operative management, and postoperative care. And I'll begin this discussion with a little bit about patient selection. It is important to remember that most neonates diagnosed with tetralogy can go home and wait for elective surgery, and the standard was about 3 to 6 months of age, although we certainly have no problem and performing earlier elective primary repair, and the age at operation has actually decreased over time. And I'm looking forward to looking at all this data when we get home. Preparing for this talk actually prompted us to think more about what we should be looking at from our data set. 3 groups of neonates require neonatal intervention: neonates with ductal-dependent pulmonary circulation, neonates off prostaglandin but with severe symptoms such as TET spells or substantial cyanosis after the arterial duct closes, and neonates with and you heard some discussion of this already, the threatened isolation or coarctation of a pulmonary artery, predominantly the left pulmonary artery. Because this is certainly a situation you don't want here, where the left lung is devoid of blood flow. This is an old, from an old paper and courtesy of Mitch Cohen. And this diagrammatically shows the loss of left pulmonary artery. Here's an echocardiogram from one of our patients demonstrating the ductal insertion and the, let's make sure I do this correctly. I don't want to, there we go. The isolation of that part between the left pulmonary artery and right pulmonary artery. I don't know if this echo is going to play, and it didn't. I'm sorry. This is a CT scan documenting the tortuous ductus entering both pulmonary arteries labeled here. You can see the ductal insertion and the area of narrowing that will occur when this ductus closes. So it's an important thing to recognize. For these 3 groups of neonates that require neonatal intervention, 4 basic options exist. You can do a complete repair. You can do a systemic to pulmonary artery shunt. You can place a ductal stent, or you can balloon and place a stent in the right ventricular outflow tract. If a neonatal intervention is required at the University of Florida, most patients undergo primary complete repair, and this occurs in almost all patients. Systemic to pulmonary artery shunt is performed, and in the case or 2 where we have proceeded with shunts, where I was unable to identify the left anterior descending in the operating room, we suspected that the intramyocardial left may have come off the right, but we could not identify its course. And this was, in fact, discovered post-op and post-operative imaging studies with CT scanning. So also, if we identify a left anterior descending coronary crossing the right ventricular outflow tract in the operating room, where we think that the patient requires a transannular patch, where we can't just tailor it off to the left, and we think it will compromise the coronary, we can proceed with a shunt. The next series of photos and a short video demonstrate the importance of identifying the coronaries during the repair of a tetralogy. We'll zoom in first and focus on the coronaries in this patient with double Allarite type of tetralogy. This black arrow points to the left anterior descending coronary adjacent to the patch, and just to orient let's see here, obviously the head would be up here, feet down here. The relationship between the transannular patch and the LAD is clearly demonstrated in this intraop photo. The LAD was identified and carefully avoided. As you can see, the stitches are relatively close, but spare the artery. We also identified a large conal branch that was identified as identified with this arrow, and it too was preserved. The relationship between the transannular patch and the large conal branch is demonstrated, very clearly in this intraop photo. And the short video, hope it plays. Let's see if it demonstrates those features clearly. My volume isn't here, but one of the things I mentioned in the volume is that the opening between the two is only about 6 millimeters, and we're able to use the patch and it enlarges, and you can see that looks a little wider than 6 millimeters, but it was only a 6 millimeter width opening. However, it's important to remember that if a transannular patch is necessary in the coronary arterial pattern, will not allow safe placement of such a patch, then placement of a systemic to pulmonary artery shunt remains an important option, and we typically elect central shunting. Ductal stenting is performed if a neonate with tetralogy needs intervention as contraindications to cardiopulmonary bypass, such as neonates who had bad preoperative stroke, or some children we've had who have had really bad necrotizing enterocolitis. We also reserve it for very small, extremely premature babies, and where we can use a stent selectively. There's something on my screen. Sure. None. Okay, thank you so much. Sorry about that. So, here we go. Ballooning or RVOT stenting. I think we went back. Yep, ductal stenting. Yes, sorry. Ballooning or RVOT stenting may be considered in these situations when ductal stenting cannot be performed for technical reasons. At the University of Florida, we rarely use this technique, and it's only been used as a bailout palliative procedure in kids with severe comorbid conditions and an inability to stent the duct. So next, I'll provide some comments about the preoperative management of neonates with tetralogy. We manage neonates with cardiac disease in our cardiac ICU rather than in the neonatal intensive care unit. They're typically moved upstairs within the first 6 to 24 hours. In these children, besides prostaglandin, besides placing them on prostaglandin, we tend to avoid inotropic support unless they absolutely need it. We try to extubate these children prior to surgery if possible, unless they have significant apnea secondary to the prostaglandin infusions. And we use NIRS preoperatively, intraoperatively, and postoperatively to kind of monitor their systemic perfusion. From an evaluation perspective, obviously all children get echocardiogram. We use actually CT scanning liberally, and in many patients they'll get CAT scanning to completely evaluate the pulmonary arteries, because we have seen not an insignificant number of children have collaterals that are significant. All neonates also undergo brain MRI, abdominal ultrasounds, and chromosomal evaluations, but we rarely perform cardiac catheterization unless planning an intervention or further diagnostic information is needed, but rarely do we have to perform cath. We cath all patients with pulmonary atresia, but that's not the purpose of this lecture, and we cath all patients if we question if their question remains about the pulmonary artery size or PA continuity. So I'll talk a little bit about the operative management. Operative management for us includes cardiopulmonary bypass with bicable cannulation, vent placement via the right superior pulmonary vein, and we typically do cool the small babies to 25 to 28 degrees centigrade. And this depends on the venous return. Oftentimes these children have a lot of venous return to the heart. And so cooling them can allow you to drop your flows to keep up. Even the vent won't keep up with the amount of return. And we recently converted to del nido cardioplegia. I was an avid microplegia user and recently converted to del nido cardioplegia. And my my colleagues tell me they're trying to teach an old dog old tricks. So most repairs are performed transatrially and transpulmonary in our practice, and we limit the ventriculotomy when necessary for right ventricular tract augmentation or VSD exposure. And we do, if we do a transannular patch, we try to minimize the transannular patch, as Roger Mee had talked about for many, many years. The VSD is most commonly close to the right atrium prior to incising or excising any muscle. And transannular patches, for us, is often necessary if the Z-score is less than -3. And that's a general rule of thumb. Sometimes we can go a little more negative, and sometimes you need a transannular patch if you're greater than -3. And even if a transannular patch is placed, we close the VSD more commonly through the right atrium to limit the size of the ventriculotomy. I try to patch the main pulmonary artery when I do have a transannular patch into at least, all the way into the sinus to the annulus. I'm sorry, if we do not place a transannular patch, I usually patch well into the sinus. And if there's an anterior commissure or slightly off-center commissure, I will try to patch into both the anterior, into both sinuses anteriorly, so it's sort of like a Y patch. We extend the pulmonary artery patch into the left pulmonary artery beyond the ductal insertion, as has been taught for many years, to avoid developing a late LPA coarctation. And there are a number of patients who we've been able to make separate infundibular and main pulmonary artery patches to avoid annular incision as well. For us, it is essential to always leave a PFO. I would say, in my opinion, in all neonatal and small infant deaths, we always leave a PFO, and it's important for perioperative, postoperative management. And in our neonates and very small infants, we always leave the sternum open for after neonatal repair or a small infant for delayed sternal closure. All patients in our practice get modified ultrafiltration, which we think helps in decreasing their body edema and their inflammatory response. Also elevates the hematocrit and allows you to get products in if you need blood products perioperatively. We use standard inotropes and infusions in our practice these are sort of typical what you might find when you're doing a small infant TET. Low dose epinephrine, typically it's 0.02. No hesitation to go higher if we have to. Milrinone we use less so than I used to, and I rarely am above 0.3. We use calcium infusions in neonates, nitrite for blood pressure, and we really have been using a lot of dexamethasone or Precedex to help with sedation, and it also helps with prophylaxis against some of the supraventricular arrhythmias. So I think it's been an excellent adjunct in decreasing our narcotic usage and also in helping with arrhythmias. We don't hesitate to have a loading dose and drip of amiodarone if there's any suggestion.
Please conclude.
SVT. Yes, I'm sorry. So we directly stick the right ventricle for pressure measurements and accept, usually the pressure are less than a third systemic, but we will accept less than 75% systemic pressures, typically. I'll make very brief mention of post-op at the expense of time. I mentioned all neonates get closed within the first, usually the first couple days. Usually they need volume, but we transition to Lasix infusions to allow for delayed closure. So in summary, I've talked about those four things. If you look at our data over the last since 2010, in 110 TETs, we've had no mortality, mostly small, 6 in the neonatal period within the first couple weeks of life, typically first 30 days. Most of these infant TETs are kids who were in the hospital and were never sent home. So I'd like to thank the society and the moderators for allowing me to present our data. I'll ask people to look at our meeting, our joint meeting with Dr. Najm and Cleveland Clinic and University of Florida next year. And also, once again, to emphasize, please come to the World Congress. Thank you so much.
Thank you, Dr. Blackvice. Please, we can get only one question because we are very late.
Microphone. Yeah. So thanks, Mark. Great results and great presentation. We have the identical approach almost at the clinic. I don't rush to do newborns if they're not symptomatic, but if they become symptomatic, whenever they get done. My question to you is why the surgical community accepts doing a BT shunt that may actually have a higher mortality than repairing neonatal tetralogy, and accept that rather than doing a neonatal tetralogy, accepting that it is actually higher mortality than repairing them at 3 or 6 months. Is that because the stat category is lower for repairing a tetralogy versus a BT shunt? Or why, what is the philosophy behind that? It's all, at the end of the day, is the mortality.
Yeah, you know, I don't know how to answer it. I think I would hope that centers would do neonatal repair if they feel that their center is capable of doing neonatal repair from a subspecialization. I mean, we have a separate group of anesthesiologists, intensive care, surgical team, perfusion team. Everybody's experienced with complex neonatal surgery. I don't know how to answer that except that I would hope that we would consider this in all or most cases. But I know, fact is, there are great centers that palliate and get excellent, outstanding results. And I know there are people here who would say that they would get nearly equivalent or equivalent results with a palliative strategy and follow that with. But I agree with you. I find no reason to shunt a baby TET unless there's something.
Please conclude,
Yeah,
because we are running over
Yep.
time.
Yep.
Great, thank you.
Okay, thank you
Thank
very
you
much,
so much.
Dr. Blackvice. We need to proceed to the next presentation. George Sorais from Athens, Greece, will present the management and technical challenges for infant with the tetralogy of Fallot. Is George here? Christo, are you aware whether George is here? He's not here. Oh, there is someone. Oh, recorded. Okay. Thank you, Mr.
Friends, dear members of the World Society for Pediatric and Congenital Heart Surgery, members of the African Society for Pediatric and Congenital Heart Surgery, it is a great honor for me to have been invited to speak at this really historical meeting in beautiful Marrakesh. And I am sorry that I could not be physically with you here today. I do wish, and I'm sure that this will be a fantastic meeting and that you will all have a great time. My task is to speak about the management and technical challenges for infant repair of tetralogy of Fallot with pulmonary stenosis. I have no disclosures. The remaining challenges and controversies in the management of tetralogy of Fallot with pulmonary stenosis are surprisingly many. For the symptomatic neonate, to repair or to palliate, which is the preferred palliation? Is it to shunt, to stent the ductus, or to stent the RVOT? When is the best time to operate on the asymptomatic patient? Which is the optimal surgical repair technique? Transatrial, transpulmonary, or classical transventricular? What are the new techniques for preservation of pulmonary valve function? And what are their results? There are no accepted by everyone answers to these challenges and controversies. I will present our approach which of course depends on the teachings of pioneers in the field, notably Professor Kawashima and Roger Mee, who have taught many of us, and all these colleagues, their students, have disseminated these approaches with some variations all over the world. What is our patient selection protocol? For asymptomatic patients, we choose to repair them primarily, electively, in infancy, let's say by 6 months of age. If the patients are symptomatic, then we would shunt or repair depending on age and anatomy. For neonates that are duct dependent, we generally choose to perform a right-sided shunt. For patients who are symptomatic, but at the time of presentation they're 6 months of age or older, we would perform the complete primary transatrial transpulmonary repair on all of these. For patients in between, we would choose to either shunt or repair based on details of anatomy and associated lesions. For example, we would prefer to shunt a smaller, a younger infant with anomalous LAD from the right, because repairing at a somewhat older age would allow us to do a transatrial transpulmonary repair without needing a conduit. What are the goals of the operation? Well, first, to relieve the obstruction while maximizing postoperative pulmonary valve function, and then to close the VSD, minimizing injury to the right ventricle, and of course preserving the function of the tricuspid valve. To achieve these goals, we seek an ideal balance between leaving residual RVOT obstruction due to inadequate resection or valvotomy, and the other extreme of leaving too much pulmonary insufficiency, which would result in an effort to completely abolish any degree of RVOTO by using a large transannular patch. And this balance is not always easy to achieve. What is the operative strategy? Transatrial and transpulmonary, so there's dual access. From the atrial approach, we perform the RVOT resection, close the VSD, repair the tricuspid valve is needed, and typically we would close the PFO unless there is some real concern about right ventricular function. Through the transpulmonary approach, we perform a pulmonary valvotomy, which involves commissurotomies, cusp repair, incision of the pulmonary valve ring to the minimal degree required, completing the RVOT resection, and addressing any hypoplasia or stenosis of the MPA and the branch pulmonary arteries. From the specific technical point of view, for the perhaps younger colleagues in the audience, we would use a standard median sternotomy, perform a thymectomy and pericardial sutures to optimize exposure, dissect the aorta, the main pulmonary artery, and the branch pulmonary arteries if work is anticipated on these. We would encircle a prior shunt if present, and take a good look for the presence of possibly an anomalous LAD from the right. Cardiopulmonary bypass would be established with aortic and direct bicaval cannulation. We would place caval snares and establish full flow CPB with moderate hypothermia. Immediately upon starting cardiopulmonary bypass, shunts, if present, are ligated and divided. The aorta is cross-clamped. We use single-dose crystalloid cardioplegia and Shumway type topical cold installation. Immediately after cross-clamping, a right atriotomy is performed with caval snare snugged and the left atrium is decompressed via an existing PFO or via an incision in the fossa vallis using a coronary sucker. This is an important step as left atrial return can be voluminous in these patients, especially if a little older with a lot of bronchial flow. We then place atriotomy stay sutures. We gently retract the tricuspid valve with 2 Langebecs and also the RVOT in a cephalad and leftward direction. We visualize the perimeter of the VSD and the RVOT, and this is facilitated by placing a small coronary sucker into the RVOT and retracting posteriorly. One then can perform with this transatrial exposure as shown on the picture up top by taking care to stay parallel to the aortic annulus and to resect trabeculated muscle bundles, being aware of solid muscle so as to avoid perforating to the RV free wall or even worse to the left ventricle. That has not happened in our experience, but it is possible. One must visualize the pulmonary valve, and that ensures that the RVOT has been relieved of obstructing muscle bundles. The resulting RVOT size can be measured with Heger dilators, as is shown here, with a Heger entering through the tricuspid valve and exiting, as you see here, from the pulmonary incision. The VSD can be closed transatrially with interrupted pledgeted sutures, which are placed on tricuspid valve tissue only in the area of the anteroseptal commissure to protect the conduction. We then have 2 transition areas to the ventricular infundibular fold superiorly, staying close to the aortic valve annulus and inferiorly at a point near the coronary sinus. Then the patch, which is usually Dacron, is measured, the sutures are passed, the patch is seated, we avoid chordal entrapment, and the sutures are tied. We need to take care of the tricuspid valve. The leaflets are carefully unfurled. We may need some sutures to close the anteroseptal commissure, which can be splayed somewhat open by the VSD patch in this area. We confirm the adequacy of tricuspid valve function by saline insufflation, and then turn our attention to the transpulmonary approach. A longitudinal incision is made on the main pulmonary artery. The branch PA size is confirmed with Heger dilators, and the pulmonary valve is inspected. Pulmonary valve commissurotomies are performed. If needed, additional muscle bundle resection is performed via this approach, and we measure the resultant diameter of the RVOT and pulmonary annulus, with the goal being mean normal plus a couple of millimeters. If necessary, the incision can be extended as dictated by infundibular and annular hypoplasia for a few millimeters across the pulmonary valve annulus, and the resulting size is confirmed with Heger dilators. There are important tips to consider. Many of these shown here are from the 1980 publication of Dr. Kawashima. You can go over them, but in essence, if the commissure of a tricuspid valve is anteriorly, it is safe to enlarge the annulus by an anterior incision without much damage to valve function. If the commissures are arranged horizontally, then one may have to incise the valve and either augment it or perhaps consider placing a monocusp valve. The monocusp valve is, we have found, is quite useful. These are illustrations on how to do it from 2 more recent publications. Early on, we used autologous pericardium. More recently, we have been using thin-walled Gore-Tex membrane with very good results. So the functioning monocusp valve limits pulmonary insufficiency and is particularly helpful in the early postoperative period, although eventually, of course, a monocusp valve will not function very well, but it will not become obstructive. Branch pulmonary arteries are reconstructed as necessary. The MPA incision can be extended onto the branches to repair usually a left pulmonary artery stenosis, but occasionally there is RPA stenosis as well. Typically, we use a reverse D-shaped untreated autologous pericardial patch to repair the MPA. Of course, if the pulmonary valve annulus is being divided, the same patch serves as a mini transannular patch. If both the right and the left pulmonary artery have needed repair, it is advised to use separate pericardial patches. As mentioned earlier, the presence of an anomalous LAD precludes a repair with a large transannular patch, but with this technique of transatrial transpulmonary repair, the infundibulum can be cored transatrially and transpulmonary, then, if necessary, the pulmonary valve annulus can be divided by the oblique incision shown here and patched as the LAD course is parallel, not exactly parallel, but rather obliquely, and therefore the obstruction can be relieved, and it is therefore possible to avoid using a conduit. Once everything is done, then the patient is warmed, the ASD is closed, the airing is performed, and the aortic cross clamp is removed. The atriotomy can be closed as well as completion of the work on the pulmonary arteries with the beating heart. A and V temporary pacing wires are placed. We routinely use a peritoneal dialysis catheter and ensure very good mediastinal and pleural drainage. Cardiopulmonary bypass weaning is generally very easy. We avoid using inotropes and overfilling, ensure AV synchrony. We use transesophageal echo to assess repair, and on occasion we would measure right ventricular pressure directly, typically we get 50% systemic RV pressure. Regarding results, our own experience at Athens Heart Surgery Institute, after establishment of our program in 1997, on the 5-year mark, we had almost 100 patients with classical tetralogy, which included 10 patients with prior shunts. We had shunted one of these patients initially, and everyone had transatrial transpulmonary repair with no mortality. By 2012, we had a series of 245 consecutive patients with 6.5% prior shunts, 6.5% new shunts, with 213 of those having had direct transatrial transpulmonary primary repair, again with no mortality, and interestingly, at about 15 years, our reoperation rate for pulmonary valve replacement was about 10%. Now, at about the same time, an EXA database study on the results of reparative surgery for tetralogy of Fallot, published in the European Journal, showed that about 20% or slightly less of tetralogy repairs recorded in the database were transatrial transpulmonary repairs, and mortality was low. It was 1.5%. It was a little higher with the traditional right ventricular approach. Now, regarding new techniques to optimize pulmonary valve function, we should mention the pioneering efforts of the Padova group with Giovanni Stellin and Vladimir Ovida who described leaflet delamination, balloon dilatation of the pulmonary valve, and therefore these could result in better pulmonary valve function with not much violation of the annulus, perhaps using a mini transannular patch. Now, the data as to how effective these innovative approaches are to limit reoperations of the pulmonary valve is not all in, but I think longer observation will demonstrate their utility and perhaps which patient subgroups these patients will benefit from such innovative techniques. So the essentials of the transatrial transpulmonary repair technique are that it respects right ventricular integrity. There is no or a very minimal ventriculotomy, just incising the pulmonary valve annulus with the incision limited to the more distal infundibulum, just a few millimeters from the pulmonary valve annulus. This technique also maximally preserves the pulmonary valve function with a precise valvotomy, leaflet release and thinning, minimal transannular incision, and may be combined, as I mentioned, with the newer techniques of balloon dilatation, delamination, and resuspension of pulmonary valve leaflets. As I showed in the operative photograph in the previous slide, when you complete such an operation, there is no incision on the right ventricular free wall, and I think this is an important component of contributing to the good early and late results. So, in conclusion, dear colleagues, most patients with classical tetralogy of Fallot with pulmonary stenosis can undergo one-stage primary repair in early infancy by the transatrial transpulmonary repair technique. And by early infancy, we, in our practice, mean approximately 6 months of age. For symptomatic neonates, we prefer to offer palliation with shunting. We would also palliate very young infants who have relative contraindications to primary repair, such as the anomalous LAD originating from the RCA or possible other comorbidities. The transatrial transpulmonary repair, respecting the integrity of the right ventricle and as much as possible the function of the pulmonary valve, is associated with excellent early and late outcome in our experience and in many series from around the world. I thank you very much, and again, I wish you great success at this historic meeting and very, very enjoyable times with so many good friends and colleagues from around the world. Thank you again for your attention.
Thank you, George, for this high-class, comprehensive lecture on tetralogy of Fallot. Unfortunately, time is killing us, so we have time for only one question. Is any question from the floor? It's not online. All right, so there are no questions. All right, so we proceed to the next presentation.
Thank you. So next presentation will be on TOF with absent pulmonary valve, including severe airway obstruction. And I'm calling Dr. Jeffrey Jacobs from USA.
Well, good morning, everybody. It's just absolutely wonderful to be here in Marrakesh. It's a pleasure to have the opportunity to participate in this great meeting. The turnout's fantastic. And I would like to thank the local hosts and the organizers. My topic today is to talk about tetralogy of Fallot with absent pulmonary valve and to also mention airway obstruction. Before I start, again, I would like to thank Drisi and all of our colleagues from Marrakesh. My family was lucky enough to get out to Morocco a few days early and see some of the beautiful sights in this absolutely amazing country. The food is great, the sights are great, and the hospitality is wonderful, so thank you very much. As was shown a few talks earlier, this is the standard definition of tetralogy of Fallot used in the International Classification of Diseases and the International Pediatric and Congenital Cardiac Code. This definition also applies to patients with tetralogy absent pulmonary valve. They have the absent pulmonary valve part, but it starts that they all have this basic presentation of tetralogy, which is primarily caused by anterior superior deviation of the conal or outlet or infundibular septum. There's also the four main components as shown here: VSD, narrowing or atresia of the pulmonary artery, aortic override, and usually right ventricular hypertrophy. All these elements are also present in tetralogy with absent pulmonary valve, and they're all caused by anterior superior deviation of the infundibular septum. Now, this is the definition for TET absent pulmonary valve. It's all the parts with tetralogy, plus the ventricular arterial junction of the right ventricle with the pulmonary trunk features an atypical valve with either absent or rudimentary leaflets or cusps that do not coapt. So oftentimes the leaflets are there, it's just that they're tiny little leaflets. And in the usual form of TET with absent pulmonary valve, probably the primary problem of importance is the dilatation of the pulmonary trunk and central right and left branch pulmonary arteries. So here's a photograph that comes off the International Society for Nomenclature's Archiving Working Group website of a heart with tetralogy and absent pulmonary valve. In this heart, the right ventricle is opened, and we can see the right ventricular inlet and the outlet components with the aortic valve overriding the ventricular septal defect. We can also see that the infundibular septum or outlet septum is anteriorly malaligned, exposing the aortic valve. Now, here's another picture of a heart with tetralogy of Fallot and absent pulmonary valve, and this picture really shows the important features. So here, the right ventricular outflow tract is viewed from the front, and we can see the pulmonary valve with some very tiny rudimentary leaflets. The pulmonary valve consists of these rudimentary nodular valve tissue that fail to coapt, sometimes fail to move. And I think this is a really nice picture that shows this anatomy. This anatomy shows that the absent pulmonary valve has rudimentary leaflets and it can have varying degrees of stenosis and regurgitation. And this picture also shows important dilatation of the pulmonary trunk and the right and left branch pulmonary arteries, and we'll talk about that dilation more. And finally, this heart shows the common feature that there's no patent ductus arteriosus or patent arterial duct, and in this heart, the aortic arch is extending rightward. But this is what a morphologic specimen of TET absent pulmonary valve looks like. Now, this is a picture of an echocardiogram of the TET absent pulmonary valve, and the key features we can see here is the hugely dilated right and left branch pulmonary arteries. And this was a video that's just not going to play, but you can see there's dilated right and left branch pulmonary arteries and a regurgitant pulmonary valve. And here's now a labeled version. Again, you can see the RVOT labeled on the top, the pulmonary valve, and the right and left branch pulmonary arteries. And then now that's actually a video showing the to and fro flow through the diminutive pulmonary valve. And finally, here's a picture of a CT angiogram showing the same anatomy: dilated main pulmonary artery, right pulmonary artery, and left pulmonary artery. So TET absent pulmonary valve is a rare syndrome. It's only 3 to 6% of all patients with tetralogy. We queried the STS database over a 4-year analytic window of July 2015 to June 2019, looked at all forms of both tetralogy and pulmonary atresia. Highlighted in yellow on this slide is the various forms of tetralogy, including TET with pulmonary stenosis, AV canal, absent pulmonary valve, and pulmonary atresia VSD. And we can see that the rare forms are TET AV canal and TET absent pulmonary valve. The rarest is the TET absent pulmonary valve. If we do the math in the STS database during this 4-year analytic window, 330 out of 8,268 cases of tetralogy had TET absent pulmonary valve, so it's only 4% of all forms of tetralogy in the STS database. Besides being rare, it has the distinctive feature of airway obstruction, which can cause tracheo and bronchomalacia, and this is caused by the massive dilatation of the main pulmonary artery and the first and second order branches. And this tracheomalacia and bronchomalacia can be life-threatening in neonates. Nearly half the patients will present as infants with some form of respiratory distress, and some will present as neonates with severe respiratory distress that can necessitate not only urgent surgery, but oftentimes ECMO. The remainder of the patients will present later in life with minimal respiratory compromise, and they'll present with typical tetralogy presentation. The standard treatment for TET with absent pulmonary valve is a one-stage primary repair. In symptomatic patients, this usually needs to be done in a semi-urgent fashion, often in the neonatal period, whereas in asymptomatic patients, this can be done electively 3 to 6 months of age. Goals of surgery are to correct the tetralogy using techniques that were just displayed by Dr. Bleiweiss and Dr. Saris, and also to ideally reduce the size of the pulmonary arteries to decompress the airways and prevent further airway compression. There's a lot of ways that have been described, a lot of techniques that have been described to decompress the airways. Papers have been written about plicating and reducing the airways, plicating and reducing the branch pulmonary arteries, replacing the aneurysmal pulmonary arteries with a homograft, and even completely resecting the dilated pulmonary arteries and reconstructing them with homograft conduits. If we go to the Nomenclature Society, this is a list of all the different operations for TET with absent pulmonary valve in the International Pediatric and Congenital Cardiac Code. There's a variety of forms of reduction pulmonary arterioplasty that include excision and plication. And then there's a variety of modifiers in the code to describe the type of excision and plication that is performed. To talk about the surgical technique, I went through lots of articles and lots of literature, and I thought the best way to use the time I have is to focus on one surgical technique, which is the technique described by Victor Hraska. And Victor began describing this technique back in 2000, and there's a series of 5 publications between 2000 and 2010. And I'll use most of the time I have left to describe Victor Hraska's technique for repairing this lesion and a little bit about his results. So all these patients undergo a standard repair of tetralogy, which includes closing the VSD and alleviating right ventricular outflow tract obstructing muscles. Beyond that, the first step in fixing these dilated pulmonary arteries with the Hraska technique is to widely mobilize the aorta and pulmonary arteries, as is shown in this picture. Then the aorta is divided, and a piece of the aorta, a ring of the aorta, is resected, facilitating a Lecomte maneuver and placing the pulmonary arteries anterior to the aorta with a shorter aorta to sit posteriorly behind the pulmonary arteries. So here we can see now the Lecomte maneuver is performed. There's already a VSD patch in this picture, so the VSD has already been closed. Then after the Lecomte maneuver is performed, one can perform an anterior wall resection and a posterior wall plication, as is shown in this picture. So here in this drawing, the anterior wall of both the right and left branch pulmonary artery and the main pulmonary artery has been resected, and an incision and slight resection in the posterior wall is also going to be made. And then they can be closed, and in this example, they're closed over a Hagar dilator to assure the appropriate size of the newly created branch pulmonary arteries. Now, this is another technique that Hraska has described that he says is most applicable to the most symptomatic of neonates, where the right ventricular outflow tract is actually replaced either with a monocusp valve or with a short pulmonary homograft. I'll talk a little bit now about the results that Victor Hraska presented. And in his publication that was in the Seminars in Thoracic and Cardiovascular Surgery, he described 13 patients who underwent this technique over the time period of 1998 to 2007. 3 of these are newborns, 10 infants, median age 6.7 months, range 1 week to 10 months. 6 of these 13 patients were ventilator dependent before surgery, and 2 of the 13 had tracheostomy. So this is a 6 series of patients that have big problems from these big dilated pulmonary arteries. 8 patients in this series of 13, this was their primary operation as treatment for tetralogy of Fallot with absent pulmonary valve. 2 of these were newborns, 1 infant, and 4 of the patients had a combined anterior and posterior plication of the branch pulmonary arteries. 5 patients in this series actually were undergoing a second operation after having previously undergone repair of truncus, double outlet right ventricle, tetralogy, or a classical correction of tetralogy with absent pulmonary valve. The same technique that I just showed the pictures of was used on all of these patients. No patients died, and in this article he published a median follow-up of 4.1 years with a freedom of reoperation of 78%. 3 patients, one patient needed a valve conduit insertion 3 months after a neonatal repair, and 2 other patients had conduit placement. Most importantly, the respiratory symptoms disappeared or significantly reduced in all of the patients in this series. No patient was ventilator dependent after this series or required subsequent tracheostomy. And that's substantial because these patients were quite sick, and many of them went into surgery either on the ventilator or some with the trach. And at the latest follow-up, all of the patients are alive and doing well. So this, I think, it's a fairly aggressive operation for TET absent pulmonary valve, but it describes many of the most commonly utilized techniques today. And some of these techniques can also be applied even without the LeCompte maneuver. I'm going to finish discussing Dr. Hrosko's work by kind of stating his 6 conclusions about TET absent pulmonary valve from his substantial experience. Victor first says that controversy persists regarding the management of patients suffering from TET with absent pulmonary valve. Airway obstruction caused by the dilated pulmonary arteries is the determining factor in the mortality of symptomatic newborns. So airway obstruction is the main challenge. A number of surgical techniques, as we discussed, have been described for reducing the bronchial obstruction. The results of these techniques are variable, as I will show shortly. All of the strategies have focused on plication and reduction of the anterior or posterior wall of the normally positioned pulmonary arteries with or without pulmonary valve replacement. Hrosko describes this alternative technique of using a LeCompte maneuver to bring the pulmonary arteries anterior to the aorta and away from the trachea and bronchial tree. And he finally makes note that failure of treatment of any of these techniques can be expected in symptomatic patients where the pathology of the airways extends beyond the proximal pulmonary arteries. This is the last table of data I wanted to show. This is a table that has outcomes from the Society of Thoracic Surgeons Congenital Heart Surgery Database. Again, a 4-year analytic window of July 2015 to June 2019. And over these 4 years, this is the data of all patients who had surgery for any form of tetralogy in the STS database, representing about 90% of the tetralogy surgery done in the United States during this time period. So most strikingly, this yellow row shows 4 years worth of data in the United States for TET with absent pulmonary valve. In 4 years in the entire country, 208 patients underwent surgery for TET absent pulmonary valve. So about 50 a year in the United States. This represents 0.2% of the entire STS database. And I think the most important number of this talk is that 10.6% of these patients die before going home. So even in a recent era of time, 2015 to 2019, this is a lesion that's associated with a substantial mortality of 10 to 11%. And I think the techniques are evolving, but this lesion still remains a surgical challenge. I think that summarizes my presentation on TET absent pulmonary valve. I hope I got us a little bit more back on schedule. Happy to answer any questions. Again, thanks to our wonderful local hosts. Join us in February in Orlando for our meeting. And everybody remember the World Congress that I'll talk about soon. Thank you all very much.
Thank you, Dr. Jeffrey, for this beautiful presentation. And we open the floor to some questions. We have 7 minutes discussion. Would you please come to the mic and introduce yourself and ask your question?
Zohar Al-Halis, Riyadh, Saudi Arabia. Thank you very much, Jeff, for this presentation. I would just like to bring a little bit of a historical perspective about the management of the disease. Dr. Farouk Idris, who is a American surgeon, worked in Chicago from Lebanese origin, described a technique for palliation of this lesion because at that time the mortality was in the range of 30%. He actually interrupted the pulmonary artery completely and shunted the patients with a remarkable outcome. And at our hospital also, rather than doing the complete interruption, we palliated some of these patients by pulmonary artery banding. As you know, despite the fact that there is pulmonary stenosis, the pulmonary artery pressure remains high and pulsatile. And probably that's the reason why the pulmonary artery becomes dilated. So when you band the pulmonary artery and actually get rid of the pulsatile flow of the pulmonary pressure, the pulmonary artery gets to become smaller and the symptoms, the respiratory symptoms improve quite a bit. So these are two approaches to try and palliate the patient to reduce the mortality. Another comment is the fact that many of those patients will develop emphysema of the lung. And I think even if you do a successful repair and the emphysema remains there, without getting rid of the emphysema, the outcome is not good. So it's very important also to check the lungs for the emphysema. Thank you.
Yeah, well, thank you, Mr. President. I think those are important comments. Although I have no experience myself with either of those two techniques you described, I have read about them, and clearly they are effective techniques. And I think your point about emphysema is an important point. These lungs are not healthy lungs, and the patients who remain sick even after repair, it's because they have lung disease and abnormal airways, and that can be a real challenge.
Alexis Palacios from Mexico. Very nice presentation, Jeff. Thank you.
Thank you.
I have observed several times repairing this malformation that there's no really infundibulum, stenosis on the infundibulum, and most is localized on the valve, so on the annulus. So I have always wondered if how close the relation with the tetralogy of Fallot is. I don't know if this is a correct observation, or can you correct me and explain to me this?
Yeah, that's a great question. It's, in my entire lifetime, it's obviously been classified as a form of tetralogy, and it's grouped in all of the different nomenclature trees as TEDEPS, and pulmonary valve as a subtype of tetralogy. But there's important differences, obviously. And I wonder if somebody who's much smarter than me, that knows a lot about genetics, would be able to just tell us if this is genetically related in any way to tetralogy, or if it's a totally different disease, and we all name it with a misnomer. You're raising a good point. I don't know the answer, but I bet you the people who do are, people who spend their time studying DNA. Thank you.
Please.
Dr. Najam.
Jeff, great talk. So do you think reduction of the pulmonary arteries in the central or the accessible pulmonary arteries is key here? Because typically the reason for emphysema is obstruction or pulmonary artery compression of the bronchi when they lose the cartilage intrapulmonary. So it's way beyond actually our reach as surgeons. So it's more important to take away the pulsatility, and 100% of those patients, I believe, should be repaired with the implantation of a valve rather than a transanular or anything else, because this is where you can decrease the intrapulmonary pressure or pulsatility. That is, if you look at the cross-section of the alveoli or the vascular bundle, you'll see the pulmonary artery, pulmonary vein, and the bronchus in the same vascular bundle. And if you have pulsatility right out there next to the alveoli, this is where you compress the bronchus, and this is where you get the emphysema. And it is actually the biggest problem on those patients because they're intrinsic lung disease that is a resultant of the emphysema or air trapping from the pulsatility in the pulmonary artery itself.
Yeah, Hani, I think you're also raising a very important point here. I think placing a valve in these patients, either with a homograft or a monocusp or some type of a functional valve, is very important to protect the distal airways by protecting the distal pulmonary vasculature. So in my mind, that should be part of the operation. But I also think to ask what you said at the beginning of your question, to address that, I also do think it's important to reduce the size of the main and proximal branch pulmonary arteries. And the reason I think that's important is from what I've seen of those airways, doing bronchoscopy on those patients. And these are lessons I learned at Great Ormond Street. In my year there, we had several patients with TED absent pulmonary valve that were very sick, and a couple that even did go on ECMO. And on bronchoscopy, their carina and their proximal airways were crushed. They were fish mouthing and small. And from what I saw there, that tells me that that's an important part of it as well. So from what I understand about this disease, it's important to fix the pulsatility by putting in a pulmonary valve to protect the distal airways, but also to reduce the size of the proximal pulmonary arteries in order to protect the intrapericardial or central airway as well. I think both are important.
Marcelo, very short question because we're running short.
Yes, Jeff, congratulations. It's just a point about the technique. We consider that it's important not only to reduce the diameter, but to reduce the length of the pulmonary arteries, bringing them from the lung to the central part, resecting a part of it. We had the opportunity to do this in two recent cases. One of them successful, the other one unsuccessful. And the unsuccessful case, we had it was a neonate, it's a very large aneurysmatic pulmonary artery. What's your impression about doing the correction, the neonatal period, closing the VSD and putting a valve, or you prefer to only palliate this child?
I think that the patients that present as symptomatic neonates need to be repaired as neonates. And I think I have no experience with the technique you're describing, where they're being plicated longitudinally as well. But I've read about that technique, and clearly that's another way to do it. But I do think that in the neonatal setting, where a patient has horrible airway compromise, the best approach to solving that problem is to fix them by reducing one way or another the size of the pulmonary arteries and putting in a competent valve.
Thank you, Jeff. We are
Thank you.
concluding our
It's a great
session.
meeting.
And the next speaker, Diane Spicer, is actually introduced by Jeff Jacobs, which I would like to ask him to come back to the podium. And Jeff. You introduce it, Diane. Thank you. Thank you very much to everybody for the attention.
I have some slides I want to show to do this. So give me 1 second to find it. These are actually my most enjoyable slides for the meeting. No, those two are the same, so hopefully it's in here. Well, this is really one of the most important parts of our meeting. As many people know, there's a series of named lectures associated with the World Society. And these named lectures, along with the presidential address, are the highlights of each of our annual scientific meetings or every other year scientific meetings. And tremendous thought goes into choosing and selecting who gives each of these named lectures: the Castaneda lecture, the Jatine lecture, and the Van Praag lecture. A lot of thought, a lot of discussion, and the speakers who give these talks are carefully selected because of the tremendous contributions that they have made to the community of pediatric and congenital cardiac care. And that's why this now and the remainder of the named lectures are truly highlights of this meeting. And for me, it's really a big honor to have the chance to introduce Diane Spicer to present the 7th Stella and Richard Van Praag lecture. First, I'll say a little bit about this lecture. Stella and Richard Van Praag obviously are amongst the leaders, fathers, and mothers of the world of cardiac pathology and cardiac anatomy. And all of us benefit from the lessons that they have taught us in our profession. And this lecture was initially named the Stella Van Praag Lecture, and then eventually the name was modified to the Stella and Richard Van Praag Lecture. Many of our presidents have had important training in the lab of the Van Praags. And I know that when I first met Christo, one of the first things he told me was, you have to come with me to Boston one day. We have to spend a day in the lab with Stella and Richard. She's not going to be doing it this much more longer. And I flew up to Boston. And although I was trained at Great Ormond Street, I had a wonderful day with Christo and Stella in the lab. experiencing what anybody who's trained in Boston in that era got to experience. So although I wasn't there the whole time, I know how special it was, and I know what great teachers they were. This is a table from our publication of the first decade of the World Society, and in this table we list the people who have delivered all of the named lectures, and here's the list of names of people who have given the Stella and Richard Van Praagh Lecture. As I said before, first it was the Stella Van Praagh Lecture, and the first one was given by Richard. And then after Richard Van Praagh, then Bob Anderson, Jim Wilkinson, Vera Ayala, Gaetani Tiene, and our good friend, the late Paul Weinberg. All these people were the first 6 speakers of the now Stella and Richard Van Praagh Lecture. This is a picture of the first 2 speakers, best friends, Richard Van Praagh and Bob Anderson. Here they're finishing a discussion on the intricacies of various names for ventricular septal defects at one of the very first meetings of the International Nomenclature Society back in Toronto in 2001. And I spoke with Bob Anderson about this lecture because Diane is a protege of Bob Anderson. And Bob Anderson is sorry that he cannot attend this meeting. This is Bob raising a glass of wine to our meeting, to our society, and to Diane and the Van Praaghs. I want to tell everybody a little about Diane. I've been lucky enough to have worked with Diane for close to 2 decades now in Florida. And she is the future of all of the great work that is being done and has been done by the Van Praaghs, the Andersons, and many others. And as great professionals retire, people like Diane Spicer and Justin Treader will be carrying on their legacy. Diane initially trained as a pathologist assistant at the Children's Hospital of Pittsburgh. She's worked for over 40 years in the field of pediatric and fetal pathology with a special emphasis on autopsy, pathology, and congenital cardiac disease. She is the curator of the Van Meerup Congenital Heart Archive at University of Florida. She is the senior archivist for the Archiving Working Group, which is part of the International Society for Nomenclature of Pediatric and Congenital Heart Disease. This international society is currently publishing a global atlas of the nomenclature code, and Diane is a huge contributor to this, probably the most important contributor to this work. Diane is also a cardiac morphologist at Johns Hopkins All Children's Hospital, my former hospital. She's participated in many peer-reviewed publications, over 130 original scientific publications, 16 book chapters, and she's a highly sought-after speaker and really the future of giving these anatomy and morphology lectures. This is a picture of Bob Anderson with our chief of cardiology in Florida, Jay Fricker, and the late Professor Van Meerup, who died in 2021. Professor Van Meerup maintained and created this huge archive of cardiac specimens, a museum that's unable to be created today. And that Van Meerup Heart Archive at University of Florida is currently maintained and curated and used for teaching under the leadership of Diane Spicer. In 2021, we had the honor of having Professor Anderson give a talk in tribute to Professor Meerup with his children in the room shortly after he died. And Diane and Fricker were up there for this. And Diane continues to play a major role in preserving the legacy of Professor Van Meerup. I want to show a couple of pictures of her great work. Obviously, that's what she's going to be doing in her talk, but Diane's dissections are exquisite. When people need a picture that shows the anatomy of something related to the heart, Diane is the person to get this picture from. This is one of her dissections of a normal heart, and this is another one of those. There's an infinite amount of pictures that she has created like this that are in the Atlas of the Nomenclature Working Group. And finally, before I have Diane take the podium, I wanted to mention about her family. This is a picture of Diane with her husband, Scott, her son, Andrew, who I've known since he was a young boy. That's Andrew many years, Andrew's an adult now, but that's him many years ago on a fishing trip in St. Petersburg, Florida. Giovanni Stellan was actually on this fishing trip with us, and Bob Anderson's there. And I'm proud to say that I think that these cardiac meetings with fishing have had a profound influence on Diane's family, because and Bob Anderson helped with that, because this is not Diane's son now. His first redfish ever was caught on a fishing trip organized in St. Pete. Now in addition to his profession, he's also a fishing guide, and he's got his license, and he's a licensed fishing guide. So if anybody's down in Florida and wants to catch a big redfish like that, call Diane Spicer. She can prepare your cardiac specimens, and her son can take you fishing. Diane also enjoys some good wine, which is nice, so that after she does this cardiac specimens and you catch the fish, you can have some nice wine with Diane as well. It's really a pleasure to have Diane come and give this talk. It's a tribute and honor to Richard and Stella Van Praagh. My last slides come from Professor Anderson, because this is really all about standing on the legacy of others, and this is the legacy created by Richard and Stella Van Praagh. Isaac Newton said, "If I have seen further than others, it is by standing on the shoulders of giants." And Professor Anderson taught me that that actually comes from these stained glass windows in the south transept on the Chartres Cathedral that shows New Testament prophets standing on the shoulders of Old Testament prophets. And clearly Diane is now standing on the shoulders of Van Praaghs and Anderson and Van Mira and all of these other experts, as Diane and Justin lead us to the next decades of cardiac morphology. So it gives me great pleasure to introduce Diane Spicer to give the Van Praagh lecture.
Thank you, Jeff, for that great introduction. And thank you to the organizers of this important conference and inviting me to attend in Marrakesh. I don't see it. I have it still, but no, I have to go get it. They're called Morocco. Yes. Now, as I was saying, thank you so much for inviting me to this wonderful meeting, and thanks to Jeff and Christo for inviting me to do this very important lecture. So I am honored to give this lecture honoring the work of Stella and Richard Van Praagh. As I said, or as Jeff said, I was trained by Dr. Anderson, and although I never had the privilege of meeting either Stella or Richard Van Praagh, I was privy to their work throughout my entire career, and I got to share in many of the spirited debates that were had between Richard and Stella Van Praagh and Professor Anderson. And almost every day of my working life, I use an important concept that was put forth by Richard Van Praagh, notably the morphologic method. Over the years, there was constant debate between Professor Anderson and Richard Van Praagh, but that led us all to where we are today with the way we talk about congenital heart disease. Jeff mentioned my mentorship with Professor Van Mira, and I am honored to be taking care of his collection at the University of Florida. Another important mentor that I would like to mention is Enid Gilbert Barnes, who was my pathology mentor, who was the consummate pediatric and fetal pathologist I worked with for 20 years at Tampa General Hospital, doing those fetal and pediatric autopsies, and that's where I still do those cases today. In addition, I will mention that I'm currently working as a cardiac morphologist at the Johns Hopkins All Children's Hospital in St. Petersburg, Florida. Today, I was tasked with talking to you about tetralogy of Fallot, and I'm going to try and mention some of the many changes in concepts and some of those that are still evolving today with terminology and morphogenesis. Fallot was credited with emphasizing the coexistence of these four morphologic features that I have listed here, and I'm not going to mention them in the interest of time. What I've done is I've chosen an article that was published by Anderson, Becker, and Van Meerop in 1977 that will show us some of the evolution of the terms over time and involved in some of those spirited discussions. And in 1977, they published this paper with the purpose of suggesting uniformity. And I'll read a quote from the paper. "Achievement of such uniformity will be difficult, if not impossible." And as part of the International Nomenclature Group, I think that this is one of the goals that we're trying to achieve, is to get everyone on the same page when we talk about describing those cases or those patients with congenital heart disease. Let me back up. So some of the structures that I'm going to discuss with reference to hearts with outflow tract malformations are those muscle bundles that separate the two arterial valves, whatever ventricular origin these valves come from, the muscular structure separating an arterial valve from an atrioventricular valve, and that prominent septal trabeculation, which is one of the anatomic features of the morphologically right ventricle. So this is an illustration from that publication in 1977. And if we look at the encircled terms under number 1, the crista, the conal septum, infundibular septum, parietal band, and parietal band 1 were all terms used to describe this muscular structure that separates the two arterial valves. And if we note the yellow arrows, we'll also see that the term crista or crista supraventricularis was also associated or applied to 4 additional muscular structures within these hearts with outflow tract malformations. And it was Wolff in 1781 who described this structure as separating the tricuspid valve from the pulmonary valve in the normally developed right ventricle. And this structure is what I call the ventriculo-infundibular fold today, or the supraventricular crest. The conus, or the conal septum, is another term that was used by many different authors to describe parts of the developing heart, and in some circles, it is interchangeable with the term infundibulum, and it was Lev who initially suggested trading the term of conal septum with infundibulum. In the right side of the drawing, we see the left side of the heart, and you can also see that crista is mentioned here, and that is that muscle bundle that separates the arterial valve from the atrioventricular valve, and in the normally developed heart, this area will resorb and become the mitral to arterial valve fibrous continuity. So the last structure we're going to talk about is that septomarginal trabeculation, which that term has been now used widely as or transformed from trabecula septomarginalis, which is the Latin. So now we either call it the septal band or the septomarginal trabeculation. So I'm going to look at these structures first in a normal heart and then in a heart with tetralogy of Fallot. So we can see that prominent right ventricular trabeculation, which is a septomarginal trabeculation. It is described as being a Y-shaped structure with its cephalic arm and its caudal arm. The cephalic arm rises up to become part of the subpulmonary infundibulum, and the subpulmonary infundibulum joins with that muscle at the inner heart curvature or at the ventriculo-infundibular fold. And that septomarginal trabeculation being described as a Y-shaped structure, you can see where in normal development that supraventricular crest inserts between the limbs of the septomarginal trabeculation. And I will show you how these parts form morphologically in the embryo shortly. The medial papillary muscle arises from that caudal arm of the septomarginal trabeculation and in part supports the tricuspid valve. The moderator band and the anterior papillary muscle arise from the inferior aspect of the septomarginal trabeculation, and they're not shown here, secondary to the nature of the dissection. And then we can see, lastly, the septoparietal trabeculations arising from the parietal wall of that main trabeculation, which can cause additional issues with hearts that have tetralogy of Fallot. And also we need to mention the membranous septum, and the septum is made up of the muscular component and the membranous component. Jeff spoke about some of the great imagers that are coming up these days, and Justin Treader I've worked quite a bit with, and you can see that his image here is directly comparable to what we can see in the actual heart specimen, even with respect to the membranous septum. And I can't tell you how much I have learned in the past 5 to 7 years from working with these young imagers. This is now that same drawing with reference to the muscular structures we see in tetralogy of Fallot. So there is our body of our septomarginal trabeculation, the caudal arm and the cephalic arm, which rises up to become part or support the outflow septum, which is now a prominent right ventricular structure because of the developmental abnormalities. We can also see those septoparietal trabeculations, which are now hypertrophied and putting an extra squeeze on the already stenotic right ventricular outflow tract. This is the ventriculoinfundibular fold, which is that structure that separates the arterial valve from the atrioventricular valve. And in hearts with tetralogy of Fallot, this structure partly supports the aortic valve as it overrides the septum within the roof of the right ventricle. You can see between the brackets the extent of the subpulmonary infundibulum that is distal to that outflow septum, and this is actually a variable structure that we can see within hearts that have tetralogy of Fallot. In normal development, I was initially trained that there was a muscular outlet septum, a very small component above that Y of the septal band that was between the outflow tracts of the right and left ventricle. Well, it's now been shown through episcopic data sets that in the developing heart, that in normal development, it's not possible to recognize a muscular outlet septum. Embryonic septal structures are buried between the limbs of the septomarginal trabeculation, with this forming the muscular supraventricular crest. And when we have tetralogy of Fallot, these muscular structures are divorced from one another, which give us the phenotypic features of the defect. And you can see the supraventricular crest in this normal heart buried between the limbs of the septomarginal trabeculation. There's the inner heart curvature of the ventriculoinfundibular fold. And I've removed the right coronary aortic valvar sinus from the aortic root. And you can see the subpulmonary infundibulum and the muscle that was supporting that right coronary aortic valvar sinus. What I want you to appreciate is that fibrofatty plane between the subpulmonary infundibulum and the left ventricular outflow tract and the ventriculoinfundibular fold, so that normal development shows us that there is no small component of a muscular outlet septum in the normal heart. And here we see the membranous septum with its interventricular component and its atrioventricular component. And this, again, is a shout out to the imagers, and I actually prepared this dissection for Dr. Maury to match this image. And you can see how we can nicely compare normal hearts and congenitally malformed hearts with the new imaging techniques that are coming out. So when we look at some of the developmental considerations, the episcopic data sets are also part of the advances in imaging that we see today. And Professor Anderson has extensively studied many of these episcopic data sets within the mouse, and the images that I'm using today are used from his images, and he has given me permission to do so. So when the building blocks of the normal right ventricular outflow tract come apart during development, Inappropriate positioning occurs and can explain all of the morphologic features of tetralogy of Fallot. Some of those variable features are some things that I already mentioned, like the additional subpulmonary obstruction caused by the septoparietal trabeculations. The margins of the ventricular septal defect can be variable, as is the degree of aortic override entering into those variable features. Also, with tetralogy of Fallot, we must include any of the associated malformations in our description. So these are some of the morphologic developmental data sets that I'm going to show you. And initially, we all know that the inlets are committed to the left ventricle in the developing heart, while the outlets arise entirely from the developing right ventricle. And here, this image shows us the aortic root still committed to the right ventricle, and so that the only egress of blood out the arterial trunks, including the subaortic outlet, is through the embryonic interventricular communication. And this communication is between the crest of the developing muscular interventricular septum and that inner heart curvature, or that muscle bundle that in the developing heart still separates the arterial valve from the atrioventricular valve, and will eventually be resorbed to become the aortic or arterial to mitral valve fibrous continuity. This is a little later on the same day, and it's a roughly 4-chamber view. You can see that the aorta is being moved towards the left ventricle, and that this area is the previous interventricular communication within the embryo and will eventually become the left ventricular outflow tract. The red arrow marks the area where the proximal outflow cushions will fuse or insert between the limbs of the septomarginal trabeculation at the crest of the developing muscular ventricular septum, and will be the punitive line of ventricular septation. You can see that the interventricular septum is now fairly well developed, and if we increase that plane, you can see that it cuts the aortic root roughly in half. If we compare this image to a 4-chamber view of a heart that has tetralogy of Fallot, you can see that muscular interventricular septum. And again, if we increase the plane of that septum up through the aortic root, you can see that the aorta is committed a little greater than 50% to the left ventricle, and the remainder over the septum, overriding the septum, and committed to the right ventricle. The black double-headed arrow shows us the left ventricular outflow tract, which was initially the embryonic interventricular communication. And the red arrow is the area where the surgeon will place his patch to effectively put the aorta back into the left ventricle. This is a little later on in the same day, and now you can see that the aorta is totally committed to the left ventricle, and the initial interventricular communication is now forming the left ventricular outflow tract. This is the area where the tubercles of the atrioventricular cushions will fuse to eventually wall the aorta completely into the left ventricle, and this area will form what is the membranous septum. This is the same heart, but rotated to look at a long axis close-up view of the right ventricular outflow tract in the developing mouse. And here we can see the muscularizing proximal outflow cushions forming the subpulmonary outflow tract, or the right ventricular outflow tract, and that shelf that will wall the aorta into the left ventricle. At this stage, the trabeculations are coalescing to form the papillary muscles, the septomarginal trabeculation, and those septoparietal trabeculations. Here we the tubercles of the atrioventricular cushions that are fusing to eventually place the aorta totally into the left ventricle and form the membranous septum. This is a heart at the end of the embryonic period that shows us the divorce of those muscular structures and the phenotypic features of tetralogy of Fallot. So we can see the septomarginal trabeculation, and there's the outlet septum, which is now a prominent right ventricular structure, and it's deviated in anterior superior position, so that this proximal outflow cushion failed to insert between the limbs of the septomarginal trabeculation to form normal septation, and we end up with a ventricular septal defect in this area that extends between the limbs of the septomarginal trabeculation and is termed as an outlet defect. This is the ventricular-infundibular fold, or that muscle bundle I talked about that separates the tricuspid valve from the aortic valve, and also in hearts with tetralogy of Fallot will in part support the aortic root within the roof of, or the overriding component of the aortic root within the right ventricle. And there are septoparietal trabeculations that will also cause a little bit of havoc in those hearts that have tetralogy of Fallot with additional stenosis of the right ventricular outflow tract. So knowledge of developmental concepts allows for clarification of terms related to aortic overriding and ventricular septal defects. So within normal septation, the right aortic valvar sinus overrides the interventricular septum, with the leaflets of that aortic valve exclusively supported within the left ventricle. Aortic overriding can only be found with deficient ventricular septation, and when you have that deficient ventricular septation, the aorta has a biventricular connection. And these defects with an overriding aorta are extending to the outlet of the right ventricle. There's also been a lot of controversy over the years with the terminology associated with ventricular septal defects, and it was Peacock in the early 19th century who described the so-called membranous defect that was a consequence of deficiency of the muscular septation that formed the borders of the hole between the ventricles. And this concept was actually what led to the accepted term of perimembranous ventricular septal defect today. We all know that we can have perimembranous, muscular, and doubly committed and juxta-arterial ventricular septal defects, and these defects can open to different parts of the right ventricle and can have different borders and different geography. The point I would like to impress upon you all that the borders are the most important descriptive component of the ventricular septal defect, because this will allow the surgeon to know the proximity of the conduction tissues relative to the borders of that defect. The geography will also add additional information for the surgical repair. Defects opening to the outlet of the right ventricle usually have malalignment of the muscular outlet septum, and those defects, including tetralogy of Fallot and the Eisenmenger defect, have that malalignment in the cranial direction, which makes that outlet septum an exclusively right ventricular structure. This malalignment defect also allows for overriding of the aorta. Now, I'd like to review between two different hearts that have tetralogy of Fallot, some of the variations in the anatomy and some of the variations associated with those muscle bundles that I mentioned earlier. So here we see the outlet septum within both specimens. The left specimen is a very diminutive structure, while as in the right specimen, it's very prominent within the right ventricular outflow tract, both of which are deviated in anterior superior direction. The ventriculo-infundibular fold also is diminutive in the left-hand image and very prominent in the right-hand image. I'd like to point out the fibrofatty tissue plane between the subpulmonary muscular infundibulum and the prominent outlet septum in the right-hand image. So the degree of subpulmonary infundibulum is also a variable structure. Here we can see the septomarginal trabeculation with the cephalic arm rising up to join the outlet septum, as it is a prominent right ventricular structure. And there's the caudal arm in the left-hand image, which does not reach the ventricular infundibular fold. And we can see that this defect is rendered as a perimembranous defect with fibrous continuity between the tricuspid valve and the mitral valve along the posterior inferior border. And these are the defects that are most at risk for damage to the conduction tissue at surgical repair. In the right-hand image, you can see a very prominent caudal arm to the septomarginal trabeculation, which joins the ventriculo-infundibular fold and forms that posterior muscular bar, which is protective of the conduction tissue. And there's other variation associated with the aortic root, and in the left image, we can see aorta to mitral fibrous continuity, while in the right-hand image, the aortic valve is supported within the left ventricle by a complete muscular infundibulum. We would be remiss if we didn't mention that the outlet septum can be both a muscular and a fibrous structure, and this shows a juxta-arterial ventricular septal defect that is in subarterial position. Here we can see the septoparietal trabeculations, the septal marginal trabeculation with its caudal arm rising up to support the subpulmonary infundibulum and the fibrous outlet septum, and the caudal arm which does not reach the ventricular infundibular fold. And again, we have a perimembranous ventricular septal defect, which in hearts that have tetralogy of Fallot, this defect occurs in 4/5 of those patients. This patient also has fibrous continuity between the mitral and the aortic valve within the roof of the left ventricle. I have an image here that we found going through Professor Van Merop's things as we were writing an article memorializing him. And he was a wonderful cardiac illustrator. And you can see here that he shows us a fibrous outlet septum with an overriding aorta and a stenotic pulmonary valve. And he, interestingly enough, called this a truncal tet. So this is just another shout out to the imagers. I don't even need to label these images, as we can all compare them with one another and see the anatomy very clearly between the heart with tetralogy of Fallot and the specimen and the images. We can even see that caudal arm of the septomarginal trabeculation joining the ventricular infundibular fold along the posterior inferior aspect. And these images were provided by Justin Tretter. Nowadays, imaging has become an important part of diagnosis and preparation for surgical repair, and we can all see the anatomy, both normal and in congenitally malformed hearts, very nicely and with great detail. The imaging that has been created with reference to the episcopic data sets have changed the way we look at the developing heart and have led us away from armchair or speculative embryology to knowing what the real thing is. And I would just like to say that in the past, morphologic studies have been done using the actual specimens and are maybe becoming a thing of the past with the new imaging that's taking place. But to me, it's very interesting how we can directly compare these images with our specimens. And those old specimens of tetralogy of Fallot should be guarded because we don't get those unrepaired specimens or even repaired specimens today because of the great surgical repairs that is performed by most people in this room. Thank you so much for your attention and for inviting me to the meeting, and go Gators.
Well, thank you very much, Diane. You can use words like few of us can, and that was a very impressive talk. And the entire World Society is grateful for you coming and teaching us what you taught us, and we look forward to multiple collaborations in the future. Our final talk before lunch is maybe the most important talk of all, because we've talked a lot of science. We've talked about anatomy, morphology, echocardiography, angiography, various surgical techniques. But the real reason we're obviously all here is to be able to use all the science to take care of patients. And our last talk today, we're going to have a patient talk to us and provide a little bit of patient perspective about life with tetralogy of Fallot. And our speaker comes all the way from Washington, D.C. Her name is Chloe Searchinger, and Chloe is going to come and tell us a little bit about life with tetralogy, the patient's perspective. And like I said, this is the most important part about what we do, because we're all here to do this to take care of our patients. So join me in welcoming Chloe.
I do, yes, just like some short slides, but I'm not sure.
We'll
Just some
have to put-
pictures. I have them first one. Yes. Thank you so much. Thank you, of course. Right here. Just like that. Okay. Good afternoon. My name is Chloe Searchinger, and I am a 21-year-old university student from Washington, D.C. Tomorrow, I will present proposed research with Children's National Hospital investigating the quality of life of children, adolescents, and young adults living with corrected congenital heart defects in Uganda. Some of you may be wondering why and how I came to be interested in this topic, and the answer is that my connection is personal. I myself was born with tetralogy of Fallot, and today it is my honor to speak to you about my experience growing up and living with what I always called as a child a fixed hole in my heart. Truth be told, the irony in my presenting here is that I am one of the few fortunate people in the world born with a congenital heart defect to not really have had to think much about it. My dad always tells the story of how, at 3 days old, having detected a murmur in my heart, my panicked parents were told by my cardiologist, Dr. Sable, who was supposed to be in the audience today but unfortunately couldn't make it, that the issue with my heart was, quote, fixable but serious. Looking back at my records, more technically, I was diagnosed with a case of pink tetralogy of Fallot. Dr. Sable reassured my parents that surgery for this condition had been successful since the 1970s. The echo on this slide shows valvular pulmonary stenosis and single ventricular septal defect. Advised to consider elective surgery, in March of 2001, at 6.5 months old, I had my first open heart surgery to successfully close the ventricular septal defect, or patch the hole, and remove extra muscle from underneath my pulmonary valve. With mild leakage of my tricuspid and pulmonary valves, I was discharged, and my parents carried me home within 1 week of surgery. And for the next 17 years, covered with a cloth patch is how I understood this hole in my heart. From what I can recall, I've never presented any symptoms of tetralogy of Fallot. Although diagnosed with a heart defect, my condition is mild on the spectrum of defects. I once had an echo technician tell me, I always say that if I had to pick a heart defect, I'd pick tetralogy of Fallot. I grew up incredibly active, doing gymnastics, competing in capture the flag in elementary school, playing competitive soccer through middle school, and even qualifying for track and field nationals as a short distance sprinter in high school. For most of my life, my experience with tetralogy of Fallot consisted of minor details. Stories about my surgery as a baby from my parents, annual visits to Children's National to see Dr. Sable, where I would dread the sticky gel spread on my chest for echoes and having to rip off the many stickers on my torso for EKGs. And of course, people's questions about my scar, or my zipper. The funny thing about having a scar in the center of your chest is that for the most part, you don't see it. I would have to be tilting my head down to notice it. It's other people who see it. At the pool or changing with friends as a child, when other kids asked about my scar, I would proudly state that I had heart surgery as a baby, pointing to the pale white line as a badge of honor. When they would ask what that meant, I would tell them that if I hadn't had surgery, I probably wouldn't live that long past my teenage years and that I wouldn't be able to play tag on the playground. It wasn't until I was a freshman in high school that I ever felt self-conscious about it. I acutely remember trying on dresses for a homecoming dance with my mom, already in a mood due to the usual anxieties that high school girls often feel, and staring into the mirror of the dressing room at the reflection of my scar in a low-cut dress. In hindsight, it was barely anything, a thin, faded line peeking over the top of my dress. But in that moment, I hated it. I yelled at my mom, erupted into tears, and refused to try on or buy a dress that showed my scar. While I eventually moved on from my early teen breakdown, I remember this moment because it marked what was the beginning of me thinking about my heart more seriously. In freshman year biology, I recognized the condition tetralogy of Fallot in a text box describing blue baby syndrome. The next 3 years, during my annual cardiology checkups, I began to ask more questions. What was actually wrong with my heart? Would it ever affect me later in life? Would I live as long as others in my generation could expect to? In response, I was told that, for the most part, we're not really sure. Advancements in surgical techniques to ensure widespread successful repair, especially in babies under 1 year of age, were innovated not many years before I was born. Many adults living with repair tetralogy of Fallot are themselves my age or a decade or two older. The data needed to answer these questions are still emerging, with me in it. I was told that there was a chance I might need to have a second or follow-up procedure as I got older. I was told that my heart might need to be considered one day if I wanted to have children. Yet while these discussions slowly brought to my attention the idea that I would be a lifelong patient, somewhat in the dark about whether or what limitations my life might eventually have, I still felt untouched. My life was completely normal. As I said, I participated in sports every day after school. I stayed up late studying. I went to parties with my friends. That's why I was completely shocked when, in November 2017 of my senior year of high school, days after I'd submitted my college applications, my parents sat me down to tell me that I would need to have open heart surgery in January. What? I stammered. Why? After some tears, I learned that the latest MRI from the summer had found that, as is relatively common, regurgitation from my pulmonary valve had led to dangerous enlargement of my right ventricle. But over the following weeks, as I learned about the details of the surgery, the cutting of the sternum, the heart and lung machine, I felt surprisingly zen about it all. Coming back to the same hospital that I had gone to as a baby, that I had been to once or twice a year throughout my entire life, I trusted that my surgery would go well. What remained unsettling, however, was coming to terms with the reality that my heart condition was more serious than I'd ever thought. What I imagined to be a universal experience, there I was, a seemingly perfectly healthy person, being told that I was actually not that healthy. For the first time, I felt scared about the unexpected, unknown feature of my heart condition. My memories from my successful surgery in January 2018 are blurry but ultimately pleasant. I remember driving in the snow to the hospital at 5 a.m. I remember smiling for this picture with my parents waiting to go into the operating room. I remember counting down while being placed under anesthesia, waking up in the ICU moments later, the pain of being forced to walk a few steps, and mainly sleeping and watching animated movies in my recovery room. Less than a week later, I returned home with a new bright red scar just next to my old one. I was back in school in less than a month. 3 years into college, still with a bright red scar that often peeks over my clothing, when people ask me about its origin and I tell them about my surgery, they usually express awe, as if I've been through something painful or traumatic. But the truth is, I still feel untouched by my condition. In the grand scheme of medical or health procedures, my surgery passed seamlessly, thanks to the skill of my second surgeon, Dr. Jonas, who is in the audience today and who I only had to meet with twice given the success of my operation. I was back on my feet at track practice within 3 weeks of being driven to the hospital. I've transitioned to an adult congenital heart team since then and have checkups once a year. And so far, so good. My stress test from my most recent appointment in March showed my oxygen consumption rate to be in the 93rd percentile range for those my age. I completed an ultramarathon last fall, running and walking a total of 50 miles in 24 hours, and I plan to participate again this fall. While I know that I may need another procedure depending on the progress of my heart, depending on the durability of my bovine pulmonary valve, I have come to terms with the relative unknown surrounding my heart and my life as I grow up. The most profound impact from my experience with tetralogy of Fallot has by far been on my life perspective. The accident of my birth in the United States with health insurance, in a city with an incredible pediatric hospital, a first-rate medical team, nurses, cardiologists, and surgeons has left me immensely grateful. I quite literally would not be here if it weren't for individuals willing to dedicate their lives to medicine, and in my case, the field of cardiology. But even beyond being alive, my remarkable quality of life shows just how much this field continues to progress. There is not one choice I have made in my 21 years where I've had to consider my heart condition. And though I know that there are unforeseen repairs or limitations that may present themselves, I have faith that there will be continued advancements in cardiology and cardiac surgery that will allow me to continue living the way that I want to. In fact, if I do need a follow-up repair of my bovine valve and investigate ways to increase access to the more than 3 million children born with congenital heart defects and their parents, most of whom lack any treatment options, those around the world born into completely different contexts, but ultimately in positions just like the one my family was in. On Monday, I will be traveling to Uganda for 3 weeks to meet with patients and research the quality of life of children and young adults with congenital heart defects in resource-constrained settings. In collaboration with the Uganda Heart Institute, our team's aim is to apply their experiences towards the design of sustainable interventions and follow-up care to address unmet needs that stand in the way of a high health-related quality of life. About a year ago, I noticed that my scar was beginning to fade, and to my surprise, my feeling was sadness. While I'll still have moments like the one I had in the dressing room with my mom at 14, I'm incredibly proud of my scar. Just last month, a fellow college student who I'm friendly with came up to me and told me, "I have a zipper too." When I do look down at it, it's a reminder to me of just how extraordinary it is that I can live my life the way I do, and a reminder to make the most of it. I'd like to thank all of you for the work and dedication that you've committed to making it possible, and I hope to do my very best to contribute. And thank you so much for listening to me today.
Thank you very much, everyone, especially for Chloe for this touchable presentation.
Yeah, Chloe, that was phenomenal. The whole room is inspired, and to be able to stand up and talk like that is truly impressive to all of us. So thank you.
Thank you.
We will just reconvene at 2 o'clock after lunch. That's it. Thank you very much for your attention.
Thank you very much. La recepção ela começa até daqui. Ainda deverá ter ensinado a gente, mas lá para informação sobre a pedagogia. Estou aí, legal.
Testing, testing. There we go. Okay. Well, welcome everyone to the afternoon session. I'm sure everyone was very enthralled with this morning's talks about tetralogy, and we're going to continue that theme. We're running a little late, but we will try to catch up so that we can get done in time for the editorial board meeting. My name is Carl Backer. I'm from Cincinnati and Lexington in the United States. I have the honor of being the new editor-in-chief. So for those of you who haven't met me, please come up and say hello so I get to know everyone. It's my pleasure to introduce our first speaker, Dr. Pedro Becker. Pedro, do you want to come up? Pedro is the director of cardiac surgery in Chile and has been for many years, and he's going to kick us off with his experience with tetralogy of flow. Pedro?
Well, thank you for the organizers to have our paper presented here. I will ask for some help to bring up the presentation. Are they coming? Yes. Oh, this one. That one, yeah. Can you put it on presentation? Okay, so this is the title of our paper. I want to point out that the second and third authors are our medical students that I hope that they're watching the presentation on the streaming. These are the pioneers of congenital heart surgery that made possible survival and well-being of many children around the world, from palliative procedures to open heart surgery, primary repair, or the so-called new philosophy of cardiac surgery. So I think they represent the history of surgical treatment of tetralogy of Fallot and the history of surgery of congenital heart disease. So my tribute to them, which introduced our paper. Our group reported the first series of early primary repair in Chile in the early 90s, but there's still controversies regarding the ideal age of repair, the surgical approach, and more recently, the use of percutaneous palliative procedures, many of them very much pushed by the interventional cardiologist group. And there's also been attempts to maximize the preservation of the pulmonary valve. And the question is, will they decrease the need for reintervention or better preserve the RV function? So our objective was to investigate the early and late results of tetralogy of Fallot treatment with the most, I would say, the most common techniques and with the longest follow-up during the last 30 years, so they may serve as a reference against new options. Patients with tetralogy of Fallot were searched in our cardiac surgery database from January 1990 to December 2020. Exclusions were pulmonary atresia, AV canal, and absent pulmonary valve. We made a revision of their clinical, operative, and cath records. We applied a survey to investigate their functional capacity and use of medications. Mortality was searched through the National Civil Registry, and reinterventions were searched through the clinical records of our own institution and a search at the Thorax National Institute, which is the reference centers for patients turning 15 years of age that belong to the public health system. I'm going to skip this. I'm going to show you briefly what is, I would say, our way of working. And as it was mentioned this morning, most of it's related to the way that we were trained. Primary repair is that what we do unless there is a contraindication. Newborn intervention only if symptomatic. If there's no or mild symptoms, surgery is scheduled before the age of 6 months. Our preferred approach is via an infundibulotomy, one linear incision with minimal muscle resection to close the VSD and enlarge the right ventricular outflow tract. Whenever pulmonary valvuloplasty is performed, it's consisted only on commissurotomies and dilating of the or calibrating the annulus. Our threshold to use a transannual patch was the pulmonary C value or a residual gradient greater than 30 or 35 millimeters of mercury. We always leave a PFO open or small ASD. The transatrial approach was done only if there was a coronary anomaly that precluded an incision on the infundibulum, or there was a minimal right ventricular outflow tract. Follow-up is forever, and pulmonary valve replacement indications are based on symptoms and or MRI findings. The series is of 217 patients with a median age of 5 months at time of first surgery. There are the comorbidities, being the majority Down syndrome. This graph bar demonstrated the age at first procedure being the majority before the age of 6 months. 91% of patients have a primary repair, and those with a palliative procedure represented by 15 patients with modified BT shunts, and more recently stenting of the right ventricular outflow tract. There's a distribution of our surgical approach for primary repair. Newborns represented only 4%, as I mentioned, only if they were symptomatic, and there was most even palliative versus primary repair with no mortality. Early or operative mortality was only one patient that belongs to the first decade of the experience where ECMO wasn't available. Probably that would be an avoidable death nowadays. And a total mortality of 8 patients, which comes to 3.7%. There you can read the causes of death according to their official death certificate. Reinterventions were frequent in almost a third of patients, and there you can see the distribution, the majority of them having one reintervention. These are the most frequent reinterventions, being the pulmonary valve replacement, the most frequent one, which includes 7 percutaneous valves, followed by need of transannular patch or cath angioplasty or enlargement of the RVOT. Of note is that only one patient required a defibrillator, and only one patient so far required a pacemaker. 96% survival at 30 years. There was no difference in survival comparing palliative or primary repair approach, but there was no difference in survival comparing those patients with or without a transannular patch, but there is a difference in terms of need of reintervention when you compare patients with or without a transannular patch, being the pulmonary valve replacement the more frequent one, as you can see there. Although it's interesting to see that even patients without a transannular patch, they may need later on a valve replacement. The search of patients, we found 65% responses, and almost 25% were taking some medications, being the majority aspirin, mostly due to the presence of a biologic valve. And finally, this is the functional capacity, being the great majority in functional capacity 1 or 2. So this, the limitations is obviously a retrospective study that could be some missing data. This study was not designed to compare different strategies. Functional capacity may be misevaluated. Best way would be an exercise testing with oxygen consumption. And reintervention could be underrepresented, but survival is accurate because it's searched at the National Civil Registry. So finally, my conclusions and a final comment. Treatment of tetralogy FLO with pulmonary stenosis with or without preservation of the pulmonary valve allows a 96% survival at 30 years in a middle-income country in an average surgical program and with an average surgeons as me. Most patients remain in functional capacity 1 or 2. Rhythm disturbances were not frequent in this series. Reinterventions were necessary in almost a third of patients, especially among those where a transannular patch was used. Catheter-based procedures are a frequent component of the armamentarium. Our findings coincide with other series, as for instance, the STS database and the European database, and may serve as a basis of comparison against other strategies, like expanding the limits of pulmonary valve preservation, or moving back to palliation with percutaneous procedures. And my final comment is that the need, rather than the use, of a transannular patch may be an indicator of worse anatomy or severity that may not be overcome, pushing the limits of pulmonary valve preservation, but this needs to be proven. Thank you very much for your attention. Mics are not working.
Oh, thank you, Pedro. First, I'll say I don't think you're just an average surgeon. And Dr. Huddleston would be very proud of you. Anyway, do we have any questions from the floor? While people are thinking, I was going to ask you, have you changed the percentage of patients that have transannular patch over the years, or has it remained relatively constant? In other words, have you made more, everyone is focused more on preserving the pulmonary valve if possible. Give us your thoughts on that.
Yeah, I would think that it has been changed a bit since, I would say, the first decade and the third decade. As it was mentioned this morning, when Miguel Navarro, that was the surgeon that started the program in Catholic University and trained with Aldo Castañeda and Richard Jonas, probably he brought the idea of large transannular patches to avoid any residual gradient. Over time, we learned that it was better some gradient without pulmonary valve insufficiency. But although I would have to say that in general, we wouldn't tolerate a gradient greater than 35 or 30, and we will prefer to do a transannular patch. And I think that, in Chile, the coverage for cardiac surgery is pretty high. So, and you can see that the majority of patients are operated on very early. I think that maybe some series that there is some not very well coverage, and you're kind of seeing the survivors. Most of those patients probably had the worst anatomy, so sometimes those patients will not come to surgery, and your rate of transannular patch need will be less, I think. But anyhow.
Dr. Najam, quick question to get us back on time. Go ahead.
I just wanted to say a comment. We had this conversation this morning about really the transannular versus the RV health. I think the idea of cutting the annulus or not is much bigger question. I think more important that we don't kill the RV to take all the RV muscle bundle obstruction and have such a huge dyskinetic infundibulum or a patch just to preserve an annulus of a valve that is never going to work anyway, because you know you're going to replace it. And the biggest example is actually our patient who presented this morning. She was a pink tetralogy, and she still needed a pulmonary valve in her teenagers. And that is a classic. I do what was called valve-sparing tetralogy repair, pulmonary valve implantation. Many times I've done it, and all of you have done it, I'm sure. So these valves are malformed. I think more important than the tetralogy repair is to preserve the RV function rather than just preserve that annulus of the pulmonary valve. And that's where the balance between how much you cut on the RV versus muscle resection and leaving the annulus comes in an important question.
Agree.
Okay, thank you very much, Dr. Becker.
Thank you, Pedro. Our next speaker is Dr. Mohd Razis. He'll speak to us on total correction of tetralogy flow in adult patients, a single center.
Yeah, it is. So, there is a problem with this.
Thank you, and a very good afternoon to all ladies and gentlemen, the distinguished faculty members, and fellow colleagues. My name is Abdul Rashid, and I'm from Malaysia. So today I'll be talking about total correction of tetralogy of fellow in adult patients, a 20-year single-center experience. So as we all know, tetralogy of fellow in adulthood is comparatively rare compared to in childhood. This is due to most of them being detected early in childhood, as well as 84% of patients with tetralogy of fellow who are left untreated do not survive beyond the age of 18 years old. So TOF repair in adulthood is considered the exception rather than the rule. Nevertheless, there are a lot of publications and literatures describing tetralogy of fellow repair in adulthood. In one example, Dietrich et al. Found that hemodynamic impairment in survivors to adulthood may reflect a less severe spectrum of the defect, and their comparatively high morbidity and mortality in this subset of patients may be due to the long-standing cyanosis. The long-term outcome and quality of life is excellent post-repair. However, we have to be wary of the late complications that may occur, which may require re-intervention. Presence of severe cyanosis, right and left ventricular dilatation, elevated and diastolic pressures, and significant tricuspid regurgitations serves as predictors for higher surgical risk in this patient population. Knowledge and colleagues found excellent long-term survival up to 35 years in their experience after the surgical repair, which is being comparable to the life expectancy of the general population. So the aim of this study was to report the outcomes of tetralogy of fellow repair in patients who underwent surgical correction at the age of 18 years old in the last 20 years, from January 2000 to December 2020 in our institution, and to demonstrate that these patient populations with tetralogy of fellow who present in their adulthood have favorable anatomy for repair. So we looked at a total number of 107 patients over a period of 20 years. And this is a retrospective review of the patient's records with follow-up data which we obtained from clinic appointments and conversations we had with the patient or their family members. This graph here shows the total case according to year. As you can see, in the last 5 years, the number of cases have reduced significantly as earlier detection means that repairs are being undertaken earlier. These are some of the pre-op characteristics of the patient. Most of the patients who came at operation had a mean age of 30.5 years old, ranging from the age of 18 to 60 years old with a BSA of 1.51, a pre-op hemoglobin level of 16.1, RVOT gradient of 80.6 millimeter mercury, and the gender distribution is quite equal in that male represents 46% and female represents 45% of the total number of patients. And of these total patients, 15 patients had a previous palliative surgery in that they had a modified VT shunt. So this pie chart represents the predominating symptoms that patient came with upon their diagnosis. So most of the patients came with cyanosis, shortness of breath, and reduced effort tolerance. 4% of patients were asymptomatic, and the rest came with either chest pain, syncopal attack, or palpitation. Operation was performed through a standardized manner, through a median sternotomy with cardiopulmonary bypass, aortic and bicaval cannulation, blood cardioplegia, and also cross-clamp with moderate hyperthermia. Ventricular septal defects were closed using a PTFE patch. Pulmonary artery augmentation, if it was required, was using autologous pericardium, and a monocusp was fashioned using a 0.1 mm PTFE patch. A biocore valve conduit size 24 mm was also used in one patient, and a biprosthetic valve at the pulmonary position was used in 2 other patients. The mean cross-clamp time is about 92 minutes, and the mean CPB time is 139 minutes with a RV to LV ratio post-repair of 0.56. So most of the patients who underwent tetralogy of Fallot total correction in the adult patients in our center had their pulmonary valve preserved, accounting for 78.5% of the patients. 19% had a transannular patch with a monocusp, and the remaining 3 patients had a pulmonary valve replacement and also a conduit. Patients who underwent surgery in this age group had an average stay in ICU for about 4 days and a mean hospital stay of about 13.2 days, with a 30-day mortality of 2.8%. The cause of death in these 3 patients were 2 of them died due to multi-organ failure with septic shock, and the other one passed away due to biventricular failure, which accounts for 0.93%. So post-operatively, patients were not without complication. 8 patients had arrhythmia, which was treated and with chemical cardioversion and reverted to sinus rhythm. 5 patients had right ventricular dysfunction, and 2 patients had pericardial effusion requiring drainage. 2 patients had pneumonia, and 1 patient had a prolonged ventilation which required tracheostomy. Total number of 13 patients had a pleural effusion requiring drainage, and this contributed to the long hospital stay. 2 patients had a vocal cord palsy. 3 patients had acute kidney injury, which did not require any renal replacement therapy. And 6 patients had a chest reopen for hemostasis, and 3 patients had a superficial wound infection. So the long-term results of these patients, most of the patients are under follow-up by their pediatric cardiologist or at their previous hospitals. A mean follow-up of 5.8 years was visible in 85% of the patients, with a maximum follow-up of 20 years and 1 month. This is a schematic representation of the improvement of functional class in the patients. As you can see, pre-operatively, most of the patients were in class 2 and class 3 NYHA functional class, and some were in class 1 or 4. However, during our long-term follow-up, we observed that these patients either improved and maintained in class 1 functional class, or the rest were in functional class 2. This Kaplan-Meier survival curve shows that the long-term survival is at 96.7% over a duration of 20 years. And freedom from re-intervention is at 95.7% at up to 20 years after surgery, in which 1 patient had a cutaneous transluminal balloon valvuloplasty done after 3 years, 1 required resection of the RVOT after 2 years, and 1 patient had an occlusion of a residual VSD. This Kaplan-Meier curve shows the freedom from re-intervention. The long-term freedom from intervention is at 95.7%. So in this slide, we would like to demonstrate in 1 patient that we did the objective assessment of the improvement in the functional in the function of the ventricles of the patient. So as you can see from this 4-chamber view here, there is dilatation of the RV with the RV hypertrophy and dilatation of the RA. And post-op, the right ventricular end diastolic volume went down from 110 mils to 70. The left ventricular end diastolic volume improved from 80 to 76, and there is improvement in the ejection fraction. The RV pre-op from 40% to 61%, and the LV function improved from 45% to 50%. However, there are limitations to our study. Most of the patients were discharged to their previous hospital post-operatively, and there are some patients who we were unable to identify their status for those who are not under our follow-up or who are unreachable via telephone. So in conclusion, total anatomical correction of tetralogy of Fallot in adults is associated with a low operative mortality and low morbidity, with improvement in cardiac function in our population, also proven with imaging. It also offers immediate symptomatic relief in all patients with good long-term outcome, and late presenters are self-selected patients with a good anatomical variant for repair. With that, I thank you.
Questions? I have a question. Really astonishing, 30 years of age that you see these patients. Were there patients that you turned away? Were there anyone that presented that either had too many comorbid factors at the time that weren't surgical candidates?
Most of the patients who came in, they were referred from other centers, and these other patients, they had some of them had hypertension, diabetes, but none of them had any coronary artery disease or any significant medical disease that we would turn them away for surgery.
You operated on all comers.
Yes.
I would like to find out about your peri and postoperative bleeding complication with this patient, and if you do occur, what strategies do you employ to control this hemorrhage? Because it's been a big problem in most centers when repairing the adult tetralogy.
I think the normal hemostatic strategy applies, in which careful hemostasis during or before closure, and then making sure that there is no bleeding from the suture lines. Sometimes we know that these patients with long-standing cyanosis, they could have a problem with coagulopathy, but we were a bit aggressive in terms of treatment with blood products and using blood products as well. However, we experienced 6 chests reopen for hemostasis in this cohort of patients.
Congratulations for the presentation. I had 2 questions. One of them is, do you have cases with collaterals because they are adult patients and these collaterals bother you during the operation? And the second question is, in the 20 cases that you placed the implant and monocusp, how was the evolution of these patients? Have you considered to put a valve, or the monocuspid is a good option in your opinion?
Thank you. The first question was regarding, sorry, I'll answer the second question first. So we did some of the patients who had a transannular patch with a monocusp still under our follow-up, but so far in the 20 years, all of them were who are still under follow-up, still have a good functional class. And also there are no evidence from imaging that they have any RV dilatation. So we haven't had any patients from this cohort of patients who required a valve replacement yet, but they are still under our follow-up. The first question again, sorry. Collaterals. So we don't routinely do CT scans, but however, there is one patient that previously had a AP collateral in which we had to ligate the collateral as well, but that was only in one patient. So it was not a big problem in our series of patients.
We have time for one more speaker. Could the questions, please, the individuals asking questions speak with their name, city, and country, please?
Etioma, Nigeria. Thank you for your presentation. You had 108 patients over the period. Were these all the patients that were presented to you, or were they a subset of people you had to screen off others? Did you have to screen off some others from surgery, so that at the end of the day, it's not all the patients that presented with adult congenital TOF that you operated upon?
Okay, if I understand the question correctly, usually the patients that come to our center, as we are a tertiary center, the way our healthcare system works in our country is that patients are being detected from peripheral hospitals and then referred to us for surgery. So these are the majority of patients who came in, and some those patients who were directly referred to us from our nearby center, then we would screen these patients and counsel them for surgery. So most of the patients that were referred to us did underwent surgery in this adult tetralogy of Fallot patients. Was that the question? Was there a percentage of patients that? I don't have the number at heart at the moment, so I'm not really sure about that one. Sorry.
But you did comment in the first question that you operate on all comers, correct?
Yes. Thank you. Thank you.
So we call Dr. Marcello Cardarelli to talk to us about major postoperative complications and mortality in pediatric cardiac surgery. Dr. Marcello, you're welcome.
Assalamu alaikum, everybody. Thank you for to the society for the opportunity to present our data. Let's see if we can start some trouble. So outcomes in pediatric cardiac surgery are perceived to be superior for high-income countries compared to low and middle-income countries, high-volume hospitals compared to low-volume hospitals, and high-volume surgeons compared to low-volume surgeons. And while patients can be risk stratified with STAT, RASH, or other scores, when it comes to surgeons or hospitals, or rather healthcare systems, outcomes research always seem to be intrinsically limited to volume. We are not aware of data comparing surgical outcomes between a low-volume surgeon in a low-volume hospital in a high-income country versus a low-volume surgeon in a low-volume hospital in a low- and middle-income country, while risk-adjusted for patient and for surgeon. So this study is a retrospective analysis, surgeon-specific outcomes of pediatric cardiac surgeries performed in the USA and in some low and middle-income country hospitals. Data was collected from the STS and our own NGO database. IRB at our institution approved the study, and after logarithmic regression, a propensity score matching was carried out. Between December 2014 and December 2020, including the infamous 2020, 418 pediatric cardiothoracic operations were carried out. 245 of those patients qualify as STAT procedures. All the surgeries that were excluded include surgeries that were mentoring somebody else, ECMO procedures, pacemakers, and any other procedure in which the surgeon was not the main surgeon. We end up with 121 patients in Group A, USA, and 124 patients in 7 LIMACs, Iran, Ukraine, North Macedonia, Ecuador, Iraq, Libya, and Lebanon. The overall mortality was 4%, or 10 out of 245 patients. There were some significant differences between the groups. The median weight was lower in Group A, the US. And of course, age, there were younger patients in the United States with a mean of 1.7 years compared to 4.3. There were more patients diagnosed as having syndromes in the US group. And although not significant, but on the way to becoming significant, there were more patients with major non-cardiac structural anomalies also in the group A. On the results, you can see that we have distributed patients in both groups according to the STAT qualification. And the mortality in group A was 3 or 2.4%, which is 1-to-1 estimated over observed. Meanwhile, the mortality for group B out of 124 patients was 7 patients, or 5.6%, when the expected mortality for that group should have been 2, or 1.6%. None of the mortalities were significant, but again, the groups were small to achieve significance. I would like to make 2 observations. The first one is that there's a mortality in the STAT group 1 that shouldn't be there. And just to, if you allow me to explain, I think it's a good teaching point that bad things happen everywhere. This is a 2.5 kilo patient with VSD, PDA, small PFO, with significant pulmonary hypertension and with funny looking pulmonary veins. Underwent catheterization to rule out any anomalies of the pulmonary veins. And during the catheterization procedure, the heart was perforated, the patient tamponade, the patient arrested, was placed on ECMO. And a week later, once we proved that there were no significant CNS consequences, that patient underwent full repair. And at the time of repair, we visualized normal pulmonary veins macroscopically. Despite that, the patient continued to have severe pulmonary hypertension. All the measures were in place. And a week later, a genetic profile showed very bad genetics, not a syndrome, but bad genetics. And the family decided to withdraw care. So the second observation is that patients in STAT group 1 were much larger in the patients operated in low and middle income countries, as it normally occurs, significantly more. Neonates are, special group within all the patients we operate. As you know, there are less neonates with critical congenital heart disease to be operated during surgical missions. And there were 32% on the group in the United States compared to only 7% of the patients. And while the mortality in the US was only 2.5%, it reached 22% in LMICs. And although it's not significant, it's just not significant because the denominator is very small. Ischemic times were similar, and there was a similar reintubation on the patients, although it's pretty high, and there's an explanation for that. Patients in the United States undergo MRI before and after any procedure, and many of them were extubated already and needed the MRI, so had to be reintubated just for the study. Speaking of major postoperative complications, we revised every single of the 18 major complications: low cardiac output, acute kidney failure, pulmonary hypertension. We consider all pulmonary hypertension as a complication, although that's debatable. And the number of complications was twice the number in the United States, significantly higher. Fortunately, we were able to verify that the failure to rescue was about the same, or 10%. As you know, patients who have no complications do not die after heart surgery. They die because of the complications. So depending on what your failure to rescue ratio is, depends on your mortality. So group B had a higher mortality just because they have more complications. But 10% were the failures of those to be rescued. A log regression was performed for mortality, and the use of cardiopulmonary bypass was the single most important, and the combination of use of cardiopulmonary bypass and small weight was the second one. The R square in the bottom right of 0.40 tells you that only 40% of the mortalities is justified just by these two parameters. So in an ideal world where everything is perfect, you will take the same 245 patients and randomize them. Half goes to surgery in a low and middle income country, the other half goes to surgery in a high income country, and that would be the way to really know what the differences are in between the health systems. Remember, we're not judging or we're not measuring the intervention as cardiac surgery, but cardiac surgery in different environments in high income and low and middle income countries. Since this is unethical and unpractical, the alternative is to address the issue of selection bias by creating what is called as a propensity score match. And in that case, two groups are created in which we take patients from the original groups, and the patients have to have the same characteristics. Two groups of 55 patients each were created in this format. The use of cardiopulmonary bypass now was similar in both groups. The length of cardiopulmonary bypass not significant. The median weight was 6.9 compared to 7.4, not significant. And again, the chromosomal abnormalities, syndromes, and other major cardiac structural anomalies, non-cardiac structural anomalies were not significant. Once we did all that, to our surprise, the postoperative complications went up by 3 times compared to the complications in Group A. And the mortality, although higher, was not significant just because the group numbers are very small. So in conclusion, our limited study seems to indicate that given the same surgeon and matched patients, the higher rate of postoperative complications and mortality in low and middle income countries are likely attributable to shortcomings in their healthcare system other than failure to rescue. The ability of a hospital to use a systematic approach to manage complexity seems to be at least as important as volume. I couldn't emphasize more. This is the slide, the take-home message slide, I think. Finally, before surgeon-specific results are made available to the public, as is being made for coronary artery surgery in England right now, some consideration should be given to the development of a health system risk adjustment tool. The limitations of this study is that it's a retrospective study. The groups are small. Healthcare failure, healthcare system failure is a very wide category. And because we operate in more than 7 countries with 7 different healthcare failures, we are just giving generalizations, but failures in one area, in one country may be different than the failures of the system in another country. And I thank you everybody for your attention, and I invite you, we're conducting a cost analysis of cardiac surgery in low and middle income countries. If you can take the picture with your camera and contribute, and with your answers, it's just 10 questions, takes 30 seconds. Thank you very much.
I have a comment and a question. So we recently looked at 16,000 patients through a database, and it's being published. It's in the publication process right now. And we did see a pretty dramatic difference in outcomes across all stat scores for low income, middle income, as defined by the World Health Organization, versus higher income studies. And the interesting part was, although there were more stat 5 cases, there were a much higher complication rate in higher income, which sort of makes sense. So that some of that data is coming to more fruition as we accumulate more and more real data, through our databases. The question is one thing: your expected mortalities. How did you come up with that?
Is on the latest paper from the regarding the stat categories where the mortalities are listed. That's the expected mortality listed in that paper from the STS database. So if you multiply, and maybe we did this wrong, but if you multiply the expected mortality times the number of patients, you have how many patients should have died or were expecting to die in each category.
Very interesting analysis, and we've been trying to get a handle on this in the Congenital Heart Surgeons Society. I think, to me, what your study points out is that there's multiple components to a successful cardiac surgery center, not just the surgeon, but you go down the line: anesthesia, perfusion, nursing, the ICU, the pre-op evaluation, the post-operative care, and I think most likely that's what's missing in the other countries.
Yeah.
And currently, the CHSS is coming forth with guidelines that we feel are important for centers to fulfill regarding what would make either an essential cardiac surgery center, which would be like at a lower middle income country, versus comprehensive centers that would have all the nuts and bolts and everything for care of the most ill and smaller babies and neonates and transplants and VADs and that sort of thing. So I'll be presenting some of that stuff on Sunday morning, but I think your presentation points out that those other components are very important.
Yeah, not only that, the reason we did this is, and maybe I wasn't clear enough, the people working in low and middle income countries, they read the literature that comes from America and Europe, and we glorify volume because we have very different systems. And you should concentrate on having quality by breaking down the complexity of cardiac surgery, achieving good results. You can achieve good results with low volume, and then the volume will come. But don't guide yourself based only on the American literature, which has very different goals behind, starting with money.
No, it's a very complex interaction, but I think at some point you have to have all the necessary components.
You have to have
Absolutely.
Absolutely. There have to be a minimum of components to do this.
And the problem is that you have to have a certain volume to support those components. You can't have, 2 pediatric perfusionists, 2 pediatric anesthesiologists, 2 surgeons, a full ICU,
right,
and then only do 10 cases a year. So,
right.
Yeah.
But don't forget that the American healthcare is a subsidized demand healthcare, and in low and middle income countries is a supply subsidized healthcare. So it's a very different approach to each.
Well, thank you very much for your
Thank you.
insights. Appreciate it. Nice presentation. Well, now it's my pleasure to introduce our next speaker, Dr. Nestor Sandoval, who is the chief of pediatric cardiac surgery in Bogota, Colombia. Most of you may or may not know, but he's the incoming, what's your new title? Vice President-elect or second Vice President. So he will be president of this organization in, I believe it's 4 years. Christoph, 4 years. Okay. Don't want to make a mistake. And Nestor's going to talk to us now. We're going to talk about over 500 tetralogy patients. The numbers keep growing.
It's okay. But I hope. First of all, thank you to the society for the invitation and to privilege to be here, and thank you to the organizers for put together this meeting and be able to see you face to face again after 2 years of difficulties. It's a pleasure to be here, and this is a work that we did in our institution in Bogota, Colombia. and it's about the outcomes of 556 consecutive primary repair of patient with tetralogy of Fallot. As everybody mentioned before, as the tetralogy of Fallot is one of the most common cyanotic congenital heart diseases. Every day there is more information about low and middle income countries. That's as Marcelo and the previous speakers they mentioned, is very important to know and have a comparison with those. The treatment has evolved from systemic to pulmonary shunt to pulmonary valve sparing and preventing the pulmonary valve insufficiency and right ventricular dysfunction. So the objective of this study was to report our outcomes of total primary repair of 556 patients of consecutive patients in a single institution in Colombia, and correlate the surgical technique with the requirement of pulmonary valve implantation with time. As everybody knows, on blue column is the age of the operation in the STS series in developed countries. And on the red column is the IQIC database from developing countries. You can see that in the developed countries, the operations are performed almost before the 1 year of age, and in developing countries, after the 1 year of age. So we did a retrospective study from patients from December 2001 to January 2022. This is a descriptive analysis of preoperative, intraoperative variables and postoperative outcomes, and preservation and late pulmonary valve replacement. The statistical issues are written there. So in 21 consecutive years, we operate this number of patients. The median age was 19.4 months, from 11 to 51. Malnourish was present in 57%. Median preparative oxygen saturation was 87, and the surgical mortality total was 3.9, and decrease, it was lower in the last year. It went down to 1.6, I think, due to implementation on the heart team and the ECMO. And this is our column in green, is my institution. And you can see that we are operating patients even older than the IQICs. This is low and middle income countries. The mortality is similar, and the tendency is to improve mortality with the experience of the team. When we analyzed the mortality, we found that in general, the age of those patients who die, they were older, but it was not statistical significant. However, the oxygen saturation below 87 and the cardiopulmonary bypass time were the only risk factor for mortality. Other postoperative issues were not significant. However, those patients who die require more intervention because of bleeding, and those patients who survive require more ECMO. During that period of time, 5.8% required pulmonary valve implantation in our institution. And since we were able only to review the medical records on the operative note from 2010, we found these 309 patients. 40% of the patients receive a transannular patch. And you see in the blue, 24%, those who didn't receive any new valve or monocuspid valve, and 23% in green are those who received transannular patch with implementation of the neo valve or monocuspid valve. When we analyzed the characteristic of patient during the required pulmonary valve implantation during the follow-up, at the moment of the primary operation, they were younger as we expected. So we start thinking it's because it's younger, because the age is a risk factor for this pulmonary valve replacement. Of course, the weight, and however, the other variables were not statistically significant. We couldn't find any difference between the intraoperative and postoperative variables related with the moment of the primary repair that were related pulmonary valve replacement. However, the time for pulmonary valve replacement was at 102 months after the initial primary operation. This is a sub-analysis of a patient, and you see in the middle of the screen is the transannular patch with no valve. It was the group that required more implementation of pulmonary valve replacement during the follow-up, followed by the Hagar dilatation. It means that we think that we are doing something with the valve, and we are destroying the valve, with pushing maybe the Hagar a little bit, trying to preserve the valve. When the patient that we use the transannular patch with a neo valve or monocuspid valve, it was only 5.7%. The age was similar from the initial operation to the time of the pulmonary valve implantation. However, those who had a transannular patch and neo valve on the left side of your screen, 117, those group of patients received the valve later compared with the other type of surgery. Of course, they were older because we were able to put a valve in an older patient and a bigger patient that we are not able to do in a very small patient. And this is the number of the operation through the years, and you see the red button are the mortality, and we had no mortality since 2017 until the COVID came, and the day before one patient was going to discharge, he got COVID, and even with the ECMO implementation, he dies. So I think in conclusion, the age of the operation in our institution is higher than the developed and developing countries, and it's something that we have to have in mind. Risk factor for mortality are low saturation and prolonged aortic cross clamp time. The decrease of mortality in the last years is due to the hard teamwork and, of course, the ECMO implementation. The transannular patch is used normally in almost 50% of our population, and the implementation of a neo valve or monocuspid valve is being, I think, it's been a good idea, since I think we prolonged the time for the valve implementation that everybody knows is a very bad situation. The Hagar overdilation is, we've seen, and it's been mentioned before. Many groups have described this. It's about a technique in order to try to preserve the valve. And finally, database is very important for evaluation and change strategies if you are having problems in your center. That's why we are at the moment we have 3 database, and our limitation are due to we don't know the survival of patients who that we didn't operate when they were younger. Maybe they die. And due to the lack of complete follow-up, the incidence of pulmonary valve replacement could be higher than 5.6%. Thank you for your attention. And as I mentioned, happy to be here with you, my friends.
Well, thank you, Nestor. That's an amazing series of patients. We'll take our first question and just tell everyone who you are. Thanks.
Attilio Lotto from Liverpool, United Kingdom. The need for pulmonary valve replacement late following tetralogy of Fallot is mainly dictated by dilation of the right ventricle. And I see that in your series, you had quite a few of those patients needed pulmonary valve replacement, but they were also operated much later than what we normally do. Do you think actually that has got an impact? So the right ventricle hypertrophy kept for months and months have got something to do with the delayed dilation of the right ventricle post-Fallot?
We try now to leave at least 20 millimeters of mercury gradient after the operation, and then the patient that we operate, we follow them in our institution, and those who have an X-ray, a big X-ray with a increase in right ventricle, we do MRI, and we try to follow recommendation 105 and 80, but every time we try to prolong the days of the months and wait a little bit in order to not put very early a pulmonary valve or artificial pulmonary valve. So I think that if we modify our technique, we try to do something. We like the pulmonary valve implantation. Pulmonary valve, monocuspid valve, could help us a little bit. Could help the patients to prolong the time between the operation and the pulmonary valve implantation.
So you're basically talking about a restrictive RV physiology. Is that what you're talking about? Yeah, and I think that probably makes sense. Because that's kind of the description.
I was alluding more actually to the fact that his series of patients are older.
Correct.
So our ventricle, it's much stiffer.
Stiffer, thicker, restrictive.
You do your operation, and then when you have a pulmonary regurgitation, the dilation of the ventricle, it's less because there is already a fibrotic right ventricle, and might not dilate as much as if we do the operation at 6 months.
Nestor, what's happening to these patients when they're hanging out? We're in the United States, everywhere. The minute the child has one slight blue spell, they're in the hospital and go directly to the operating room. Are you just watching these patients with TET spells?
It's very difficult. The follow-up in our countries is really hard. So we just operate the patient that are able to get to our center. We don't know the other patients that are operating in other centers. But it's very difficult.
I do think, though, we have a tendency in the United States, I don't know if anyone agrees with me, but I think we're a little bit overly worried about those patients. You look at your patients, they're surviving until they're quite old to have the operation. I don't know if Dr. Bleiweiss is out there. Maybe he wants to make a comment on, he operates on his patients before 30 days of age. Nestor's waiting until 2 years of age. It's quite a wide spread. I got Mark's attention. He's going to come up to the microphone.
I think, as I mentioned earlier, we do operate on them earlier and earlier. We have been operating on them typically between 6 weeks and 3 months of age tend to be for elective TETs.
So we've got a wide variation.
Yes, a wide variation.
Yep, and your mortality is actually pretty low when I look at it.
It's been getting very low, and
now I finally got everybody coming up to the microphone. This is much better.
Well,
Dr. Overman, please introduce yourself.
Yeah, David Overman, Minneapolis. I think, as most others in the room know better than you or I think a lot of that's about the denominator and presentation of the patient for repair. And, centers in low to middle income countries don't have the same amount of penetration and oversight in the preoperative period than we would have the luxury of in the United States. So I think that probably accounts for a big part of the age difference. Would you agree with that, Nestor?
Yeah, completely agree. It's a different story. It's a real world for us.
And it is, I remember, and you talk about Dr. Castaneda, I trained with Frank Hanley, and I remember Frank Hanley saying when I first showed up, he would let us do a Norwood way before he would let us do a neonatal TET repair because the decision-making and the complexity of the repair, the technical demands were so challenging. And I think it still holds, but I think with more and more neonatal experience, we've gotten better and better with it.
Thanks. Cristo.
Just to bring up an issue, my 35 or 36-year experience, I have never shunted at that. Operate all comers whenever they needed the operation, whether it's neonatal or a bit later. But one of the things that's very important in the asymptomatic neonatal young infant, I tend to operate on these patients earlier if I feel that the pulmonary valve could be preserved rather than waiting. I'd rather do them around 6 to 8 weeks of age because it's more likely you might be able to save the pulmonary valve with a small annulus before the patient has grown and the body surface area has increased than waiting till 3 months or 4 months when maybe the valve will get somewhat thickened and the annulus perhaps will not grow. So the more likelihood to preserve the valve, the earlier I would operate on the asymptomatic patient. I don't know if you have any thoughts about that.
Nestor, do you have any thoughts about
Yeah, I'm
how?
completely agree with you, Krista. I think it's an issue. If we operate a very young patient and the valve is not perfect, it's very hard for us to preserve the valve. And we see patients older than a year, and we can work a lot with a bigger patient. I think it's very important. But there is not a paper that says exactly that if you operate the tetralogy of Fallot younger, or the first month of age, you will be able to not to preserve the valve. It's just an idea, but we don't have the total complete response for that question.
Well, you certainly have enough patients to do the analysis, so thank you very much. Great
Thank you very much.
presentation. Appreciate it.
Our next speaker will be Dr. Ashri, who will speak to us on results of urgent interventions in patients with tetralogy of Fallot within the first 3 months of age.
This one brush, and last one, yeah. Is it in PowerPoint? Can you... That's okay. Thank you. It's not. Right. Good afternoon, everyone. My name is Amr Ashri, one of the cardiac surgical team at Elder Hay Children's Hospital, Liverpool, UK. I would like to thank Society for inviting me to such prestigious meeting to present our work. Today I'm going to speak about results of urgent interventions in patients with tetralogy of Fallot in the first 3 months of age. As we all know, life-threatening cyanotic spills may be very frequent, severe, with challenges in establishing reliable source of pulmonary blood flow in duct-dependent pulmonary circulation. These patients may require urgent intervention in neonatal period or as young infants. So our cohort contain all patients with tetralogy of Fallot less than 3 months of age, treated with either surgical or cath lab intervention in 6 years period from January 2015 to December 2021. We have 42 babies. Group 1 include surgical cases, 19 cases, and group 2, 23 cases of cath lab procedures. Median age and weight in surgical group was 38 days and 3.7 kilos, while in cath lab group was 29 days and 3.2 kilos. In the surgical patients, we had 9 patients had complete full repair, 8 patients had modified BT shunt, 1 patient had transannular patch, and 1 patient had RVPA conduit. In the cath lab group, we have 9 patients who had PDA stent, 9 patients required RVUT stent, 3 patients had pulmonary valve balloon dilatation, and 2 patients had RVUT balloon dilatation. Of course, ICU stay and hospital stay was shorter in the cath lab group, with median ICU stay and hospital stay of 1 day and 5 days in cath lab group, compared to 4 days and 9 days in the surgical group. However, reintervention rate was higher in the cath lab group, as we had 5 patients who required further reintervention before full repair, compared to only 1 patient who required reintervention before full repair in the surgical group. Median time to full repair was 13 months in the surgical group and 10 months in the cath lab group. As I mentioned, we had 9 patients who had primary full repair, with median age of 59 days and median weight of 4.4 kilos. No further intervention required, and we didn't have any mortality. In the cath lab group, we had one mortality of a patient with RVOT stent complicated by ventricular arrhythmias and required ECMO. Unfortunately, he had a cerebral infarction and passed away. Regarding re-interventions, the 5 cases who required re-interventions was mainly after RVOT stent. 2 cases after RVOT stent required further RVOT stent. 1 case required stent balloon dilatation. 1 case required multiple MAPCAS coiling. And 1 case after RVOT balloon dilatation required PDA stenting. In the surgical group, we had only 1 patient who required re-intervention. It was a case of modified BT shunt, required unblocking of the BT shunt and transannular patch. 6 patients in our surgical group came to surgery after unsuccessful intervention palliation. 3 PDA stents were abandoned. 1 of them because PDA was too curly and required urgent BT shunt. 1 because of abnormal anatomy and required urgent full surgical repair. 1 had a significant desaturation, instability, high lactate, and high inotropic support, so went immediately to surgical theater and had emergency BT shunt on bypass. 3 patients with RVOT stent were abandoned because of difficult anatomy or difficult to cross the RVOT, and 1 patient had a guide wire perforating RVOT. 2 of them had urgent BT shunt, and 1 had transannular patch with RPA plasty. Finally, what we have learned from our experience, PDA stent is not an option if PDA is too tortuous or curly. In case of abnormal origin or insertion of the PDA, such as PDA inserting into LPA and large PDA. RVOT stent, despite having high reintervention rate, it's still useful option in low weight, prematurity, significant comorbidities, unfavorable PA anatomy, and abnormal coronaries. Surgical repair, primary corrective surgery is not feasible when there is hypoplastic pulmonary arteries, abnormal coronary arteries crossing the RVOT, significant comorbidities, prematurity, or low body weight. While criteria for early for repair are favorable anatomy, good size branch PAs, normal coronaries, and no significant comorbidities. In conclusion, in patients with tetralogy of Fallot needing urgent procedures early in life, good results can be achieved with either surgical or cath lab interventions. Clinical and anatomical features affect the success of the procedure. Intervention procedures had more reintervention rate than surgery. And finally, in patients with favorable anatomy, full repair can be performed as primary procedure with good outcomes. Thank you.
Open the floor to questions. I'll start off. So it seems your bias is to go to the cath lab first as your institutional protocol to treat these urgent patients, and then if they don't are able to be taken care of in the cath lab, they move on to surgery. Is that true? Is that what your first, how you evaluate these patients? And is there a bias to go to cath before going right to surgery?
Yeah. Usually we have a weekly MDT meeting between cardiology, cardiac surgery, ICU, and anesthesia. We decide, we make decisions either to go on cath lab or to do surgery from the beginning based on the clinical and anatomical features. We tend to do CT scan for these patients to see the pulmonary arteries, to see the PDA origin, insertion of PDA, whether it's straight or not, also to see coronaries, and then we decide. And we tailor the indication based on anatomy of each single patient.
But if a patient shows up in your ER as an outpatient with low saturations, you go to the cath lab first, or do you go right to surgery?
No, we decide in depending if it's like tortuous PDA or if it's favorable anatomy, we can go straight forward for a full repair.
Dr. Najam.
Thank you. I just want to comment about the size of the pulmonary arteries as you're talking about small pulmonary arteries.
Yeah.
In the absence of orthopulmonary collaterals, and it's a newborn, do you think that the pulmonary artery size with a tight RVOT is reliably measured by our imaging tools? I say that because I firmly believe that if there are no orthopulmonary collaterals, you have central PAs with good arborization, you should not worry about the size. If they're symptomatic, they will be fine. And if you do a good repair, the RV pressure is going to be low and normal. So the choice to palliate based on pulmonary artery size in a symptomatic newborn, I think is erroneous at best, because we cannot measure them really well because they're not pressurized. The other comment that I have for your RVOT stent, once you put an RVOT stent, you obviously committed to a transannular patch, one. Two, a lot of them actually may require an RV-TPA conduit. You have to put this into the equation because tetralogies do much better if you just repair them without having to do an RV-TPA, because if you leave that stent for a long time, then it depends where it's placed, how far in the MPA it is placed. By the time you take it out, you may have lost the MPA and you need to bridge that with an RV-TPA. So this is a drawback of the RVOT stenting. Your comments about these?
Yeah. Regarding first question, we use Z-score for the pulmonary arteries, depend on the echo and CT scan with 3D reconstruction to have a full idea about the PAs. And again, we decide based on the MDT discussion to decide if it's favorable anatomy for full repair or not. If not, we assess clinical condition of the baby. If he can tolerate surgery, we go for surgery. If not, if he has favorable anatomy for PDA stent or RVOT stent, we go forward for this. Regarding the RVOT stent, again, it's a good option. We had in this series, we had some cases who had significant comorbidities, so they were not favorable for surgical palliation, like necrotizing enterocolitis or other comorbidities like this with a tortuous PDA, so RVOT stent was a good option. These patients after RVOT stent went for a transannular patch, as we tend to do transannular patch in most of our cases.
Thank you.
You're welcome.
Hani, that's a really good point. I just want to poll the audience. How many people think in tetralogy of flow, if you do not have aortal pulmonary collaterals, that the pulmonary arteries are always going to be okay? Nestor, you don't agree? I don't want to put you on the spot. But that's a very interesting comment, Hani, because I mean, that's in all the textbooks, it says a contraindication to primary repairs, hypoplastic pulmonary arteries. But if you don't have AP collaterals, they're probably going to be fine. Interesting. Thank you.
Thank you.
Giovanni, Salim.
Yeah. Well, I enjoy your presentation. So I understand that you treat tetralogy of Fallot with symptoms within the first 3 months of life.
Yeah.
Nevertheless, I've seen that your average age of the operation is 13 months or something like that. So my question is this: why don't you operate all your patients, even the asymptomatic one, within the first 3 months of life, in order to avoid chronic cyanosis, progressive IV hypertrophy, and make your operation much easier than it would have been after 6 months or 12 months of life?
Yeah. So we tend to operate on these patients at about 6 months of age, unless desaturated or in a bad condition. So we discuss and then we decide if they have a favorable anatomy with good PAs, good normal coronary arteries, and not very long RVOT segments that require very long transannular patch. So we go straight forward for a full repair.
Well, I don't think you answered my question, but doesn't matter.
Yeah, your question is why don't you operate them in the first 3 months of age?
Yeah, earlier.
No, the question is this: it's much easier to operate and asymptomatic patients all of them in the first 3 months of life, in order to avoid chronic cyanosis
Yeah.
and the progressive RE hypertrophy. So, what's your philosophy to wait after 6 months or 12 months of life in order to fix a patient with a tetralogy
Yeah.
fallow?
We tend to operate at 5-6 months of life for asymptomatic patients in our unit.
Yeah, but you showed a picture, it was a 13-month average.
Yeah,
for-
yeah, 13 months average from palliation to full repair. Some of these patients had like delays. They had a good saturation, acceptable saturation.
Yeah, all right.
And-
So what's the reason for delaying? I don't want to discuss too much. What's the reason of delay so much? That was question.
What do you mean, Giovanni? You seem to be enjoying yourself. All right, I think we're not going to resolve that one. Dr. Becker from
Yes,
Chile.
I'm going to switch a little bit the focus. I think for a suggestion for your paper, and I think that you need to better define what is urgent, because probably what I was thinking when I saw the title, I was thinking of a patient spelling with a TET spell. Those patients are very sick. Probably it's very complex to take them to the cath lab, getting vascular access, messing around with catheters in the RVOT. So maybe you should define in your paper what do you mean by urgent to make a difference by emergent, I think. Because in general, I would think that when you're speaking of urgent surgery or treatment in tautology, is a patient spelling that you cannot manage medically, and unless you put those patients in ECMO to do your cath and all around, I think it's going to be very complex. So just want to warn you on that. And if you can define, how did you define urgent for your talk? I enjoyed it very much.
Okay, so all of these cases had severe desaturations that required hospital admission, and some of them required intubation ventilation before going for a cath lab or for surgery.
People may or may not know, but there's a active trial going on in the United States now to compare the outcome of intervention with transcatheter techniques versus PT shunts. Christo?
Very quick point. The pulmonary arteries assessed by echo or imaging modalities before the repair are always bigger than what they say they are. If they say they're 3 millimeters, in my long experience, usually 4.5. If they say they're 4, they sometimes 5.5. I did a quick calculation on the Nakata index. If you have branch PAs that are 3 millimeters each in a newborn, the Nakata index of that size is about 70 millimeter per meter square. If you're wrong by 1 millimeter and they're really 4 millimeter each instead of 3, it goes up to 120 millimeter per meter square. If they're wrong by 2 millimeters, it goes up to 190. And in my experience, the pulmonary artery is always distensible. They're always bigger than what the echocardiography tells you. So to make a decision on imaging modality as far as size and base your clinical decision on that, I think I support the other comments from Hani and others. It's erroneous. Thank you.
All right, the president or the executive director has spoken. All right, thank you very much. Nice presentation.
Dr. Solafa Ali from Sudan, you're welcome to present your work about outcome of after in patients with TGA undergoing Rashkin procedure. Dr. Solafa? So, Dr. Yuri Kolaibin, I hope I pronounced good. You're welcome to talk us about your 10-year experience of right ventricle and fundibulum sparing surgery.
Dear colleagues, hello everybody. It's a great pleasure for me to be here and present our experience. I have a little bit of time to change my analysis and expand it for 5 years. So now I would like to present our 15 years experience of right ventricular infundibular sparing surgery of tetralogy of fellow. I have no disclosures. The mortality rate of tetralogy is not an issue in modern era, but the main concern is the late outcome, such as our redo catheterization surgery, redo open surgery, and so on. This is predisposed mainly by approach using in primary repair. Using of transannular patch leads to impairment of the RV function due to progressive pulmonary valve regurgitation. Especially in small patients that also have long postoperative period with heart failure signs. Sparing of the pulmonary valve annulus and also RV infundibulum structures provides a significant improvement in systolic and diastolic function of the right ventricle in both early and late period. However, preservation of the RV infundibulum structures is much harder in patients under 6 months old, and the risk of residual obstruction of the RVOT is much higher. So in our institution, we perform about 1,000 tetralogy repair from 2008 to this year, and in this analysis I include 859 infants. It's all patients below 3 years old, and I divide it in 2 groups. First group is transannular patch, is about 415 patients, and the another one is pulmonary valve sparing approach with preservation of pulmonary valve annulus. In the first group, monocusp was implanted in 23% of patients. We excluded such patients that require conduit implantation, that underwent RVOT stenting in neonate period, and also those patients who had pulmonary valve atresia or absent pulmonary valve syndrome. In the second group, when we preserve pulmonary valve annulus, we use the following approach. The mainly one was transatrial transpulmonary approach without incision on the infundibulum, but 20% of patients required RVOT patch with saving of the pulmonary valve annulus, and 21% of patients underwent mini TAP with augmentation of the pulmonary valve annulus. Here's a little table of the baseline characteristics of the patients, and you can see here that the only difference is the Z-score of the pulmonary valve annulus. And this in the group of the transannular patching, the median Z-score was -3, with range from -2 to -4. And in the pulmonary valve preservation group, it was the median was -1.7. The median age of the primary repair was equal in the both group, about 15 months old in the pulmonary valve sparing, and in the TAP group 13 months. Early mortality was 2.1%. It is about 18 patients. All of them were in TAP group. However, the pulmonary valve preservation group patients had more higher postoperative gradient. The median RVOT gradient was in this group 26 millimeters. and the ratio between pressure of the right ventricle and left ventricle more than 50% was higher in the pulmonary valve preservation group. But the inotropic support time, the cross-clamping time, the CPB time was gradually lower in the pulmonary valve preservation group. And also these patients had no significant tricuspid valve insufficiency in the post-operative period. And subsequently, the length of stay of this patient was significantly lower, and the median was 10 days. Signs of early heart failure were progressively increased in the first hours after surgery in the TAP group. However, in the next days, all hemodynamic parameters recovered and did not significantly differ from the PVP group. Made in a logistic regression, we found the two only factors that was predisposed to early mortality. It were cross-clamping time more than 60 minutes and Magoon ratio lower than 1.2. In the late outcome, we have not so big follow-up. The median was 56 months. And I decided to put here our sub-analysis from another work, but I think it is important. 160 patients underwent MRI assessment of RV function postoperatively, equal 80 patients from each group. In the pulmonary valve preservation group, the median age of the patient during follow-up was 60 months. In the TAP group, 72 months. We have no late death, but 13 patients were reoperated due to residual VSD, 3 patients, RVOT reobstruction, 8 patients, and we have 2 patients with heart block who required pacemaker implantation. And also 37 patients underwent redo-cath lab interventions during late postoperative period. In the transannular patching group, freedom from open surgery was 97%, and in the PVP group it was much higher, but without any significant difference. Freedom from the cath reinterventions was lower in both groups, but also without any statistical difference. We consider that RV to LV pressure more than 60% was the only risk factor for catheter-based reinterventions. And from those 37 patients who underwent catheter-based reinterventions, balloon valvuloplasty and dilation of the main pulmonary artery was performed in 22 patients from the pulmonary valve preservation group and in 15 patients in TAP group. These are our results. Just briefly about MRI function of those 160 patients we received in the late postoperative period, and we seen that non-affected RV diastolic function occurred more often after repair without ventriculotomy when we used transatrial transpulmonary approach compared with other types of PVP strategies, and more often than after transannular patch. A restrictive type of the RV dysfunction was observed predominantly after strategies with ventriculotomy, and the ejection fraction of the whole RV and its various parts was significantly higher in the PVP group, while indexed end diastolic volume and stroke volume were higher in the TAP group. The majority of patients who had underwent PVP had pulmonary regurgitant area index lower than 10 millimeters squared per meter squared, while in the TAP group it was significantly higher. The area of pulmonary regurg
was 36.7% in the TAP group, compared with 13.2% in the PVP group. So we conclude that pulmonary valve preservation leads to improvement of the both systolic and diastolic RV function. Use of the pulmonary valve sparing strategies significantly improves the hemodynamic results not only in the early postoperative period, but also achieves excellent results in the late postoperative period. We found also that those patients who received monocasp valve did not influence the grade of the pulmonary regurg in the late follow-up. Thank you for your attention. It's a great pleasure to be here.
Any question? Yes.
Very interesting and a huge series, but I want to point out that in your first table, where you compare the two groups, 400 for each, you mentioned this is the only difference between the two groups,
yep,
which is the pulmonary valve size annulus. I want to point out that that is the key difference between the two groups. So somehow I can presume that you're comparing oranges with apples. And your conclusions are trying to imply that preserving the pulmonary valve is better. As I mentioned in our work, I think that when you're comparing a Z-1 with a C-3, that's a different subset of patients. So I would be reluctant to that conclusion, although it's a large series and very interesting. So congratulations.
Thank you for your comments.
Well, again, congratulations for your talk. You started with a sentence saying that the preservation of the pulmonary infundibulum is much more difficult before 6 months of life. And for most of the institutions, including mine, is the opposite. It's much more difficult after 6 months of life. So what are the causes that made you make such a statement that is much more difficult in the first 6 months of life?
Yeah, thank you for a comment. So for our experience, when we operated on patients who 3 or 5 months old, for example, the annulus of these children is very small. And when we try to preserve the valve and then measure the RV pressure after CBP, so we have very high pressure. And this is not dynamic obstruction, but only the annulus restriction. And so we just need to incise the annulus to receive the optimal results.
Yeah,
it's just for our experience.
No, I think I understood. In other words, in the first 6 months of life, you just operate on the critical patients and the more severe form of tetralogical follow, and therefore, for this reason, it's much more difficult.
Yeah,
but in
yeah.
case you operate all of them, you might find it much easier.
Yeah.
Okay.
Well, I was glad to see that he quoted your paper, Giovanni, for their valve sparing technique. So that was good cross-country collaboration. Well, thank you very much. That's an excellent series. Thank you. All right, our final abstract, we're switching gears a little bit here. And Dr. Shivang Saxena from India will be presenting the outcome of total correction of isolated total anomalous pulmonary venous return, a retrospective study. Dr. Saxena, thank you. And we need our slides changed, of course. While he's getting that ready, I just want to thank everyone for your comments. I think actually many of us have learned a lot from these different presentations and the very active discussion. So thank you for participating.
A very good afternoon to all. I'm Wspchs from India, and I'll be presenting a retrospective study on the outcome of total correction of isolated TAPVCs. So, slide has gone wrong. Yes, this study is a retrospective analysis which was conducted between the time frame of 2008 to 2018. We included all the patients with isolated TAPVCs with or without ASDs and PDA, and all other variants were excluded from the study. We included the risk factors, the pre-operative, intraoperative, and the post-operative risk factors, and tried to correlate them with the early and the late post-operative outcomes. Coming to the variable studies, the important pre-operative variables which we took in the study were the age, the weight of the patient at the time of surgery, whether the patient presented with an obstructed or unobstructed form of TAPVC, the type of TAPVC, and what was the pH of the patient before the surgery, whether he was acidotic or not. Intra-op variables, we took the clamp time, the bypass time, the temperature at which the surgery was conducted, or whether the patient required circulatory arrest, the type of surgery performed, and the post-operative PA pressures. In the post-operative period, we have measured the vasoactive inotropic score at the 24-hour period post-operatively, the number of ICU days spent, whether the patient had any form of PA crisis, arrhythmia, pulmonary hemorrhage, or early or late mortalities with requirement of any re-intervention. So there were 242 patients in a study with a gender ratio of 1.6:1 amongst males to female. The important part was the patients weighing less than 3 kg were 50, which comprised of 20.7% patients. Most common TAPVC which we faced was supracardiac TAPVC, which was 52.5% of the patients. Around 86 patients, that is 35.5% of the patients, had preoperative acidosis with pH less than 7.35. And around 111 patient, 45.8% of a patient, had preoperative pulmonary venous obstruction, with infracardiac having 100% obstruction. So we have seen previous studies, and we have compared our current study with the previous studies. This is the slide showing the mean weight, and we have seen that with comparing to the previous studies, we had almost the same weight, around 4.67 median in kgs. Preoperative pulmonary venous obstruction in our study, we had around 45.8% patient, which was almost comparable to the previously published studies. Technique-wise, in our institute, at around 2015, we changed to sutureless technique with a mindset that it causes less re-interventions with less chances of pulmonary vein restenosis. So we had around 111 patients operated by sutureless technique, and the rest they underwent conventional repair. We compared the sutureless repair with the conventional repair, and almost everything was similar statistically. The number of mortalities in sutureless were 5 compared to conventional 15, but there was no statistical significance there, and the re-interventions were almost same. So to conclude with the repair, what we did was there was no significant difference between the two kinds of strategies, the conventional and the sutureless repair, when it comes to the post-operative outcome. Patients were followed up after the surgery for 5 years and 10 years, and we have seen that there were 7 patients who had turbulent flow. 4 belonged to the conventional group, and 3 belonged to the sutureless repair group, and all these patients are still in medical follow-up. So we try to establish the relationship between the age, temperature, and the weight of the patient to the intraoperative and other post-operative variables. Coming to the age, the neonatal patient had significantly high bypass time. The vasoactive inotropic score and the number of ICU days were significantly high in the neonates compared to the infants and the children. And this is the Kaplan-Meier curve showing, though there was an increased early hazard in the neonatal group, there was no effect on the long-term survival of the patient when it comes to the age at which the patient was operated. This is a scatter plot diagram showing the correlation between the temperature and the inotropic score. There was no correlation as such, but when it comes to the weight, there was a significant correlation with the vasoactive inotropic score at the 24-hour period and the number of ICU days. Similarly, though all the patients weighing less than 3 kg, they had an increased early hazard in the early post-operative period. There was no effect of the weight on the long-term survival of the patients. Coming to the complications, we had patients with arrhythmias. There were 3.7% of the patients. 7 patients underwent reoperation, which was around 2.9%, and 1 patient in our study had pulmonary hemorrhage. So the most common arrhythmias were atrial arrhythmias, and in long-term follow-up, 3 patients still have persistent arrhythmias. 2 patients underwent Schumacher repair, and 1 patient underwent Warden's repair. Out of those 3 patients, 1 had intermittent junctional rhythm. 1 patient has a intermediate right bundle branch block with atrial ectopics, and the other one has atrial flutter. All these patients are being managed medically. The 1 patient who had pulmonary hemorrhage, that was in the early post-operative period, and that patient died at 29th day of life. Coming to the mortalities and reintervention, we had 242 patients. Out of that, we had 20 mortalities, and 222 are still alive. Out of those 20 mortalities, there were 18 early mortalities and 2 late mortalities. For the reintervention, out of the 18 early mortality patients, 2 had reinterventions. 1 patient had obstructed cardiac TAPVC and 1 patient had obstructed supracardiac TAPVC. And out of those alive, the 222 patients, 5 had reinterventions. So coming to the anatomical type, for the mortality, 8 patients with supracardiac, 8 patients with cardiac type, 4 in infracardiac, and there were no mortalities in the mixed type. Out of the 18 early mortalities, in the 20 mortalities, all patients belong to the neonatal and the infant group. And most common cause of death in that group was sepsis and PA crisis. Most of these mortalities which we faced were in the period when we didn't have sildenafil infusion or nitric oxide availability in the ICU. So comparing our current study mortality with the previous mortalities, we had 9% mortalities, which was comparable or even less to many studies published earlier. Coming to the reinterventions, out of the 7 patients who underwent reintervention, 3 were for the sutureless repair and 4 patients from the conventional repair. The common thing amongst all the patients was they all had preoperative obstructive anatomy. So there was a reintervention rate of 2.8%, and it was comparable or slightly less compared to the previously published studies for isolated TAPVC. Thus, to conclude, pulmonary venous obstruction is the single and the most important preoperative variable which affects the early as well as late outcome of the patient. Weight less than 3 kg is a risk factor for the immediate post-operative period, but it didn't have any effect on the long-term survival. And the primary sutureless technique provides no additional benefit over the conventional technique in both early and late outcome. Thank you.
That was a very nice presentation. Another excellent high volume group from your study. How many people here are using primary sutureless as their most common strategy for total anomalous pulmonary venous connection? Not very many. Interesting. There's a lot of papers comparing the use of sutureless technique versus standard technique. Dr. John, you have a question.
I was going to ask exactly the same question, although I was the first author on the publication from Sick Kids on the first sutureless repair. And I don't do that on primary sutureless repairs ever unless you have a problem or you have a redo. So I think it's, and I'm glad you asked that question. Nobody is using it primarily. So I think the use of sutureless repair is probably more on those 2 or 3% patients that you had to operate on. These will help you out because these are the ones who have intimal hyperplasia, they have active pulmonary veins, and these are the sutureless ones will help as opposed to doing it primarily in the first operation. Thank you.
Yeah, there's still in the literature, there's, people that are espousing primary sutureless repair. So thank you for your comment, honey.
Just a question, and I might have missed it though. The postoperative pulmonary venous stenosis, which in a lot of studies are almost 25% is probably the worst thing. Did you talk about that at all? I think I missed that.
Yes, sir. The patient were followed up by echocardiography.
Right.
And we had 7 patients with turbulence, but they are still being managed medically. They had mild pulmonary venous turbulence.
So you've had no patients you've had to reoperate on for
7 were re-intervened. So there were 7 patients with re-intervention. Out of those, 3 patients had, 5 patients were in the late period, and 2 patients were in the early postoperative period where 2 mortalities happened. So,
Those are remarkable results.
A quick question. Do you use, for your anastomosis, do you use proline or absorbable
Proline,
suture? Proline. Okay. All right. Any other questions? Christo, do you want to make a comment? Oh, okay, fine. Session is finished. The only comment I want to make is the incoming editor-in-chief of the World Journal. These were all very good abstracts, and I encourage everyone to submit their content to the World Journal. So thank you. Oh, good. Perfect. Thank you, Christo. All right. Do you want a microphone? There you go.
Yeah. Okay. Yeah, I can go there. Thank you, Carl. So just before the break, I want to tell you that there is a walk-in visit of the posters. They are right here in the corridor, and we will be very happy that you have some time to go and visit the posters. Second point, at 5 p.m. after the break and the walk-in visit poster, the editorial board meeting is held in this room from 5 to 7. And after that, at 7:30, there is welcome reception in the bar lounge, the same level of the swimming pool. I think there are some signalization to reach that. And after that, there is a dinner in the same restaurant. We have lunch this midday. Okay, Crystal, good? Last thing, excuse me, last thing, there will be at 9:30 in this room, the annual business meeting of African Society of Pediatric Congenital Heart Surgery.
University for Pediatric and Congenital Heart Surgery is that every healthcare professional anywhere in the world involved in the care of patients with pediatric and congenital heart disease should have access to ongoing education. Education, communication, mentoring, knowledge everywhere and for all. Imagine being part of it. Worldwide, each year, 1.4 million children are born with congenital heart defects, and over 350,000 children acquire heart disease. You are taking care of them. The vision of the World University for Pediatric and Congenital Heart Surgery is that every healthcare professional anywhere in the world involved in the care of patients with pediatric and congenital heart disease should have access to ongoing education. Education, communication, mentoring, knowledge everywhere and for all. Imagine being part of it. heart disease,